I declare open this public hearing of the Standing Committee on Health, Aged Care and Disabilities inquiry into the Thriving Kids initiative. I'd like to acknowledge the traditional custodians of the lands from which we meet today and pay my respects to their ancestors and elders past, present and emerging. I extend this respect to all Aboriginal and Torres Strait Islander peoples and their cultural and spiritual connections to Australia's lands and waters. In accordance with the Committee's resolution of the 21st of August 2025, this hearing will be broadcast on the Parliament's website and the proof and official transcripts of proceedings will be published on the inquiry website. I remind members of the media of the need to fairly and accurately report the proceedings of the Committee. I remind all public officials and stakeholders who are present before us in ensuring the safety of children during these proceedings. This includes avoiding the use of names or identifying details when referring to children, ensuring that any discussion involving children is respectful, appropriate and consistent with our shared responsibility to maintain a safe environment. And I also would suggest that no photographs of children should be displayed in the committee hearings. I will invite the members of the committee to introduce themselves.
My name's Alice Jordan-Baird. I'm the member for Gorton, representing Melbourne's western suburbs.
Ms Stanley.
Anne Stanley. I am the member for Werriwa in South West Sydney.
And I'm Mike Freelander, the chair of the committee and member for Macarthur in South Western Sydney. I'd now like to invite representatives of the Australian Primary Principals Association, the Australian Special Education Principals Association to give evidence today. And I'd also like to thank you very much for coming today and giving us your time. I know it's a very busy time of year for school officers and principals, so really appreciated the fact that you've been able to give us some time today. And would one of you or two of you like to make a brief opening statement of no more than 5 minutes?
Yes, I would. Matthew Johnson, President of the Australian Special Education Principals Association. Thriving Kids really needs to be a preventative, equity-building system, not another crisis response that leaves schools absorbing responsibilities that they were never resourced for. And we can't continue as schools to be as the universal catch-all. Thriving Kids must strengthen the health and community service system around children so schools can focus on education. When other systems fail, the child still shows up at school and principals carry the risk. Schools are becoming the de facto disability service system through crisis, not design. Thank you.
Good. I should also mention Sam Birrell. Would you like to announce yourself? And having trouble unmuting yourself.
Sorry. Thanks, Chair. Yes, Sam Birrell, member for Nichols and Shadow Assistant Minister for Regional Health.
Thanks, Sam. And I should also mention we have Mr Pat Murphy, the Australian Government Primary Principals Association President, and Ms Angela Falkenberg, President of the Australian Primary Principals Association. Would either of you two like to make an opening statement?
Yeah, look, thank you. APA is the voice for more than 7,600 primary school leaders across all sectors, and primary schools are where every child comes together and where the early signs of developmental delay, disability, trauma or family complexity are first noticed. Principals see the daily consequences of fragmented systems, families navigating multiple doors, long waits, duplicated assessments and falling between agencies. So schools, and as Mr Johnson has referred to, become the default coordinator of services despite limited administrative staffing and severe workforce shortages. The goodwill of educators fills the gaps, but that goodwill is now exhausted. So we strongly support a national integrated approach to early identification and early support, but Thriving Kids must not unintentionally shift even more responsibility onto schools or onto classroom time. And we're concerned that place-based support, which should mean co-located services on school sites, is seen as support delivered in classrooms during essential teaching time. The classroom is for learning. The Australian curriculum is every child's entitlement, and children should never have to choose between maths and therapy or other support. Full service schooling is not about educators becoming allied health workers. It is about having the right expertise in the right place and ensuring families are part of the process.
Thank you. Mr Murphy.
Thank you, Mr Chair, and thank you, Committee, for the opportunity to present on behalf of the 7,000 government primary school leaders. And my colleague Angela said 7,600. That's 7,600 principals. We represent principals and deputy principals in the government sector in 5,300 government schools across the country. Our purpose is ensuring every child thrives in an Australian government primary school, and that early identification and early intervention remains central to this goal. Parents need simple, accessible, cultural responsible tools to recognise early development delays. Schools frequently become the first point of concern and also, in many cases, the first contact, yet the resources for parent engagement vary greatly across our communities. We're asked for the support the development of a nationally consistent evidence-based screening information. At the moment, that doesn't exist, and we want that co-designed with educators, but also beyond educators with paediatric experts and families. We want to advocate for universal access to parent-friendly resources and translatable materials for families from multicultural backgrounds. Apologies there. Schools see inconsistencies between jurisdictions in early childhood screening and referral pathways. Many children enter prep or kindergarten without prior assessment or with significant delays, and they're unrecognised. We call for strengthened child mental health checks with clearer links to school, enhanced collaboration between primary care and allied health in education setting, and improved data sharing protocols to support continuity of care while maintaining privacy. Early childhood educators and primary principals report gaps between identified and timely follow-up services, especially in rural and low SES communities. First Nations children and children in remote disadvantaged communities face the highest barriers. The need for culturally informed assessment tools and outreach delivered in partnership with community organisation is essential. Schools require dedicated funding to employ cultural liaison officers and community connections to ensure families engage early and confidently and continually. We obviously have workforce support and training and issues across the country. We've got significant shortages in teachers, in other school staff, but also in allied health, child development specialists and inclusion staff. There are long waiting lists for assessment in some regions. We need for a sustained investment in workforce pipelines for speech pathology, occupational therapy, psychology and specialist teachers. We want professional learning for our school staff to recognise early signs of developmental delay and stable on-site allied health partnerships embedded within school communities. We want to make sure that this is a reflection on domestic and international best practice. International models show success where early childhood and health education operate as integrated systems. Where we invest early, we reap long-term rewards. Good. Key features of universal, we believe, work are universal early screening at ages 3, 4 and school entry, co-location, and this is in the APA submission as well, of health and early intervention professionals in school, and strong investment in family support and parent coaching models. We want seamless transitions through mainstream systems. Many families feel lost navigating fragmented systems. Schools often carry the burden of coordinating this. A single national consistent referral pathway for early childhood to school age is essential. A case management model for children with mild to moderate needs, ensuring consistency across health, early childhood and school settings. Improved data transfer from early childhood schools in early childhood centres into schools is also absolutely essential for student success. And this is piecemeal at best in certain communities and certain areas. So in closing, AGPA strongly supports the Thriving Kids initiative. Every child, regardless of the background or postcode, needs to receive early, timely and appropriate support. Schools cannot do this alone. Coordination across health, allied health and community and early childhood sectors is essential. We urge the committee to prioritise equity, early intervention and integrated service delivery so that children have a fair opportunity to thrive.
Thank you very much. I should also note we have online appearing Monique Ryan and Sophie Scomps. Would you two like to announce yourselves to the committee? Monique? You're muted.
I might start. Can you hear me, Mike?
Yes, can hear you well, Sophie.
Dr. Sophie Scomps, member for Mackellar on the Northern Beaches of Sydney. Good morning.
Morning. And Monique Ryan, member for Kooyong, is here as well. Look, we might open up to questions. Thank you very much for your submissions, but Alice, would you like to?
Yes, thank you, Chair. Thank you so much for appearing before our committee today. It's great to have you here. Obviously, primary schools play a really important role in that early identification and support for children with developmental delays. So it's really great to have your expertise in the room. My first question is just for Ms. Falkenberg. Just around your submission, you mentioned the early support brokerage packages as a sort of recommendation. I was wondering if you could elaborate on what you'd like to see in that and what would be included in something like that.
Well, certainly the idea of a national screening tool is the first step. And what happens after that can be problematic for families, particularly those who are vulnerable. So having someone to walk with them, but also checking the currency of available services. One of the challenges, particularly for low socioeconomic communities, is supports can be short-term. You know, the funding can be 1 year, 2 years. So when you're working with families and trying to connect them, it's really problematic to stay up to date with what's happening. So having, you know, in essence, determining what the support is, where it actually is available and how to access it. And I say access deliberately because for some of these supports, they are complex to access without a car. Public transport. It's why APA has been advocating for place-based services. If you can walk to school, you can get to the service. You know, and across Australia, a primary school is in literally every community. So, determining what the support is, how much is available for the support. Is it 8 sessions, 10 sessions, or so on, or whatever it is? Is it connecting to a dad's play group? You know, what would it take to build the capability of the family to support the child, not just an external service? But I think for many of them, they need the package and they need someone to walk with them. Because when, you know, as a parent, when you become aware that the child may not be meeting a milestone, there's some grief that's attached to it. And for some families, there can even be shame. And so a kindly, you know, I use the word kindly, but someone to walk with them, to keep them connected, but to let them know that kids, milestones are like this. You know, there's no single point where we ever give up on a child. But because the child's dependent on the family, we need to wrap the support around the family.
And in terms just building on that, you mentioned sort of building capability of the family and that sort of role that you mentioned to sort of support them through that. Is that where you see the family navigator role to help build that capability of the family, particularly pertinent to cold communities as well, where you mentioned the sort of stigma earlier?
Yeah, so it's not just navigating the space, but when I think about building family capability, often when the support is at school in school time, that's exclusive of families. So the child might be getting some gross motor skill support, but how's the connection with family work? It's left to the teacher. But I think the navigator role is key also in keeping the family present for the support. And that's why, we've always wondered why, support services aren't open till 7 at night or on Saturdays. Why we think that the school day is the only option, because when we do that, we exclude parents and we don't build their capability.
Are you aware of those navigator roles existing already, or is that something you would have to look at?
So I did have a children's centre, a birth to 7 school. I had a community development officer, and they, unintentionally became that role because they were a trusted person who the family could go back to. Yes, there were supports on site, but sometimes if it was an appointment to a children's hospital, for example, there was even that sense of, so what bus are you going to get, or what buses, how would you get there, what do you need to know? So that navigator role was, in teaching me about foregrounding, thinking through all the things you need to know before you do something. And that community development officer role became a really important part to kind of prime families for what might be coming. And then after an appointment, to have a bit of a debrief about what it might mean.
Sure, thank you for that. My final question, Chair, if that's okay, is just for Mr. Murphy. In your submission, there's a recommendation to implement a sort of triage structure to better inform parents of learning options for their children. Would you mind elaborating on what you mean by that and what you'd like to see in that space? Sorry, Mr. Murphy, I think you're on mute.
Yes. Thank you. Apologies there. It's very similar to what Angela is talking about, that the navigator would come in early, but it's then as they're going through a schooling system, in some cases, some of the school staff do not know necessarily where the best options are because, for instance, someone might be transferred as a principal. A lot of teachers get transferred to Longrange, to Cloncurry, to Broken Hill. They're not actually locals in those areas, so it takes them a period of time to actually make those connections. So if you had someone local in those areas through the school, one of the things that we do know, and Matt, Angela and myself have all worked in primary schools and high schools, and we actually fund some of these positions more in high schools than we do in primary and pre-primary. And we seem to get it a little bit the wrong way around. We would love them still more at secondary. We don't want them taken out of secondary schools, but what we're saying for in primary schools and special schools is probably when we're actually needing those supports and families need those support. We know early intervention actually works, and in those countries where they do intervene early, they get fantastic results. But leaving the intervention to later, the navigation to later, actually creates difficulties down the track.
Thank you all. Thank you, Chair.
Ms Stanley, are you online? No. Monique, would you like to ask some questions?
Yes, thank you, Chair. Sorry about my technical issues earlier on. Thank you both for your time this morning. I'm really interested in the comment about schools, not only being available to the public between 9 and 3:30. It's always been something I've always wondered about, why we don't have hospital clinics on Saturdays and in the evenings as well. Do you see any issues with clinicians or support services potentially coming into schools at 3:30 in the afternoon and using those facilities for 2 or 3 hours after school or on the weekends, or any ways that we could provide additional support to schools to facilitate that process?
Could I answer that one, please, Chair? From the special schools...
Could you announce your name when answering before?
Matthew Johnson, President CEO of the Australian Special Education Principals Association.
Thanks.
With our special schools, a lot of those facilities are used on weekends by parents and families because it's a secure environment where the children can be safe, and these are the students with the most complex needs. The parents know the school environment. The children know the school environment, they know their play spaces, they know their rooms. And so it is a really fantastic use of a government facility within the weekends. We also, within our special schools and within our primary schools and high schools, we've got a lot of teachers' aides or school learning support officers who usually supplement their income by being transport officers in the morning, so they might be on the buses that help our students get to our schools, but they also might be the respite care people on the weekends. So some of them are actually working 7 days a week. But if you could extend that school day, you've actually got a workforce there who would be willing to extend that day for additional income and be able to have that facility open for all of the specialists to come in. The challenge, as Angela mentioned before, is that our primacy and our legislation in each of our states makes education of students and the delivery of the curriculum paramount. And if we throw away all of that time, then that compromises the core business of what we do and staying in our lane of education. And at the same time, though, most of my students will have 2 to 3 specialists working with them because of the complexity of their needs. And if I've got 150 students in my school, like I did previously, that's 300 allied health professionals who want to have access to the school at any one time. And it's just unsustainable. Our facilities aren't built for it. So extending the school hours, being able to use the facility on weekends is a great move. And considering all of my 150 only go to 2 paediatricians in the first place, the entire cohort's there rather than, coming to the mountain. All those services could come to the school, but not in that educational time.
Can I just ask where your school was?
Newcastle Special School, and so it was a community of special schools, junior, middle and secondary. Senior.
Thanks.
Can I also...
Sorry, please. Go on.
Sorry, Angela Falkenberg. I think, anything can happen with the will, and some interface guidelines, MOUs around spaces, responsibilities, etc. One of the challenges for many primary schools, though, is a lack of space. So we've never been set up, our standard or our footprint has never included sort of specialist spaces. But there are some that absolutely have spare space that could be used. I think, in the time pressure of families, and I know there was a report recently about families who would like to access after-school support, but the pressures of work mean they can't. I do think later in the day and Saturdays presents a whole lot of options. And I also think OSH, out-of-school hours care, could be looked at to provide the duty of care. It's another fascination for us that only a teacher can hold duty of care between 9 and 3. But after school, non-teachers can have duty of care, so maybe that could be looked at as well.
Thanks.
Yeah. And do you think, I'm interested, presumably we're building new schools around Australia, and it would make sense that sort of consideration should inform the design of those new schools, where they're sited, I guess, firstly, but also the spaces and the facilities that any new school that's built in Australia should take into account.
Matthew Johnson again here. The challenge is that it's the staffing formula in each state and territory that dictates what your facilities have. So if you've got a principal, you've got a deputy, you've got APs, assistant principals, you've got teachers, you've got SLSOs, they will build to your staffing entitlement. And since we don't, in New South Wales, for example, in my system, since we don't have allied health as part of that entitlement, those allied health rooms aren't there. There might be a multi-use room, but nothing dedicated.
Yeah. Could I come in there at Murphy from Australian Government Primary Principals just to say, I think it's about what all three of us are proposing really is that state, federal, but also various departments lend in to actually create this, because normally it's the state education authorities building the schools, and they sort of say, well, why would we build something for health? Why would we build something for allied health? Our job is to build something for schools for students. Our job is education. So if we're going to expand this, we actually need everyone to be in the room working together on this.
Right, agreed. Thank you. That's really interesting. Thanks, Chair.
Good. Mr. Birrell, any questions?
No questions. Thank you, Chair.
Dr. Scomps?
Thank you. Thank you very much for the presentation. My question was to all or any of the witnesses, thank you, just about your view on the Department of Education's Inclusion Support Program, if you have a view on that, how the effectiveness of embedding inclusive practices into schools.
I can mention this one, Matthew Johnson again. Look, inclusion is a really, really loaded word. From the Australian Special Education Principals Association, we believe that inclusion isn't a place and that inclusive practice can certainly happen across settings. Within our specialist schools, we take the most complex students, and sometimes our special schools are called segregated, and that's just not what we are. We're actually the most inclusive. When you look at specialisations, we value that in our health services. If our general practitioner can't meet our needs, we seek that specialist support. And it's the same with our special schools. We're just part of a suite, right from selective high schools, faith-based schools, the full range, gifted and talented programs, English second language support classes. But sometimes our special schools are isolated as being segregated when we're actually just specialised. So when it comes to inclusive practice, the need is for teachers to be able to have more than just a one semester Disability 101 course within initial teacher education. That's good for the general teacher, but for a mainstream primary teacher and high school teacher to generalise to individualise, make adjustments for so many students is a really huge challenge. Within our special schools, we have lower ratios, which makes that a lot more achievable. And our parents value us highly because of that individualisation and specialisation. So it's really not starting with a system or an ideology of what inclusion should be, it's what does that child need? And one of the challenges too is that early identification without early support is just early labelling. And we see a lot of families come to our schools who've had no intervention whatsoever, and they don't know what's out there, they don't know the full suite of educational opportunity. So inclusive practice is a really challenging space. What does it look like? What does it mean?
Thank you.
Okay. To answer that from the Australian government perspective, can I first say one of the things I think we should celebrate in this country is that all schooling sectors in primary school actually do inclusion exceptionally well. And we take the students that we probably didn't take 30 years ago in our schools, and they are included. So Matt talked about high disability students there going to special schools, but 88% of students with disabilities actually come to government primary schools across the country. So we believe right from the start we're inclusive. Now, as Matt said, what does inclusion look like? Inclusion can be full inclusion into the classroom, but for some students that's not perfect. That is, and we've got some students who have sensory overload. So putting them in a classroom for 6 hours a day, every day, actually can turn them off their learning. So how do we work with every student to meet their needs at their level to deliver the best outcome for that student, but also for all students in the school? And inclusion shouldn't be at the inclusion of that student and the exclusion of other students, or the exclusion of that student. It's about meeting students at their needs to deliver the best outcome across the system. But I think there's also, we really need to celebrate teaching and how far teaching has come and how far our schooling sectors have come in terms of inclusion in this country, up against other countries and even where we were 30 years ago. We have grown. And it's probably the area, as Matt identified, we haven't spent significant parts of training for our workforce. And that would be an area that we would see needing significant work for all teachers, but also there are very few special educating courses across the country that exist. I think there's one university, Matt?
Yeah, pretty much.
Good. Thanks.
Can I please add, Angela Falkenberg, You know, the AEDC data, Australian Early Developmental Census, is telling us about particular cohorts and geographies where there are more students requiring adjustments. So we talk about perhaps level 1, 2 or 3. Level 1's universal, what we do for all children. Level 2 is that adjustment piece where within a classroom a teacher, in understanding a child's language needs, might adjust questioning from what we call concrete to abstract. They might be having instructions read to them while they're still mastering the art of reading and comprehension. But we know that across Australia, approximately 1 in 5 children, even 1 in 4, are needing that level 2 adjustment. But that means in some schools it's 75%, it's 3 in 4. And that's the challenge for teachers in particular cohorts, is to provide that level 2 adjustments for everybody. It's almost a personalised program. Yeah. And that is contributing to the workforce challenge that in some schools it is really, really hard work. They do it willingly. You know, Pat's referenced how, you know, committed our teachers are. But I also wonder, you know, at what point does it become unreasonable? And I don't mean an unreasonable adjustment, but the workload for teachers is so complex in some places that it does contribute to burnout. Well,
that's one of the problems. We know which cohorts are most at risk. We know the high levels of need are in certain areas, and so one size doesn't fit all with teacher staffing levels and training levels, and that's a real problem. Because what happens in Mosman in Sydney is totally different to what happens in West Wyalong or Burke or other places. We might move on to Ali France. You've got some questions? Ali? All right, well, I might, in the meantime, we'll wait for Ali to get online. Can we... I've just got a few questions around really how we work on this lack of integration that we seem to have, and there is a big problem, it seems to me, in that transition from early childhood into school, and whether there is room, provided it was funded, I'll underline, to have schools more involved in screening for kids before they get to school and triaging where they would be best placed. For example, have a school counsellor do a developmental assessment on a 4-year-old before they start school in the year after. Do any of you see a role for that?
So Angela Falkenberg, I work closely with preschool colleagues. So in some states and jurisdictions you have a school-based preschool. In some they're standalone. Yep. The funding is needed because if you are off the floor doing an assessment, you're not meeting standards, so it would need to be funded. I think anything's possible if we resource it. That's my short version. I think it's possible if the funding, if the time to do it is resourced, but then you have a system engagement or needed to ensure that there are options for the child, because if it's not a standard classroom, what's available will depend on what the system's willing to support.
But you do see a role for it?
I think it's possible. Again, it's a HR issue. If I'm assessing the child, who's doing the work and ensuring that the learning program continues.
Good. Matthew Johnson from the Australian Special Education Principals Association again. One of the challenges, I think it is worthy, one of the challenges that we have across systems is with a lot of disabilities, they won't be identified at age 4. People will be waiting and taking on more information and waiting to see what happens and what things look like. But with our guidance staff, our school counsellors, school psychologists within schools, a lot of them, that's been streamlined in New South Wales recently because there used to be disability confirmations that you'd be aware that would have to be updated. And any of the proactive work that our psychologists in our schools would like to do is taken up with re-identifying known disabilities that, you know, unfortunately, in the brutal honest truth, are not going to improve. They're a lifelong disability. But to being able to have that early identification is good, but we're really struggling just to get counsellors within the school to do the work that's already there. Yeah. Having that navigator beforehand that would have be there. But I mean, with the students that my special schools cater for, they are really usually well identified beforehand, except for communities of culturally and linguistically different backgrounds, because they will shy away from that lens being cast on them. They won't know how to access, and we end up with a sort of two-tier system with the parents who can navigate and advocate for their child and get support and get NDIS packages, and those who can't. And so I think Thriving Kids needs to really have, as you suggest, that kind of early identification, that person, but it's how do we get that person to it and get the information then to the school. Yeah, we are very interested in that, and one of the other workforce strengthening that we think could help would be strengthening the child and family nurse engagements, as well as sort of a soft screening. Agreed. And I mean, there are other things we should be doing as well. I think this business of having to go and see the nurse, then see the GP, then get a referral to see a paediatrician, which you either can't afford or have to wait 3 or 4 years for, needs to be changed. One of the other challenges too, looking at, and there's the current review of the Disability Discrimination Act and the Disability Standards for Education. And within that, one of the things that I think every setting, Pat's, Angela's and mine, would like is the time to be able to actually do the Disability Standards for Education recommendations around enrolment, because I don't think schools do it well, not through not wanting to, but it's to have the time and the resources to do it. The resources to do it, to be able to consult, genuinely share relevant information, explore reasonable adjustments, document the consultation. So you're getting enrolment right and seeing what that student needs, but that takes time. And it's usually an assistant principal who only gets 2 hours really from face-to-face a week that's trying to do all of that. Okay, so resourcing is important. That's really paramount.
Can I just come in there too? Probably the other one, you did mention it before, is isolated communities, rural, remote communities, also around a lack of access to any sort of help or very intermittent help in terms of what can take place there. That's a real concern around one of those, putting in place that. I would agree with Matt that yes, it's worthwhile, well and truly, but there are obstacles. It probably needs to come in as a trial first in certain areas and then expand from there.
Yeah, look, just very quickly, I just want to ask, well, there's many other questions I'd like to ask, but one last question, if I can, in the interest of time. Is the private system carrying its load in this space as well?
I don't believe so.
And Pat has referred to the percentage of children with disability that are in government schools. Mm-hmm. And, there has been conversations about perhaps the school up the road is more prepared or more able. And, APA's position is how do we ensure that all schools are confident and capable to take all children?
Mr Murphy, would you like to add anything there?
Look, without calling out anything, I think we, as the government sector across Australia, carry a significant, the larger burden of students with disabilities. And it's not a burden, but it is the bulk of the numbers, as the data says, go to government primary schools, government special schools, and we aren't funded at the level of other agencies. That's a fact. And we, while we think it's fantastic, it's great for our schooling, we do recognise that when we have really high percentages in certain schools, it is a burden on other students because of the time taken. There's a cost implication when those students go on camp. We have to take significant additional children the staff to camps and things like that, which all parents have to pay. But also then there is some parents do leave our system as a result of that because of the unfortunately. So we are concerned across the country around a residualised system in government schools.
Good, thanks. Might move on to Ali. Have you got questions? Ali France?
Hi, Chair. Can you hear me this time?
Yeah, we can hear you.
Oh, great. Thank you. Hi, I'm Ailey France. I'm the member for Dixon. Thank you all for coming today. I've read many submissions to this inquiry from parents and families that say they have been excluded from their local school or that they've had to remove their kids and homeschool them because their needs can't be met. Can you just give a general commentary? I know we've already heard from you, Pat, but I just think there is quite a lot of submissions regarding parents feeling that they don't feel that they have been encouraged to go to the local school or that they have been excluded in general and they've had to find other alternatives. Just if everyone could comment on is it the current system at the moment and what do we need to change to ensure that those parents can send their kids with needs to the school that their brothers and sisters go to? Thank you.
So starting there, Ali, the first thing I would say is that everyone in this country is entitled to an education. So I hope families listening to this and putting in a submission would feel that whatever state and territory you're in, that you can attend your local school, and we welcome children at their local school with whatever complex needs that they may have. It may be that we then start to talk with that family about is this the best place, and in some cases it may well be that they may need to go to a special school if a special school is available. But in general, that would be the parent's choice there. As Angela alluded to, we probably find it's the other way, that some are coming back into our sector saying that the families that those children have not been catered, there is no funding for them in other sectors now. That's not correct. But we welcome those children into our schools. One of the things that we've got to recognise across Australia generally, we have zones or catchment areas. So it is about going to your local school, and sometimes people go, oh, well, I really want to go to that school because I hear they've got a specialist unit or a great teacher for that particular disability. That may not be possible because we do have zonal systems and we can't have people travelling across huge cities or going past numerous schools. So it is about attending, in most states and territories, their local government school.
Thank you. Thank you for that.
Angela Falkenberg. Look, it is always horrible when you hear about children who should have a place at the local school who are made to feel unwelcome. And I think, yes, we certainly can do better in that space. But it is understanding what was being sought. As Pat has mentioned, sometimes quite genuinely that school may not be the best place for a whole lot of reasons. But what we think is important that families have an option to go to for support, that if a school is saying no because they're not capable, then how do we ensure every school is capable and confident to meet the needs of all children? That might be a resourcing issue. If it is about teacher professional learning, how do we fund that, given the incredible competing demands on teacher time, but also with the growing number of diagnoses? How do we keep everybody informed in a way that enables them to still focus on the curriculum. So I think, yes, we can do better. And for those families that have been made to feel unwelcome, I hope that we can certainly make a better system going forward.
Matthew Johnson.
Thank you.
Matthew Johnson here from ASEPA. With our special schools, we accept absolutely every student. There's never been gatekeeping within special schools because that's what we're built for. We're built for the absolute complexity of need. And when you do see exclusion or gatekeeping, as some people call it, occurring, a lot of that again comes back to that navigator, I really believe, because parents aren't aware of the suite of school choices that there are. And if you don't know, you don't know. And the default position in nearly every state is that you absolutely have that right to attend your local school. But at the same time, do you know what else is around? Do you know what other support classes are there? Do you know what other special schools? There's independent special schools as well. There's a whole heap of different services that are happening, but parents simply don't know they're there in a lot of cases. And it will be word of mouth that goes through those parent communities, through their informal network groups that they've already formed well before school. So, and one of the other challenges too is around, again, as that enrolment that you're looking at. Well, if you're getting enrolment right, you're identifying what will be the best place and support for that student. And if you're not, then it becomes guesswork and you get things that don't fit. You get schools that aren't prepared that then might go, oh, geez, we can't cope. And they could have been better prepared and they might have been able to cope.
Thank you. Sam Birrell, did you have any questions? Maybe not. Good. Well, look, we have run out of time, but really appreciate the evidence that you've been able to give us today. We do think it's really important that we do get this right. And we very much appreciate the time that you've given us today. If you've been asked to provide any additional information, could you please forward it to the Secretariat by the 24th of November 2025. You'll be sent a copy of your evidence. We'll have an opportunity to request corrections to transcription errors. And Mr Birrell's just come online. Do you have any questions, Sam?
No, thank you, Chair. I'm going to have to step off for a moment, but I'll seek to rejoin at a later time.
Okay, thanks, Sam.
Thank you.
So you'll be sent a transcript of your evidence. We'll have an opportunity to request corrections to any transcription errors. If there are any questions we haven't asked that you think we should have, could you please let us know? And we thank you also for all the work you do for our kids. And we recognise that the school curriculum now is huge and teachers have an enormous burden of work to get through, and we're keen to try and support you as much as we possibly can. So thank you.
Thank you, Chair.
Thank you.
I now would like to call witnesses from the... once I get the order right, sorry. From Community Therapy and from the Illawarra Disability Alliance to give evidence today. I think they're both groups are appearing online. And for the Hansard record, before giving evidence, would you please state your full names and the capacity in which you appear before the committee? Although the committee doesn't require you to give evidence under oath, I should advise you this hearing is a legal proceeding of the Parliament and therefore has the same standing as proceedings of the respective houses. The giving of false or misleading evidence is a serious matter and may be regarded as a contempt of Parliament. The evidence given today will be recorded by Hansard and attracts parliamentary privilege. I'd now like to invite you to make a brief opening statement of no more than 5 minutes, and to assist with transcription of the public hearing, it'd be appreciated if you could please state your name before responding to each question. I now would like you to make a brief opening statement. Who would like to start?
I'm happy to. Good morning, Chair and committee members. Thank you for inviting us to appear in the opportunity today on the inquiry into the Thriving Kids initiative. I'm Kate Southwood and I'm a paediatric clinical manager at Community Therapy. I'm joined today by my colleague Jordan Maguire, our Head of Clinical Operations. Community Therapy is the largest privately owned mobile allied health provider operating across the Hunter, New England and Central Coast local health districts. We provide speech pathology, occupational therapy and physiotherapy to children and families. Our deep on-the-ground experience gives us a unique perspective on the systemic barriers facing families in regional Australia. Our primary concern for Thriving Kids is that it must meet families where they're at by providing equitable, flexible and sustainable support. We believe the current system fails children because of its profound rigidity. Families struggle to move seamlessly between different systems like health, education and NDIS, which often delays critical intervention. The new initiative has to break these barriers down so that services are on the same page, allowing families to access necessary supports with ease and in a timely manner as their needs change. Our submission outlines 2 foundations for achieving this seamless, equitable system. The first is seamless access via early targeted intervention. The program needs to eliminate financial and diagnostic barriers created by creating a single point of entry that leads directly to early targeted intervention. And this intervention must provide needs-based, time-limited funding independent of a formal diagnosis. And secondly, sustaining the regional workforce. We must fix the current financial model. So we recommend reversing the new NDIS travel caps by implementing a tiered system of travel compensation based on the modified Monash zones. Furthermore, we believe the true cost of maintaining clinical quality, including overheads such as reasonable clinician utilisation levels, as is now built into some public awards, needs to be investigated via an independent review. To inform this process, we recommend the release of the IHACPA report on NDIS pricing to support the Thriving Kids inquiry. We believe that by focusing investment on these system design and workforce solutions, the Parliament can establish an effective, equitable system for all Australian children. Thank you.
Thank you. Mr. Burt, would you like to make any opening statement?
Yes, good morning.
Morning.
Good morning, everybody. Thanks for having me here at the committee. My name's Edward Burt. I'm the Senior Policy Specialist with the Community Industry Group, and I support the Illawarra Disability Alliance, which is a group of 14 not-for-profit providers in the Illawarra, providing early childhood, early intervention services and therapy services and a range of supports. Our submission was made with a focus on, because it's evident that while we have a tremendous amount of expertise and skills across the disability sector that has been supported through the NDIS, early intervention is not functioning as it should in Australia today for our children to identify and target developmental issues early in order to intervene and support children to get the best start in life. And in order for kids to thrive, we need to start at the beginning and understand their support needs well, ensuring the environments they are entering into are inclusive and skilled in catering to meet their diverse needs. One thing that we really focused on in our submission was in relation to developmental checks, screening and assessment. Current screening is inconsistent and relies on informal observations or is delayed until problems become severe. Early childhood educators lack accessible, validated tools to identify concerns early. I'll give a couple of examples that came through from our members in relation to these issues. The case of a family whose child was struggling at school with many concerns raised by educators, and by the second grade, At the age of 8, there were serious concerns about behaviour and cognition, only to discover that there was actually an undetected mild hearing impairment for this young girl that was easily identifiable and screened for, that was really impacting her socially, emotionally and psychologically, and which was seriously impacting on her learning and development. It's an example of a relatively simple issue to pick up and provide appropriate supports for that was missed, putting this young person well behind in learning, social and emotional development for really no good reason. Then there's a case of a family, which we've heard about, who sent their 2.5-year-old daughter to early childhood education and care, only to be told after a couple of days of attendance and this was the quote that I was given, "We are not allowed to say this as we are not clinical specialists, but we think your daughter may be on the spectrum." Thankfully, this family, who also happened to have experience working in the disability field, did not ignore this well-meaning advice and embarked on a 12-month process of a lot of time and personal money invested with paediatric psychiatrists and paediatricians to determine through a battery of 4 or 5 tests, is what I was told, and assessments that indeed their daughter was diagnosed on the autism spectrum. This allowed the family and the early childhood education and care provider to access specialist supports, the Building Blocks program, engaging occupational therapists and speech and physio, to give her the additional teaching and therapy resources to give her the best start in life. Now at the age of 14, she has had ups and downs in the school system and overcome many challenges, but is now receiving and is participating in a mainstream school, though will soon be transitioning to a special school to complete her high school years. This seeming success story is really a result of a tenacious family with the means and living in a location close to services and specialists that meant they were able to implement early intervention services for their daughter, rather than a positive reflection on the system. I have other stories, like the family of a young person with Down syndrome who was almost 6 months old, who was working through NDIS access but had received little to no real guidance from any early intervention specialists, and a little girl with a mild speech disorder, which then had a flow-on effect to her social and psychological development. And that's become quite a severe impairment, and to the point where she is now NDIS eligible, where it could well have been managed and intervened earlier. So there is no consistent developmental check approach to identify and pick up issues for kids in Australia, meaning that many children may be almost 7 years of age, in some instances where well-meaning parents have held their children back from starting kindy, thinking he or she is not yet ready for school, and another 12 months at home would be a good idea, compounding issues by delaying the inevitable and ensuring an even greater shock.
We might just stop you there in the interest of time for questions, if that's okay. Any more or part of your initial statement, you can just forward it by email to the Secretariat, and we'll put that in the minutes. But we might open it up for questions. Monique, Ryan, do you have any questions? Sophie Scomps, any questions? We're having trouble with... Ali France, do you have a question?
I just thank you both for appearing today. I just wanted to say that both your opening statements kind of reflects why we're doing this inquiry, and it's been reflected in many of the submissions that we've had to date. I just wonder, could you give us a couple of top tier, like your top suggestions on how you'd like to see the system changed? If there were a couple of things that you feel could make a huge difference and could be implemented relatively quickly, what would they be?
I think for us, the challenges we see for the families we work with is Edward touched on you don't know what you don't know. So families are unaware of the supports that children need and that are available to them. So some clarity around what is available to families. So a source of truth or a single source of knowledge that families have access to that can then point them in the directions they need. And for that to be well known within the communities, so that if families are speaking to GP, child and health nurses, to daycare workers, preschool workers, schools, everyone's referring families to the same place to look for information from where to go from here. I think the other barrier that we see a lot is the current systems that are in place in our communities aren't talking to each other. So mainstream supports like health and education aren't talking with NDIS. And for thriving kids to thrive and be successful, we need families to be able to move between these models and dip in and out of supports as needed. So the case example Edward gave of a girl with speech sound disorders, that initially presents as mild as one that I'm pretty familiar to me. So we know that if that's not treated, that it can impact children's academics and it can impact them socially, and it turns into a much bigger problem than if it was addressed at the time as early intervention. But because that family wasn't able to access support until they were deemed eligible to access NDIS, the outcomes for that child are then more difficult to predict because there's compounding factors. So if ease of access is improved for families and knowledge of how to access is improved, I think we'd really move the needle for families in Australia. That would be my biggest takeaway is, being able to dip into mainstream supports as well as NDIS supports as needs change without the 6 to 18 month wait to do a change of circumstance that we see at the moment.
Good.
If I can add to that as well, I think that there's been a lot of interest in the Illawarra Disability Alliance to think about what would be a more normalised approach to consistent developmental checks, and using existing systems wherever possible. There is the blue book that families typically leave hospital with that sort of gives some general developmental guidance, but could that be built upon? Could it be an app? Could there be consistent sort of ages and stages? And in fact, that's the name of a questionnaire that's typically used that you don't have to be an expert to use. But if all children had just at agreed ages, a check on how you're progressing, and that just became a normal thing. It was not any sort of so it allows those conversations to happen, and for further exploration or referral to specialists, to clinical expertise, should you have a concern or think that there might be an area of support needed around communication, mobility, healthcare, personal care, and those sort of areas. So I think it's just making it more consistent across the board for every Australian child that we have, an opportunity. It doesn't matter where you live or what your first language is spoken at home or other things of that nature. You are all of us having these conversations about development and what that looks like. So I think that is a big take home from the Illawarra Disability Alliance, that we would like to see the ability of, be it early childhood education providers who are often very well placed for these things, but also, there's child health clinics and other places where these agreed developmental checks could be completed. And again, families often have a great deal of motivation to be part of that as well. Like any of us who've had a blue book ourselves, and we diligently look at, the height and weight of our child. So there's a lot of that motivation and energy from families themselves. They just would like to have better information, as I think it was Kate mentioned earlier.
Do you think there's room to improve the education of parents, or the support for parents to get those checks done? Do you think we need to move in that space?
Yeah, very much. I mean, I think why don't we have the Blue Book app or something like that you have on your phone, and it gives you reminders of it's time for this check or that check, or this is where your the normal weight band for a child of your age would be. Just those sort of little tips and reminders. So you're sort of just paying attentive to that and more informed and educated, and then picking up on things earlier. So if you do have concerns, you can talk to your GP, you can talk to a specialist and get the advice that you need. I think that would make a lot of sense.
Any thoughts around the age we should be looking at these checks?
I'm not an expert in that area, so perhaps I'll...
Okay.
I would suggest, so I know in the Blue Book there's a 4-year-old check that falls under immunisations. You get your 4-year-old needles with your GP, and I know not every family does that, but a lot of families check in with their GP and they get a 4-year-old check, and we'll look at some school readiness type things at that stage. But I think for what we're talking about, there needs to be multiple check-in points. So I would suggest
maybe 2, 3...
12 months, 18 months, 2 years, 3, 4,
Okay.
And if Thriving Kids is going 0 to 8 years, I think that it makes sense for this to reflect that as well.
Good. Thanks. Monique.
Thank you. And I'm sorry about there's some issues with the unmuting function this morning on the system. You probably think we're all not here, but we are here. We're just struggling to unmute ourselves. I apologise for that. I'm really interested in this idea of that early screening. So, I mean, does it have to be done by a GP, do you think, or who would be the best person to do this? I mean, one of the issues is we all, I think, recognise that we need to wrap around parents a bit more. We need to have a universal screening model where every child gets looked at least twice probably before their school age, where we give parents the reassurance that they need, but we also pick up on those kids who do have milder sorts of developmental issues, whether it's speech or social or fine motor or whatever. But who should be doing them and at what age, I think? And we all know that there's significant workforce shortages, allied health and medical. How should we be doing this? And then I guess the next question for both of you is, we pick up some kids who've got some issues. We want to give parents the wraparound and reassurance that the kids are going to be sorted. This issue is going to be addressed as quickly as possible. Who's the best? What do the navigators look like, and what workforce are we tapping into to find those people to support parents in getting their kids from this initial assessment? It picks up some issues into the services that they need to receive. Nice, simple questions for you.
Look, I think there is a lot of expertise, as I said, in the sector, but you don't want all of those developmental checks being done by, allied health professionals or GPs, or they need to be things like the Ages and Stages questionnaire that are achievable to be done by a lay person, to give you that general. It's not an expert assessment, but it does look at what's going on for the young person. And I think the mistake would be that we have to have allied health assessments or even GP assessments. So early childhood educators would be very well placed to be doing those assessments, for example. So there's going to be different touch points, but what you want to make sure is that you're not missing kids. And so therefore it becomes a normal part of growing up in Australia that you have a development check. And if you're not enrolled in an early childhood education provider, then you still want to get that check. So it might be that you're visiting it might be your GP, or it might be visiting a child health clinic or something of that nature. But I think if those agreed points are known and understood by parents, and then it's a matter of, that there's multiple avenues to access that. And then in terms of what happens next, I suppose that's that's the bigger question. But like I say, we do have a fragmented system at the moment with a lot of very skilled allied health professionals, both in the private system as well as we need more resourcing for that within schools and other areas as well. But I do think you could resource those services to be providing those if they've gone through that screening. There is support needed. It needs to be timely. Families are waiting far too long after picking up on an issue. It can be 12 months of multiple barrage of further assessments, in which time you're losing out on valuable intervention opportunities. So we do also have to bring up the skill level for early childhood education providers in terms of speech and access and inclusion technologies. Again, which is not my area of expertise, and I might throw to other experts here.
Can I just add something?
Yeah, I think we're on a similar page when we're talking about who can deliver these assessments. I would probably caution away from GPs. I think asking families to make additional appointments with their GPs, that's another system under strain, is a challenge. I also think it places early development under the medical model, which for me, I feel like it belongs under the social model. And as soon as we start medicalising things for families, it can be a bit prohibitive or harder for them to access support. So I think if we fall more in that social model and look at our wonderful early childhood educators, and I don't think we should discount families themselves too. I think a lot of the time parents are experts when it comes to their children and we can rely on them. Something like the Ages and Stages questionnaire, they're very capable of filling in a lot of the time, not all of the time, but a lot of the time. So, I think we can put it back to we don't need a new workforce to deliver something like this. If we had a standardised screener, we could use the workforce that exists in early childhood and in families. And where to go from there, I think it's important that we use the local workforce. There's no point saying, based on the results of this screener, I can see that your child would benefit from seeing an occupational therapist for these reasons. We need to tell families these are your options in your regions. This is the wait list for these services, and we need to think about how we can reduce those. So maybe when it comes to thriving kids, we need to ensure that intervention is delivered in a more timely manner, so those referrals come through a different channel and have to be actioned in a certain amount of time.
Yeah,
but I think ensuring we're using local people who understand local supports and local systems is really important.
Can I just pick up on that with really both of you? My experience is that community nurses, early childhood teachers are actually very good at picking up kids who have developmental needs. I don't think that's where the problem is. The problem is then the next step, and there have been suggestions around having a navigator or a developmental area coordinator who can then help people get into the right areas. And one of the problems has been that next step doesn't seem to be catered for. Perhaps, Mr. Bird, if you could comment on that from the Illawarra, which is a huge area, of course, and some areas are closer to services than others. Would you like to comment on that?
Yes, certainly. I mean, that was one of our recommendations in terms of that idea of a centralised navigator function and resources to support families through what is a really confusing system. So you've got that advice that your child has some developmental issues and needs some further support above and beyond the norm. So then it really is, that's where it's like a case, I had to use the term case management function, but it is that sort of piece around helping the family then navigate to access therapists or the supports at the right level for them and their child, because the feedback is that people do feel very much lost when trying to navigate diagnostic processes. Even people with real expertise in this area or who work in the system themselves. So now where that is resourced exactly is a question, that I don't have the answer to, although we do have potentially, you might consider those navigator roles being positioned within schools or the child health service system itself, or we do have support coordinators, for example, within the NDIS service system and local area coordinators who may be well placed to assist to navigate. So again, there are resources that exist currently that may be able to be focused on this as a part of their client cohort to think about.
Good. Thanks. Sorry, Monique, I didn't mean to interrupt.
All good, Mark.
Any other questions?
Let's go. No, I have no more questions, thanks.
All good. Alice, would you like to?
Thank you, Chair. I just have one question, and thank you so much for appearing today. I'm Alice John-Bed, member for Gorton from Melbourne's western suburbs. We've heard a lot about parent burnout and parents feeling overwhelmed with the process of support for their children, and obviously given workforce shortages, delays in wait times for assessments, obviously that's quite overwhelming for parents, and this stress is compounded for with our cold communities in regional and remote Australia. And it sounds like the navigator role that you've mentioned to help families with that process would be really beneficial to a program like Thriving Kids. My question is to the community therapy group. In your submission, you mentioned a case study regarding the change of services review within the NDIS. And I think parents are also struggling not just to get that initial support with getting their children the support they need through their NDIS plan, but once they have that plan, the rigidity of the system means a change can be quite difficult in services. And one of the case studies you used was a 4-year-old child that was originally approved for speech pathology and OT because they were the areas the parent knew about at the time, but other symptoms sort of prevailed, and while the OT, recommended a physio, assessment to be done. That rigidity built within the plan meant there were delays in changing the child's plan, which I think is something that we can work on. Do you see an opportunity within Thriving Kids to potentially address something like this, whereby the current plans of the NDIS that the children have, may have some more flexibility built within them?
I think I mentioned earlier the rigidity of the system is a challenge for a lot of families, and Thriving Kids is really well placed to remove some of that rigidity, so long as families are able to flow between mainstream supports, Thriving Kids supports and NDIS supports. I think the barriers between systems need to be removed. I understand they serve a protective purpose, but there are families where circumstances change and they need to access additional supports. For the child in the case study in our submission, they were eligible for NDIS because they had delays across 2 domains. If they had only had a delay in one domain, they wouldn't be eligible for NDIS. So even if the OT flagged that it was very appropriate for them to seek support with a physiotherapist and that there were delays there, they would then have to initiate the process to access NDIS supports. So I think removing the rigidity so that families can move between systems is important. I think recognising that families don't know what they don't know, it's unreasonable to expect that families have the level of health literacy that we do when we work in this area every day. So a lot of the time a first plan that a child receives through the NDIS will include speech pathology supports and OT supports, and they need to ask for more. They don't know, they need to ask for more. So I think to stop the system from being too hard and causing family burnout, we need to shift the burden of navigation away from the family to the system itself, because the current system punishes families for lacking predictive health literacy. So I think there's scope for a single point of entry for all developmental concerns, whether that's a hotline number that's staffed that people can call, whether that's an app based on the Blue Book that we mentioned before. But I think a hub needs to be able to triage families and simplify that pathway for them, so that even when they are accessing some supports, they can still call somewhere and say, hey, we're doing this, I'm concerned about this, the health professional I'm seeing has recommended this, where do we go now, what do we do? And the system navigates that for the family rather than the onus being on the family.
Thank you. Thanks for your contribution. No further questions, Chair.
Good, thanks. Dr. Scomps, any questions?
Yes, thank you. Sorry, I'm just having a sneezing fit. And sorry, I dropped out there for a little bit as well. So I hope I don't, if I'm doubling up, please, you can ask to move on. But just wanted to follow up on what you were talking about there with the centralised hub. How would it work? I'm just wondering about this navigator role, whether it should be centralised or more local. Wonder if either if you have a comment on that. Local knowledge around local services or centralised.
Well, I mean, I think local knowledge is needed. Really, we've seen that with things like support coordination, where people try to take on participants from on the other side of the country. I think it's just really useful to have a working knowledge of the expertise locally, the availability of services. So I do think that these navigator roles or function are going to have to be locally based, is my thinking.
Thank you. Okay, great. And the other, before I dropped out, I was hearing about the use of an app, in a Blue Book type app with tips and reminders for parents, because I do think quite often parents are overwhelmed, so that parents are more informed. Are there any examples from around the world where we know that's working? Or a good one?
I don't know if Kate or Jordan know of any, but I'm not familiar with a developmental app. Maybe there's room for that. Australia is ahead of the game in a lot of this innovation space regarding disability, thanks to the NDIS, but it may be something that we could look at supporting. I think it's certainly got a lot of merit from my perspective. Don't know, Kate, are you aware of anything like that?
I think what we've got at the moment, the Raising Children's Network website, is a great website. It's super valuable. What feedback we get from families is that the information's great when we find it. There's a lot there and that volume is overwhelming. The NDIS website is too complex for a lot of families to navigate. And similarly, there's a lot of peak body websites for speech pathology, occupational therapy and physiotherapy. Some families are landing on these sites and finding information there, but they don't really know where to start, where to go, what to do with it. So centralising all of that's really important. From an international perspective, there are a few examples in our submission, but not of an app, just of things that are working well. I think the World Health Organization had something. I'm just trying to find the UNICEF Early Childhood Intervention and Inclusion Program, but it's a holistic family-centred program. It's not app-based yet, but we can pull things from what we've got and things that are working well elsewhere. But I think it's a build a new one situation.
Thank you. And then just one last question around the move towards inclusive, or the greater move towards more inclusive education. Just any comments that you have on how we can best do this so that we meet the needs of the kids who have extra needs and those in the mainstream schools as well.
Yeah, certainly that was a big focus of our submission with IDA, that resourcing for schools needs to be part of this initiative to support supported learning in every school, based on the demography and the size of the school, of course, but we really need to enhance the inclusion of local schools so that kids can be going to, that, like we've heard so many times, the importance of attending schools with your siblings, with your neighbours, and, bringing in some of the expertise that we've got through our fantastic special school system into those mainstream schools. So we do have considerable expertise across the schooling system, but it does tend to be still at this point, people are having to access those specialised learning environments outside of their local schools. So wherever we can build that capability for local schools is particularly important. Yeah, that's probably my key points.
If I could add to that quickly, I think a challenge we see is children are often accessing support before they get to school, which is wonderful. They're dipping into those early intervention supports as needed. At the moment, these children don't require a diagnosis to access those supports. When they get to school, however, in order to access funding to have SLSOs in the classroom and additional funding at school, they do need a diagnosis once they fall under the Department of Education. And families aren't always aware of that. So they've taken a breath because they're accessing supports that their children need. And they're unaware that when they get to school, the school isn't going to be equipped to support them because the schools don't have the funding to support them until they get that piece of paper. So I think it's really important that the Department of Education is on the same page here. If we're saying that children are able to access early intervention, whether it's through NDIS or Thriving Kids, without a diagnosis to a certain age, then the Department of Education needs to be able to support those children based on how they're functioning at school and what their needs are, not on their diagnosis. So I think that's a policy level change that needs to be addressed with them, that I feel is very important. And then the other one is upskilling staff in schools. I know, they're often feeling overwhelmed when they have kids with additional needs turning up. So again, sometimes these families arrive with a team of support around them and drawing on that support to upskill educators. So we're getting individualised supports for kids in schools as much as possible. There's a lot of, not red tape, but external providers have to do a lot of additional paperwork to see kids in schools, even though the evidence tells us that meeting families and children where they're at is best practice, and that's what we want to do to see the biggest impact for these kids. Schools obviously have to do their checks and balances, but families are the ones that are missing out by requiring a lot of additional paperwork and everything from external providers.
Do you think there's pressure on external providers to upgrade diagnoses for schools?
I think there can be, but I think external providers, we hold pretty tightly to our own ethics and values. We're not going to provide a diagnosis just to provide a diagnosis. That we can't do that and wouldn't do that, but it's hard to watch a child that would benefit from simple supports not being able to access them because they don't have a piece of paper that says they should. Yeah. Just, if I could just ask a quick question, just moving on before we go any further. Do you provide just one-to-one transactional services, or do you provide, for example, for schools, some block-funded services? Currently, the bulk of what we do is one-to-one intervention. We've provided some group interventions in the past and are registered under the behaviour support and therapist model with New South Wales Department of Education. So we're well placed to provide group interventions in schools and block-funded therapy and intervention there. At the moment, that's not happening. Right. Thanks. Mr. Burt, you want to make a comment as well?
No, that's all right. It's moved along. I mean, all I was going to say is that with that specialised support within schools. It needs to be flexible, really, so that kids move in and out of needing more supports and then can be mainstreamed effectively at different times in their school life into larger class sizes, for example. But if you don't have those, like a 7:2 student to staff ratio class sizes, if you haven't got that capability in your school, then they're going to need to leave the school for, to get that level of support.
Sure.
So it should be a more fluid system, is what I'm saying, that they can dip in and out as those case study examples. That young girl had to change schools every couple of years as her needs changed, rather than having the school able to be flexible and move around her.
Good, thanks. Any other questions? Alice, you all right? No. Good. Well, thank you very much for your time today. It's been very important to us and very, very helpful. If you've been asked to provide any additional information, could you please forward it to the Secretariat by the 24th of November 2025. If there's any questions you think we should have asked but didn't, please let us know, and you'll be sent a copy of the transcript of your evidence, and we'll have an opportunity to request corrections to any transcription errors. And thanks once again for attending. It's been really helpful. Thank you.
Thank you.
I will now just adjourn the committee for a short 15-minute break, and we will return just after 10:45. Thank you. representatives of the Autistic Self-Advocacy Network Australia and New Zealand, Autism CRC, Regional Autism Engagement Network Tasmania and Australian Neurodivergent Parents Association to give evidence today. For the Hansard record, would you please state your full names and the capacity in which you appear before the committee before giving evidence? I remind all stakeholders who are present before us that proceedings are to be conducted in a respectful and courteous way. The evidence given today will be recorded by Hansard and attracts parliamentary privilege. The giving of false or misleading evidence is a serious matter and may be regarded as a contempt of Parliament. It's absolutely essential that we all be treated with respect and that we all feel safe in these proceedings. I also remind stakeholders to be respectful of the parliamentary practice, that they should not criticise or make charges against any person, persons or entity by name or in such a way as to make him, her or it be identifiable. To assist with the transcription of the public hearing, would be appreciated if you could please state your name before responding to each question. I now invite you to make a brief opening statement before we proceed to discussion. Who would like to go first?
Can I just note that Sarah Langston has attempted to text and email the Secretary and is having some technical difficulties in trying to access the broadcast.
I'm here now. I've joined by phone.
Okay, welcome, Ms Langston. Okay, who would like to make an opening statement?
I'm happy to go first. My name's Heidi on behalf of the Regional Autistic Engagement Network. Before we do, we just wanted to confirm there was some emails sent regarding access needs. Was that read?
I did see some emails. Yeah, they were read. Yep. And noted.
Okay, great. Thank you. I appreciate that. And so I'm happy to do my opening statement now. Is that okay?
Yes, please.
Great, thank you. So as noted, thank you, Chair. As noted, my name is Heidi Lapalia. I'm an autistic disabled mum, an NDIS participant myself, and an advocate who's worked in systemic advocacy for around a decade in the disability space. I also work directly on the National Autism Strategy as a member of the Oversight Council that oversaw it, and today I'm speaking on behalf of the Regional Autistic Engagement Network, along with my colleague Nicole Moran. First of all, I'd like to acknowledge the traditional owners of the land on which I am joining from, Muwinina country in Litruwita, Tasmania, and on behalf of Rayan, I acknowledge and pay respects to our Tasmanian Aboriginal communities. I also acknowledge the neurodivergent community in Tasmania. For a bit of background, RAIN, or the Regional Autistic Engagement Network, is a Tasmanian disabled people's organisation led by and for autistic and ADHD people, families, carers and allies. We are formally incorporated and largely stepped into the advocacy space after Autism Tasmania was defunded and closed last year, which left the state with no government-funded autistic advocacy body. Despite having no funding or staff, RAIN has been working tirelessly to platform the voices of our community members who've shared their stories and fears with us around the impacts of thriving kids. And to ensure these voices were heard, we launched a Protect Autistic Kids, Stop Thriving Kids petition just after Minister Butler announced the program. Within 3 weeks, that petition gained more than 15,000 signatures, and many left hundreds of detailed comments about their concerns. These comments overwhelmingly made it clear that there is community opposition to these reforms, and there is a deep fear around the changes and harm they will cause. For example, one person said, "My son was told he'd never read, write or speak clearly. After years of individualised NDIS funding therapy, he is now thriving. Without these supports, he will regress." Another said, "Every change that removes support just pushes more pressure onto systems that are already at breaking point." In our view, and that of the community, the proposed program represents a fundamental step backwards. It risks removing individualised NDIS early childhood supports, and replacing them with generic block-funded or mainstream services that, particularly in our state, are simply not enough or do not exist in many areas. It is also deeply concerning that the model splinters off one specific diagnostic group, or two, autistic children and those with developmental delay, into a separate system outside the NDIS. We view this as discriminatory and fundamentally out of step with the UNCRPD and the intent of the scheme. We note that for regional families, these risks are compounded, services are already stretched. The result will be inequity, families with money will pay gap fees and others will miss out altogether. This policy also carries gendered and workforce consequences. The NDIS early intervention pathway, we know, has supported a workforce of mostly women, including many mothers and disabled women. Removing children from the NDIS would destabilise that workforce, undermine regional economies, and put the unpaid care load back onto unpaid carers, mostly mothers. Going forward, we need to ensure that any reform that occurs is done in full co-design with the autistic community and ensures that no one is left worse off. Prior to the announcement of Thriving Kids, we note there was no public consultation with autistic people or disabled people's organisations. While we acknowledge efforts that have been made since to engage with the community, we are still concerned that this process has been rushed and that the advisory group appointed to oversee the design of Thriving Kids includes only one disabled people's representative organisation, and that the most recent communique on the website states that the design will be finalised before the end of 2025, which is only next month. The United Nations Convention on the Rights of People with Disabilities requires governments to closely consult and actively involve people with disability through their representative organisations and in all decisions that affect them. The National Autism Strategy, which I personally worked on, also promises that programs will be co-designed with autistic people and reflect neuro-affirming values, and the Closing the Gap framework commits to self-determination and culturally safe approaches, particularly for First Nations autistic children and families. We're concerned that these obligations are not being met. Thank you for your time. I'll now pass to my colleague, Nicole, to finish Rain's statement.
Hi, so my name is Nicole Moran. I'm autistic and ADHD, an NDIS participant, and I have a background as an early childhood educator, and I'm currently studying a Bachelor of Disability and Community Inclusion at university. I'm a member of multiple national organisations, including AMPA and the Nobody Worse Off Coalition. Today I'm speaking on behalf of the Regional Autistic Engagement Network. I also speak as a disabled adult who grew up in a rural community in Tasmania, identified as requiring support and received block-funded supports as a child. I am also a single parent who has 100% care of their child who is disabled and received block-funded supports for developmental delays before receiving supports from the NDIS when diagnosed with global developmental delays. I acknowledge that I am privileged in my education and highlight the marginalised intersectionality I experience. I'm also here to tell you returning to block funding arrangements will disproportionately impact marginalised communities, families and children who cannot afford gap fee services, which we know will remain in rural communities due to lack of available services and providers. Block funding is also not an appropriate form of support for disabled people, and our community will not accept a program that forces this upon us. Disabled children and their families require access to self-directed, individualised funding packages such as the NDIS. We require individualised and adequate funding, information and support to make informed decisions, as well as creative supports of welcoming communities and appropriate services to meet our individual needs. This cannot be provided under block funding arrangements. I speak to the facts of the evidence I know and from the experience of myself and my community. Evidence-based research from both Australia and internationally supports self-directed, individualised funding packages such as the NDIS. These studies' findings show better outcomes in comparison to block-funded services for disabled people when certain criteria conditions are met, such as those that Australia has used in the past and continues to use for some state-funded services. Evidence-based research shows we require individualised and adequate funding, information and support to make informed decisions as well as creative supports, welcoming communities and appropriate services to meet our individual needs. This cannot be provided under block funding arrangements. Both my son and I have received block-funded disability supports in Tasmania. These supports never provided us with adequate support and always fell short of our needs. Even with block-funded supports, my family and I were left with out-of-pocket expenses that we could not afford. To receive funds from child support to assist with additional expenses for disabled children, the paying parent must either provide the money to child support, or child support must establish a collection avenue that is available to garnish from. Considering the massive amount of child support debt that exists and the inconsistencies in payments for many, this makes it difficult to rely on this supposed income. Statistically speaking, this means that disabled parents are more likely to be significantly financially disadvantaged due to multiple factors, including domestic and family violence, carer responsibilities, and more. This means that returning to block funding arrangements will logically disproportionately impact marginalised intersectional communities, families, and children who cannot afford gap service fees, which we know will remain in rural communities due to a lack of available services and providers. Disabled children and their families require access to self-directed individual funding packages such as the NDIS. We require individualised and adequate funding, information and support to make informed decisions, as well as creative supports, welcoming communities and appropriate services to meet our individual needs. This cannot be provided under block funding arrangements, and in turn our community will not accept a program that forces this upon us or our children. Thank you for your time.
Thank you. Would note that Autism CRC has just arrived, so this session we might extend a little bit, give you a bit of extra time. Would anyone else like to make an opening statement?
Yes, I would.
Yes, thank you.
We might, sorry.
Come back.
Yeah, we'll come back to you. Yes, would you like to make an opening statement?
Sorry, yes, I would.
Yeah, online.
Cheryl.
Yes, I would, thank you.
Ms. Cock.
Yes. Thank you for the opportunity today to speak on behalf of the Autistic Self-Advocacy Network of Australia and New Zealand, or ASAN AUNZ. My name is Cheryl Cock. I am a late diagnosed autistic mother of my autistic child. I have an MBA and 20-year professional career alongside lived experience of many issues that co-occur with being autistic, including abuse, discrimination, and mental and physical health challenges. I'm a director of the disability representative organisation Australian Autism Alliance, and I speak today as chair of the Disability Representative and Carers Organisation, ASAN AUNZ. I acknowledge the traditional owners of the lands on which we meet and pay my respects to elders past and present. I also celebrate the diversity of our cultures, abilities, identities and neurotypes, and honour the contributions of people with disability to Australia's shared story. ASAN AUNZ is a wholly autistic-led and operated organisation with a 20-year history. We have over 1,500 members and a national reach in excess of 80,000 people. Our board and team represents diverse lived experience, complex communication needs, LGBTIQASB plus community members, those that are multiply disabled, have intersectional identities, come from culturally and linguistically diverse communities, rural and remote communities, and First Nations peoples. We are trusted because we combine lived experience with evidence-based advocacy. Thriving Kids is a pivotal opportunity to reshape Australia's disability ecosystem, but it cannot be successful if it doesn't garner the trust of the autistic community and the neurodivergent community across Australia. It must build trust through strong protections and continuous safety nets. No child should ever lose existing support under this new system and should not be using this new system until it can guarantee that appropriate ongoing care. It must address the risks and fears that so many have shared with this community. ASAN AUNZ's submission is based on every recommendation being ethical. We need to build on an ethical framework. Autism is a natural lifelong variation in human neurodiversity. It is not something to prevent or cure or erase. Our focus must be supporting children to communicate, manage, feel safe and engage in environments that weren't initially built for them. To be accepted by our community, Thriving Kids must reject autism policies shaped by deficit framing and attempts to prevent autism or normalise autistic ways of being, and it must deliver neuro-affirming, trauma-informed and culturally respectful supports. Thriving Kids' development, implementation and evaluation must be done in ways that can be trusted by neurodivergent adults. This means transparent and ethical evaluation of supports, free from potential conflicts that are already being visible with appointments of committees and consultants. It must be done in ways that ensure that all of the supports that Australians fund are rigorously and independently assessed for safety, harm and, very importantly, long-term well-being of our children's outcomes. Please, the committee must consider how these outcomes could impact the lifelong mental health of our children. It's important to note the very concerning suicidal ideation rates of autistic children that are perhaps the highest in the country of any measured cohort. We can provide those on notice if you want more details on that research.
That would be worthwhile if you could send some data through to us. That would be worthwhile. Thank you.
Thriving Kids must be developed, implemented in ways that we can trust, and to be valued by the community, it must be measured in terms of the well-being of the child. It cannot be focused on observations of reduced atypical behaviours or evidence bases that are developed from a deficit-framed approach, as much of the existing evidence base currently is. It requires robust reconsideration from an ethical standpoint to ensure that it is genuinely not producing harmful outcomes for our children.
Good.
Okay. If we were to appropriately measure and do these things, it would help to build trust. As others have said, to be successful, Thriving Kids must be co-designed with neurodivergent people at all stages and all levels. This includes governance led by adults with lived experience of being the children the initiative seeks to support. Yeah. I repeat, to be successful, Thriving Kids must be led by adults with the lived experience of being the children the initiative seeks to support. We must provide effective early supports that are neuroaffirming, not behaviourist, and we must ensure we don't have supports that suppress autistic traits like stimming that cause documented harm, including anxiety and trauma. We call for neuroaffirming, trauma-informed interventions, respectful, transparent, independent evaluations that are clear from conflicts, as I said, that are already showing up, meaningful co-design, nothing about us without us, from policy through design, implementation and evaluation. And our message is simple: do this once, do this well, and do this with us. Together, we can create a neuroaffirming, co-designed system that ensures autistic children and neurodivergent children thrive with emotional well-being, a feeling of safety in their identity, confidence in communication, and families that feel supported, not blamed or fearful. Thank you.
Thank you.
I'll hand over to Alex to introduce herself as well.
Thank you, Chair. My name is Alexandra Bignell and I'm the Deputy Chair of ASAN AUNZ. I am an autistic woman raising an autistic son, and I actually work in the local government sector, so I have seen firsthand the impact that the NDIS has had on the broader service system. In that service system, many supports that were traditionally available to people with disability were rolled into the NDIS. And while I echo everyone's concern here that nobody should lose supports if they are already in the NDIS, I do recognise that foundational supports is an important step in actually filling a gap that has existed for over 10 years. Autistic people basically have not had the supports that some people in the NDIS have had. I support refugee communities, migrant communities, people who do not speak English as a first language, who have no access to support. So we do recognise that this is an important step, but co-design is essential. Co-design hasn't always been done well. We know that from the National Disability Strategy, the first 10 years of that strategy, we know that it did not reflect the needs of people with disability, and that the reason for that was the way consultation was conducted. Co-design is about shared power. It's about involving parents and families, but it's also about asking children. The UNCRPD does have an article on children, which clearly states that children have a right to have a say in the things that impact them. So I would call for co-design in terms of governance, how this structure is designed, how it is implemented, and with ongoing feedback loops that allow families and children to provide ongoing feedback. That should be part of independent evaluation as well. We also call for neuroaffirming practice at all times. Neuroaffirming, as my colleague Cheryl said.
I'm sorry, Ms. Bignell, we're going to have to interrupt there because we're going to run out of time. Your colleague has already gone through those very important co-design features. If you do have some more information you'd like to give us, you're welcome to email it through that to the committee. But we will have to move on to the other groups, to be fair, to give them time to give evidence, if that's okay. Good. So we might move on to Autism CRC for a brief opening statement, if you could. Thanks.
Absolutely. I'll keep it brief.
Thanks.
Thank you. Good morning. It's an honour to be here today. I'm Cheryl Mangan. I'm Chief Innovation Officer at Autism CRC, and I'm joined by Professor David Trembath, who co-led the development of several nationally significant guidelines shaping evidence-based practice across health and disability sectors. Autism CRC is Australia's independent source of evidence for best practice in autism across the lifespan and the spectrum. We bring together autistic people, families, professionals, service providers, researchers and government in a unique national collaboration. We develop evidence-based guidance, tools, resources, translating research into policy and practice. We know that you will hear a range of perspectives in this inquiry, and we are really excited about that. It's a good thing, because every view is important, because together they help us find the best solutions. But let's remember that we're all on the same side, working toward a future where autistic children and their families are safe, supported, and able to thrive. A cornerstone of thriving kids must be evidence-based resources and approaches. And the good news is that we're not starting from scratch. We already have robust national resources designed for practitioners, educators, and families to ensure consistent evidence-based practice across Australia. These include the National Framework for Assessing Children's Functional Strengths and Support Needs, a culturally responsive, evidence-based approach for children aged 0 to 12, creating a common language across health, education, disability, and community services, helping families navigate supports more easily. We also have the National Best Practice Framework for Early Childhood Intervention, guiding high-quality, evidence-informed support for children and families. We also have a national guideline for supporting autistic children and their families, approved by the NHMRC and co-designed with over 800 Australians. It sets out principle-based approach that places children and families at the centre and includes recommendations for goal setting, selecting and delivering supports, monitoring outcomes and safeguarding. We are also in the process of developing new national guidance for best practice in inclusive education for autistic students. Like our previous guidelines, it will bring together rigorous evidence, broad community input, including, critically, the autistic view. It also involves collaboration with government around federal and state governments across Australia and education stakeholders and at national authorities. The goal is simple: to help schools and teachers create inclusive environments that support social and emotional and academic outcomes, supporting autistic children in mainstream educational environments. These resources, combined with international best practice, underpin a tiered support system which integrates community, mainstream and NDIS supports, tailored to each family and child. This system must avoid silos and competition and instead focus on collaboration and community. Finally, as our colleagues have said, success does depend on true co-design with autistic individuals, families and providers. We need to trust this system, and that trust comes from working together, ensuring equity and cultural safety, and keeping children and families at the centre. The government has already committed to this through the National Autism Strategy and the National Autism Health Roadmap. We know that Thriving Kids is moving at pace, and we welcome that commitment. In our submission, we've outlined several evidence-based solutions which are ready to implement today, and we'd be very happy to work with you to bring these into action and support next steps. Thank you.
Thanks very much. And aware, Ms Langston, you're still on the line. Do you have any opening statement?
I do, yes. Yes, I do. And I just wanted to just remind the Chair and Committee that I did email through a request that I be able to read my whole statement. It is not terribly long, but it is important, especially because our submission has not been published. So ensuring this is on Hansard is really quite important. Thank you.
Good.
And I just wanted to acknowledge and thank the committee for giving more latitude to the speakers this morning and observing those access requests that were made. We really appreciate it.
Good.
Chair and members of the committee, thank you for the opportunity to speak. I acknowledge that I am presenting from Gundungurra and Darug countries in the Blue Mountains, and I acknowledge their elders past, present and emerging. I also acknowledge the Ngunnawal and Ngambri people of the lands upon which you are gathered, and I pay my respects to their elders also. In both places, this always was and always will be unceded Aboriginal land. Before I begin, I just covered this, I'll skip that bit. I am here to speak about the Thriving Kids initiative and specifically about the Inklings program, which our submission concerned, which the Minister has presented as a model of the kind of early intervention he considers fit for our community.
Yeah, if
I speak as the elected...
If I could just make clear, this is not an inquiry into the Inklings program. It is not something that we have looked at in great detail at this stage. And so this inquiry is not about the Inklings program. And could you also just give us your full name and whom you are appearing
Yes, my
for?
name is Sure. My name is Sarah, and I was about to say that. If I could just read my whole statement, it covers all of those points.
Sure.
So I speak as the elected representative of the Australian Neurodivergent Parents Association. My name is Sarah Langston, and I'm the president of the ANPA, and as a proud neurodivergent mother to a neurodivergent child. I also speak as a late diagnosed autistic and ADHD woman who was missed, and the daughter of an ADHD mother who was missed. Both of us had support needs that were overlooked for decades, and this shaped our lives in many adverse ways. My child is the first in our family to receive the support he has a right to. Many neurodivergent mothers and parents share that experience and that lineage. It is for them that I appear today, for all of us. Together we are fighting against strong private interests and political forces, with one goal together: a more dignified, good life for our children and ourselves. Thriving Kids proposes a pathway outside the NDIS for children with so-called mild or moderate autism. Inklings has been positioned by the Minister as the flagship program in that model. For that reason, and since it has been held up as an exemplar, it is essential to understand the program's development, evidence base and risks. This will help us to understand more about what the Minister may consider to be fit for our community. Inklings began with the iBasis FIP trial in the UK, led by Professor Jonathan Green in 2017, which tested filming parents with their babies and coaching their responses. The small, time-limited effects reported were seen only under tightly controlled research conditions. An Australian trial, led by Professor Andrew Whitehouse of the Telethon Kids Institute, followed similar methods, but with only 103 babies in total. That's a very limited evidence base. The program was explicitly publicly promoted as a way to reduce future autism diagnosis rates and save on NDIS costs. Those statements remain on the public record, despite efforts to step away from that language more recently. As community concerns grew, the program was rebranded to appear more neuroaffirming. When that did not resolve opposition, Telethon Kids, now rebranded as the Kids AU, rewrote the manual last year under non-disclosure agreements with 4 autistic therapists. Disabled people's representative organisations were not included in this process. This rewritten version has never been peer-reviewed, never trialled and never evaluated. Under Australian evidence standards, including according to the NHMRC, once a program is materially changed, the original evidence no longer applies. Despite that, this untested version is now proposed for national rollout under Thriving Kids. At its core, Inklings involves filming parents with their babies, analysing the behaviour and providing corrective feedback. For babies, this may reinforce a deficit model of social interaction and communication that risks driving early masking and camouflaging behaviour. Research by Cassidy and Rogers links masking behaviour to burnout, anxiety and suicidality later in life. Inklings will not make children less autistic. It will only make them appear less autistic on the outside for a little while. Programs pursuing similar goals will do the same. Let us turn now to the risks to the mothers of these babies. We have plausibly argued in our submission the risks to mothers of these children are more intense and immediate because of the methods used, how they land, and who these parents actually are. Let us first look at the method deployed in this model and be frank about what it involves. Taking a camera into the most intimate place in a mother's life with her baby, her home, and her relationship with her baby. Filming and then correcting how she connects with her baby. We have also heard directly from practitioners delivering Inklings about how it is currently being delivered and will continue to be. They told us the program is fully scripted down to the minute. After filming the parent, usually a mother, with her baby, practitioners leave the room to score the parent's behaviour, then return to deliver corrective feedback. There is no relationship building, no curiosity about the family's culture or strength, and no valuing of the parent's own knowledge. One practitioner openly admitted she did not know enough to work safely with First Nations families. This approach presumes parental incompetence from the outset and is not culturally safe, regardless of whatever may be said about it. It reflects a deficit lens applied to mothers and their babies, and not support for either. The mindset behind this and similar programs feels uncomfortably familiar. In the 1950s and 60s, the refrigerator mother theory claimed autism was caused by cold or inadequate parenting. Mothers were blamed. Many were subjected to scrutiny, coercive intervention, and even separation from their children. We now know this was entitled and profoundly harmful. Yet the pattern of assuming parental deficit and investigating parents rather than supporting them is exactly what our community is seeing again in programs like this. We wish to state for the record that the ANTA do not view mothers this way. We see them as the first and best experts on their children, with deep knowledge, love, skill, culture, and wisdom. This is especially so for First Nations parents. We are raising our children against the odds, with a lot stacked against them and us. We withstand poverty, domestic violence, endless mother blaming, pathologisation of our trauma, and harsh criticisms that constantly tell us we're getting it wrong. Still, we persist because they're our family. Nobody, in my view, has more grit, courage, or love than the disabled mother of a disabled child. What does the evidence we reviewed in our submission say about techniques deployed in the Inklings program? Firstly, clearly says that videotaping at home will very likely trigger what psychologists call social evaluative stress. Research by Dickerson and Kemeny and the TRIA's social stress test shows that being recorded and judged reliably triggers a strong stress response. For autistic women who often have long histories of masking under scrutiny, that impact is intensified because research tells us that feeling perceived or judged triggers masking behaviour in our cohort. Masking is consistently linked to depression, increased anxiety, self-monitoring behaviour, exhaustion, self-harm, and suicidality in research by Hull, Cassidy, and others. Our community survey reflects this reality. In September 2025, the ANTA surveyed 46 neurodivergent parents and carers from across Australia, all raising neurodivergent children. We asked parents how they may feel in the scenario described above. 87% said being filmed would make them feel anxious, humiliated, scrutinised, or distressed. 74% of autistic parents said they would mask during the session. Parents used words like unsafe, intrusive, and exposing. These are not isolated views. They've been echoed in thousands of conversations, concerned emails, social media commentary, calls, and texts since Inklings first entered the, since Inklings first entered the collective consciousness of the neurodivergent parent community. They demonstrate that the core mechanism of Inklings is quite likely to be experienced by our community as surveillance and not as support. This brings us to the cohort most affected, who they are and why this even matters. We know now that autism is highly heritable. Sandon and colleagues estimated heritability at around 80%. It is likely a great many babies identified for Inklings will have autistic mothers. Research by Cassidy, Crane, Poll, and others show autistic women experience far higher rates of depression, anxiety, trauma, and suicidality. Maternal suicide is a leading cause of death in the first postnatal year, and 60% of autistic mothers experience postnatal depression, compared to 11% of the general population. These risks are well known. There has been no tailored autism-specific adverse event monitoring focused on maternal safety at any stage of the development of this program. The only mental health monitoring of mothers done has been the DAS-21, an assessment scale not fit for purpose when working with a cohort of diagnosed or undiagnosed autistic mothers and babies. This is because autistic people experience a specific type of suicide risk that emerges from transitory distress. Transitory distress, which some may know as meltdown, shutdown, has a rapid onset within 24 to 72 hours of a triggering event. It is incredibly dangerous if unsupported despite being brief. Mothers are unlikely to reliably self-report how they feel on any assessment scale due to the rational fear of child protection involvement. I must emphasise, as a wind-up when discussing these risks, that mothers experiencing transitory distress are primarily a risk to themselves, not their children. The key risk to children we're concerned about, therefore, is the devastation of losing their mother to suicide. We also believe mothers are valuable, and we know that we have inherent human rights under international law to be treated with dignity and care, and to receive real, co-designed support to preserve our families. Inklings fails that test because it presumes incompetence and places us under a microscope that puts us at risk, and any other similar program will. The Disability Royal Commission made a critical point on this score, which is that disabled parents are not an inherent risk to their children. Risk comes from systems that judge instead of support, and from needs that go unmet. An autistic child is not safe if their autistic mother is not supported. The cycles of unmet needs that affect our family do not come from who we are, they come from lack of support. And these cycles are only broken through support, not scrutiny. Finally, I turn to the rights of our children in the broader context of this inquiry. Thriving Kids proposes different, non-individualised early intervention pathways based on disability type and prevalence. That is inherently discriminatory. It departs from the principles and objects of the NDIS Act, from the Convention on the Rights of Persons with Disabilities, and from basic principles of equity and fairness. And if Inklings is being presented as fit for our community, when our community clearly says otherwise, then nothing about us without us is not being honoured in principle or practice. Chair, based on the research evidence, our community data, and the principles of the Disability Royal Commission, the UN CRPD and the NDIS Act, delivering Inklings under Thriving Kids or any other general, non-individualised program that fails to meet needs and assure rights is unsafe, discriminatory, and inconsistent with our human rights obligations. Inklings, or any other program like it, is not fit for national rollout. We will continue advocating until neurodivergent mothers and children get on equal ground with every other Australian family. Thank you for your time.
Thank you. We'll now open it up to questions. I think Dr. Scomps, you're still online?
I am, thank you, and thank you everyone for your presentations. They're very, very valuable. I had a question for the Autism CRC group, just around the National Framework Assessment for Support Needs and Strengths. Can I just ask, who is able to deliver that assessment?
It's a question for you. Yes, thank you very much for the question. So David Trembath responding. The Strengths and Support Needs tool is a light touch tool that can be used by any person who's looking to work with the family to capture the child's strengths, support needs, also information about their life situations, as well as any risks and opportunities for the child and family. So it's designed to be used by allied health professionals, GPs, early childhood education teachers, Aboriginal health workers, the whole range. And it's a plain language, child and family centred approach that helps to bring all of the information together so that really sensible, evidence-based, respectful decisions can be made with the child and family in relation to the supports that they access.
And when was it how long has it been around?
Yeah, great question. So the national framework was developed and released in 2024, and that was a process that involved co-production with 20 different community and professional organisations and associations. And the framework outlines the process of assessment, so understanding the child's strengths and support needs, the process of differentiating, so understanding, working with the child and family to work out what are the priorities, what's the logical next step, and then also in terms of sharing information, so supporting a really coordinated approach to working with kids and families and the supports around them. So I only provide that basis to give the context for the tool, which has been developed over the last basically 12 months, and has gone through a process of bringing the framework to life and then working with a whole range of early childhood professionals, including allied health, early childhood education, teachers, etc., in order to develop, refine, test, validate, and prepare that tool ready for use. So we'll be delivering to the Autism CRC that Strengths and Support Needs tool in the next month or so.
Interesting.
Could I ask,
and may I ask one more question, I guess, really quickly?
Before you go on, Sophie, can we have a copy of that sent to us?
Yeah, certainly. So we have a copy of the framework today, and we'll absolutely arrange for the Strengths and Support Needs tool to be sent through as well.
Absolutely, and we're very much focused on the implementation, so developing resources and capacity building training to actually support the professionals who will be using it.
Right, and the framework you'll leave with the committee today, we can, yeah, and we can deliver that to all the members. Great. Absolutely. Sorry, Sophie.
Oh, no. So obviously it's not around diagnosis, it's around strengths and support needs. And then this might be open to everyone. What do you feel are the biggest barriers to the kids getting the support that they need? I mean, this is a big question, sorry.
Would you like me to briefly? Yeah, so in terms of the tool, so it is for use across all the, it's not diagnosis specific by any stretch. It's been deliberately designed with all of those organisations to focus on children's strengths and support needs, irrespective of whether they have one or more diagnoses now or they may do so in the future. And it really stands out from other tools which do tend to focus on a particular diagnosis or population, an area of development, etc. It kind of spans those, transcends those, and in that way provides that common way of communicating. In terms of barriers to support, they're well documented. I won't take a lot of time because I want to hear from the other people representing today. But some key ones include finding a good match between what the child's strengths and support needs are and the services and supports that are available. So that linking or fitting piece is really important. Certainly the issues around availability of services and supports and making sure that there are services and supports for kids and families. But also when it comes to barriers, a key barrier is the coordination of supports. And so often children and families spend a lot of time, money, energy and emotional energy pursuing or engaging in supports that aren't the best fit for that child and family. And that's due to a lack of coordination. So if we can address that key challenge, it will ensure the most appropriate use of resources, the most expedient approach to getting children and families the supports they need, and ultimately then the best outcomes.
Thanks. Anyone else?
Can I just ask very quickly, and we'll hear from the other presenters as well, about how we would address that?
Yeah, certainly. So My understanding is with Thriving Kids that a key aim is to connect services and supports, and that includes mainstream supports, foundational and specialist supports where they're required. Internationally, the approach that's adopted is a stepped care model of support. And the idea is that children and families are matched with the step of support that is most appropriate for them at a particular point in time. Over time, the steps can increase or decrease depending on what's required, but most importantly, children and families don't jump to the highest step, that really specialised in time-intensive and costly support. It's much more about matching. But for a step model of care to work, we really need that coordination. We need that really strong differentiation prioritisation piece to know which step is the logical next best step for that child and family.
Thank you.
Anyone else like to comment on that?
Yes, I've got my hand up. Nicole Moran from the Regional Autistic Engagement Network.
Yep, go ahead.
So one of the things that probably gives me a very different lens in this perspective is that my background is as an early childhood educator. So I'm a qualified early childhood educator. I'm also currently studying my Bachelor of Disability and Community Inclusion, and I also have lived experience in this area as well through both my own experience and my son's. And the core premise of what Rain's submission has been saying is that one of the core problems is that what has previously been implemented and what is currently being sought through Thriving Kids is not designed with us. Because it's not designed with us, that means that it hasn't been done in a way that is accessible to us or to our families or to our children. And within that space as well, there are assertions made that exclude us from the consultation process as well. And so there are many barriers, and that's why we're calling for things to be done in an appropriate way, which means looking at the process and doing it from scratch with our involvement, with us leading the way to ensure that anything is done in our best interest with our lived experience. And I can say right now that as somebody who has been through the process themselves, both as a child with parents that were very transparent about what was occurring, as well as a parent, the current systems that are in place are not adequate. The current supports that are available are not adequate. But we can't start to fix that or do anything about it until we have genuine co-design, which involves our involvement in the decision-making process, not decisions being made for us by people that are not us.
Okay.
I'd like to respond to the question and address the point about tiered support, if I may.
Sure. Could you state your name?
So it's Sarah Langston from the AMPA. So on the topic of tiered support, which David has touched on, and I'm aware the Autism CRC submission also touches on. So our position on tiered supports is that they're often presented as a way to simplify disability services, but in practice they actually create structural inequality. So these models, they've been applied internationally, so there is precedent we can draw on here. So these models tend to sort people into predefined levels using tools that don't capture real-world complexity, especially for people with fluctuating, episodic or overlapping disabilities. That includes kids. The result often is routine misclassification and predictable under-support. Disabled people, including children, their needs change over time. Tiers rarely keep pace, and there's a lot of evidence that shows that. Families often become locked into too low levels, even when circumstances do deteriorate. This leads to preventable harm and unnecessary escalation, and it often prompts child protection intervention. International evidence shows that tiering does not improve outcomes. It primarily functions as a rationing tool. Tiered systems also create indirect discrimination. Communities with less access to assessment literacy, including First Nations families, migrant, autistic people themselves, including parents of autistic children, and those with psychosocial disability who are parenting these kids, are more often placed in lower tiers of their kids. That conflicts with equal access obligations under the UNCRPD, entrenches barriers rather than removing them. So the biggest problem with them is that they fragment essential support by pre-packaging what people can receive, and we're already seeing that under the NDIS with support buckets. So they ignore individual context, undermine early and preventative intervention because they're ineffective, and they shift the burden of proof onto the participants or the users of the system, who must constantly justify their existence within these narrow categories. They don't work, and there's a lot of evidence internationally that shows they don't work.
Well, I would disagree with you, but thanks for your input. Would anyone else like to comment?
Yep, Heidi Lapalia from the Regional Autistic Engagement Network. I just wanted to make a quick point on the tiered supports / I guess putting kids with so-called mild to moderate autism onto thriving kids. I think that one of the really big problems with defining people's supports into levels, and we know this with the current diagnostic criteria as well, and I guess putting some kids into an alternative package outside of the NDIS while leaving so-called high support needs children on, is that it really does overlook the fact that autism doesn't exist in kind of a linear fashion. So autistic kids and adults actually may have really high support needs in one area and low support needs in another, and it really does depend on contextual factors as well. And I think that this kind of narrow view of how we categorise people is really overlooking that. So that's just the point I wanted to make there.
Okay. Alice, do you have any questions?
I have one question.
Sure.
Thank you all for your contributions today. It's great to have you.
Sorry, I've had my hand up. It's Cheryl from Asan AUNZ. I've waited patiently for the chair to call upon us.
Sorry, I couldn't see your hand. Sorry.
That's okay. I'm Cheryl Cogg. I'm from the Autistic Self-Advocacy Network of Australia and New Zealand. I wanted to respond to the question around barriers to success. And I guess I first asked the committee to reflect upon who was asked and who answered the question first, and understand that whether those people identify in themselves as autistic or neurodivergent, and how they introduce themselves, or if they introduce themselves, and whether or not, the conflicts and circumstances that each of us bring. I think it's important to understand those things. But most importantly, in terms of a barrier to success, we've raised this need for things to be done ethically and without conflict, because any Thriving Kids initiative will not be successful if the people that are being asked to use it, the communities that are being asked to use it, do not trust it. And I say this from 20 years commercial leadership in Tier 1 contractors delivering government programs, billion-dollar government programs. And I know that regardless of any evidence-based, professional, clinical, economic evaluation or imperative, if the people using the system do not trust it, it will not be successful. And so I ask the committee to consider this really carefully, because evidence has shown that autistic people, neurodivergent people, communicate differently to neurotypical people, and we can see that here today. The rapport that has been shown, even within this meeting, between neurotypical people that are present has built very quickly, and there is a clear disconnect between those people that identify as neurotypical people here and those people that identify as autistic. Now, that is okay. We are all different. That is not a criticism of anyone. But what it is showing us is evidence-based that neurodivergent people communicate differently. Now, the reality is that these studies have shown in, for example, chain of whispers, pass it on, or inappropriately called Chinese whispers, where a group of mixed neurotypes don't do a very good job of passing a message from one end to the end. And this is one end to the other. This is relevant in policy implementation, right, and building trust. Someone who is autistic says, this is what I need. By the time it gets to the other end, you're hearing a completely different message. Now, if all of those people are neurotypical, they are more likely to get the message right from one end to the other. But if all of those people are autistic, they are even more likely to get the message from one end to the other. So in fact, within the autistic community, we are better at continuously providing consistency of message. And this is why co-design at all levels, at all stages is so critical. Because if you can't get those support needs translated without being interfered with, you're not going to deliver the support needs that are actually required. And I see this happen all the time in Asan's ongoing communications with the NDIA. So this is not something that is purely theoretical, it is also reality, built-in reality. And I've used it over 20 years. It's really important that the committee understands that when you have people standing in front of you, sitting in front of you, with the capacity to sit in front of you, that perhaps present in the way that feels the most comfortable to you and looks like the most credible, it doesn't make it so. This is not to discredit anyone. This is for you to be aware as a committee of the challenge of engaging with the autistic community and trying to develop services for children that are experiencing things that you have never experienced in your life. And so I ask you to keep those things in mind, because that is the biggest barrier to success. It is not a checklist. It is not a tiered system. It is comprehension of the challenges and the mindset that we bring. Thank you.
Professor.
Can I just make one comment as well? It's that I too am a mother of a child on the autism spectrum, so thank you.
Professor Thompson. Professor.
Is it possible to... Sorry, go ahead.
Look, we're just going to run out of time. So I think Professor Trembath just wanted to make a comment.
Yeah.
Just very quickly, 2 points. The first, I'd encourage the committee to keep in mind that it's we never know what experiences and perspectives people bring to their work and to this moment. Some people are more comfortable talking openly, and some people take a different approach. The second part is, when we present today, we're representing all of the people who contribute to these guidelines. We're not presenting in our own personal capacity. So just 2 points. Thank you.
Thanks.
Is it...
Someone else wanted to make...
possibly be able... Yeah, I just wanted to quickly speak to what Professor
who's speaking, please?
Sarah from the AMPA. So a point that I wanted to make with regards to what Cheryl has quite rightly pointed out, I think the biggest barrier to success of thriving kids is the fact that the community it is being designed for does not want it. And I think that, so as an advocate, my wheelhouse, so the main area in which I work as an individual advocate is in child protection advocacy. So I work with disabled parents of disabled children, primarily autistic parents of autistic children. What I see in my work is that when there is low community trust for a service, parents will avoid it. My biggest concern, actually, about thriving kids is that the world sort of moved on from the medical model, and this really does lean that way. And because our community does not want this and has been so clear that we do not want it, and even Guy from CIDA said that in their survey, families were so clear that they would prefer no service to a service that in their view causes harm or that does cause harm. So what I see, and I have a huge concern about this as President of AMPA, is that families will avoid services altogether for children if this goes ahead. I am very concerned about a generation of lost children who receive no services at all because they do not want to expose their children to services that they see as bad for them. The second point I wanted to make, which is in direct response to the Professor, yes, we are all appearing here as representatives of something. However, and I really want to impress this upon the committee, the greatest obligation that this committee has is to observe Australia's obligations under international law and under the UNCRPD. And General Comment number 7, 2018 from the UNCRPD committee is so clear in who should have precedence and hold the greatest weight when making decisions of policy and law. And it is so clear in saying that that should be disabled people and their representative organisations. So while we're all here in various capacities, the voices with the greatest weight should always be those of representative organisations that meet the standard laid out in Article 4.3.
Thank you. Ali France, you wanted to ask a question. Ali? We might go to you, Alice, first.
Thank you, Chair.
Can you hear me, Chair? Sorry.
Yeah, we can hear you now.
Sorry.
No, it's just hard to see all the hands up against the backgrounds. I can't see them all.
Apologies. Firstly, my name's Ailey France. I am the member for Dixon. I'm also a neurodiverse disabled woman and a member of this committee. I just want to thank you all for coming to give evidence today. It's really incredibly important and we all appreciate it. I also am the mum of two children who had developmental delays, and so I have a long history of lived experience myself and with my children. I'm obviously not here in my own capacity, but I represent a community, and that's who I'm speaking on behalf of today, but I come with a lens of a long history of lived experience. My community, but particularly in Queensland, and I just want to highlight perhaps that there are differences in different communities, particularly in Tasmania, which you guys have talked about today. In Queensland, we do have a decade-long a generation of lost children who live in Indigenous communities and regional and remote communities who have not been able to get access to services and the supports that they need, and who desperately want change to the current system. I mean, they're desperate. The state's pulled out of providing services and there's just a hodgepodge, I think, around the country, but particularly in states like Queensland, perhaps the Northern Territory and also WA, whereby you can have the biggest package on earth, but there is literally nowhere to spend it. And what the NDIS has done has distorted the provision of services in the sense that they are very much focused in the coastline and in large regional cities or towns, and also the cities that we have here. So the feedback from my community and what I have seen as an advocate, a disability advocate over many, many years, is that the current system is not working and we need to see change. And that's what we're trying to address at the moment. I also want to point out that this inquiry is not just about autism. It is about developmental delays. And for children that won't get onto the NDIS, but deserve the supports that deserve support, just like the kids that do end up on the NDIS. My question today for particularly those that have pointed out that they don't want the system to change, I know from my community that they absolutely do want the system to change. I see lots of people who have been advocating for, with the states now having pulled out, they want to see clinics in their local, regional and rural towns. They want to have access within their communities. They don't want to have to travel. So I just want to ask, I'm really focused on solutions here. The system obviously is working for some people, but it's really not working for others, not working for a lot of families, I think, in large states. So what do you see as the solution, and particularly for those people who are against any changes? Because I don't think my community will accept that. Thank you.
I'm happy to speak to that. I firstly want to just ask, and I think it's a really important point of order, I just wanted to clarify that members of the committee are not giving evidence, and that is quite an important procedural point.
Sorry, what did you say? And can you state your name, please?
So, Sarah from the AMPA. So I just wanted to make the procedural point that it's pretty unusual in a hearing for members of the committee to essentially give evidence about their communities. That's really our role. So to speak to the point of not wanting any change, I don't think that's an accurate reflection at all of what anyone here.
So really quiet.
That is? Oh, sorry. I think Nicole is not muted.
Oh, yeah, sorry, I pressed the wrong button.
Yeah, sorry. I thought you were speaking to me, Nicole. So, no, absolutely. It is not the AMPA's position that we don't want any change whatsoever. We would love to see a lot of change. I think that in terms of what we would love to see, we would like to see expansion of the NDIS, expansion of providers. We need to see way more service provision in areas like the one that Ali has spoken about. Myself, I live in a regional area and I grew up in a regional/remote area, and I see what happens in communities where there is just no services. That has to change. I think we need to see the expansion of service provision that we know to be excellent and of very high quality. Allied Health has been an incredible asset to my own child's life, to my life, to the life of his peers. It's hard. It's really hard. Like currently we're in a position here in Blue Mountains where, you know, he has funding for OT, but there are no OTs like anywhere to be found at the moment that don't have an enormous wait list. Moving back to a block funding model will not necessarily resolve that issue. And I think we have some big problems in that the states don't have a ready workforce, they don't have the infrastructure that's needed. That's a really enormous barrier. But I think one of the biggest issues is that block funding just does not provide the individualised, tailored support that is the right of these children. So whatever solution we come up with, and we do need way more service provision for every child, whatever happens, it must be individualised and it must comply with the UN CRPD. Thriving Kids and what's suggested under Thriving Kids does not. So whatever we do has to follow international law and be adequate to needs. And I would agree absolutely that rural and remote areas are massively underserviced and that has to be addressed. I don't think Thriving Kids is the answer to that.
Right, Alice, you have...
Yeah. Can I jump in on that question just really quickly? Sorry.
No, look, we don't have time. Alice has a question.
Thank you.
Yeah.
Excuse me, Chair. This is actually directly relevant to the question that was asked. And with all due respect, Ali made a statement within her question that directly relates to our community in Tasmania and made assertions about our community that should be addressed.
Yeah, that's fine. You could put it on notice and send it to us. Ms Jordan Baird has a question.
Thank you all for appearing here today. It's really important that your voices are heard, so thank you. We really appreciate your time and all the advocacy work you do in our community, so we're forever grateful, so thank you. I think we've heard from a number of you today, as well as over the last few weeks and months of our committee, the genuine need for co-design, which we're hearing again in this forum today. My question is to all witnesses, and maybe one of you could speak on behalf of others. How do you believe the Thriving Kids program can support young people in a neuro-affirming, trauma-informed and culturally sensitive way? And do you have any sort of specific recommendations that could ensure this?
I'm happy to...
This is something that I'm happy to address. Nicole Moran from the Regional Autistic Engagement Network, and I believe that this does actually also go into the previous question. So currently, under the current way that Thriving Kids is being proposed, it will disproportionately impact rural and regional communities. And we know that there is a significant number of people who are neurodivergent that have for many, many years not known that they're neurodivergent. And, you know, there are plenty of studies that show that. So, for instance, there's a research article called Autism's Missing Girls that was released earlier this year that highlights the disproportionate impact of bias that has resulted in generations of women not being able to access a diagnosis. And it's not that our community doesn't want change. We want change. However, the change needs to be appropriate and it needs to be co-designed. And under the way that Thriving Kids is currently being approached, our community won't support it because it has been done without our community. So what needs to happen...
Sorry to cut you off, Ms Moran, but my question is, what does that change look like?
What does that change look like? Well, what you need to first do is go and talk to the community. So it's all well and good to say, we want to make you a program, and we're going to put all these ideas out there about what that program is going to look like before anything's already been announced. So, for instance, in the address that Mark Butler gave, he already had provided, at the press conference, he provided an idea of how it would be modelled and such, and that it would be block funded. And we know that by evidence that, and I am actually looking at research that says that funding from Australian and international studies show that self-directed, individualised funding packages can result in better outcomes compared to block-funded services, which is what is proposed with Thriving Kids.
I think also Ms Mangan wanted to make a comment as well. So.
I do. And it's to that point of co-design and the importance of including everyone in that process. We believe that certainly success of Thriving Kids is going to depend on co-design. But co-design is not working with one single stakeholder and one single group, as critically important as it is. We believe that co-design is about working very, very importantly with autistic individuals as well as, and diverse autistic individuals from everywhere and all kinds of backgrounds and intersectionality, their families, but also service providers and educators and health professionals who are on the ground, and grounding those solutions in the latest evidence and what we know works from best practice. So it's not just about working with one particular community. It's how do we bring those perspectives together to come up with a solution that is actually working on the ground.
Yeah. Very true.
It's Cheryl Holt here. I'd really like to follow on and provide some tangible responses to the question.
Well, look, we have run out of time. We've run well over time. Everyone has had a very fair chance to express their points of view. If there is anything you would like to send to us, we're happy to receive it by email. But I am going to have to conclude this session now because we've got lots of people who've been waiting very patiently, and I do apologise for the fact that we've run so much over time. I think we have heard from a lot of people, and I thank you all for your attendance here today. If you've been asked to provide any additional information, could you please forward it to the Secretariat by the 24th of November 2025. You'll be sent a copy of the transcript of your evidence and we'll have an opportunity to request any corrections to transcription errors. And once again, thank you all for your time. It has actually been very valuable. And to the people who are waiting to appear, I do apologise so much for keeping you waiting so long.
Thank you, Chair.
But we will extend the next session as well into the lunch break. So thank you so much for coming along today. Thank you.
Thank you. Thanks to everyone for their patience and latitude.
Thanks. Phew. Sorry about that. We might just suspend for 5 minutes. and Disability Thriving Kids Initiative, and I'd like to call representatives of Gaia Dewey and Muwachi Health Aboriginal Corporation to give evidence today, together with if I can find the list. Snake, Miss Catherine Little, to give evidence today. Hi. And I'll just briefly go through the bottom line. For the Hansard record, before giving evidence, could you please state your full names and capacity in which you appear before the committee? Although the committee doesn't require you to give evidence under oath, I should advise you that this hearing is a legal proceeding of the Parliament and therefore has the same standing as proceedings of the respective houses. The giving of false or misleading evidence is a serious matter and may be regarded as a contempt of Parliament. The evidence given today will be recorded by Hansard and attracts parliamentary privilege. To assist with the transcription of the public hearing, it would be appreciated if you could please state your name before responding to each question. I would now like to invite you to make a brief opening statement before we proceed to discussion. But if you could give us your name and the capacity in which you appear first, that'd be good. So, Ms. Little.
Hello, Catherine Little. I am the CEO of Snake National Voice for Our Children. We are the peak body for the development, wellbeing and safety of Aboriginal and Torres Strait Islander children. We are the biggest backbone service provider in the country, and those backbone service provisions not only bring forward the voices of our children but see 150 organisations every single day supported to ensure that they are wrapping around our children and families, on top of the hundreds of child and family services which include our early years services, our schools, our RTOs and of course our broader child wellbeing services that make up the incredible architecture that is the Aboriginal and Torres Strait Islander community-controlled service system. What an incredible opportunity to be here on the lands of the Ngunnawal and Ngambri people, and I feel like while we're in a Senate hearing room, I'm actually sitting in the middle of a perfect storm, and all around us I see this incredible moment of reform and all of these reforms finally coming together. And my gut is, if we get it right, that perfect storm will be a Medicare moment that brings generational change for our children. Also really clear, if we get it wrong, these incredible reforms that everyone has been working on may lay shattered in pieces. So the opportunity to come in and help it, we're up for the challenge, and we recognise how important it is to be given the opportunity to talk to your mob today. So you'd know this already, I'm sure, and that is that Aboriginal and Torres Strait Islander children are disproportionately represented in the rates of vulnerability and disability. But we see this moment as an opportunity to reverse that, and that Aboriginal and Torres Strait Islander children might be for the first time disproportionately helped by a reform like this one. What we know is that our children too often enter our school systems undetected or misidentified with developmental challenges and vulnerabilities. Those vulnerabilities persist throughout their lives, and we know all too well that if children start school with a learning gap, that gap gets bigger throughout their entire life journey. We also know that the first time our children often are picked up as needing a little bit of extra support is when they hit the juvenile justice systems. We know that often our families don't look for support because of the intersection with child protection systems. We know that they are misrepresented. We know that they are overanalysed. We know that they suffer from over-surveillance, and that those things that could have been solved in early childhood are often disregarded and left in tatters. We know that it is shameful that in Australia at this point in time, if we use the Northern Territory for example, in 2021, 77% of the children in juvenile detention had need for cognitive or developmental supports. None of them had been identified as needing those supports despite having contact with several systems by the time they hit the child protection system. And there they are, locked up in cells. The Thriving Kids initiative, we think, will change this because it doesn't have to look like this. We know that the Thriving Kids initiative has the opportunity to work through shared decision making and in partnership with us and our communities to address these failures. It is an incredible opportunity to build on the strengths of the national agreement, that agreement that roots program design and policy design in shared decision making that listens to the voices of the communities and families on the ground. We know that it has incredible architecture to support it, which includes things like the Early Childhood Policy Partnership, which brings together health and Gaia Dewey and FPDN, and it brings together all of the peak bodies that are responsible for looking after children. It's the body that looks at things like what the ACO funding model should be, what the child investment body should be, what this incredible opportunity to link into these incredible reforms should be. So when we look at what we're hoping for is that all of our children will thrive, that this moment will lead us to the opportunity to bring all of those circling storms together and ensure that we not only have thriving kids, but thriving ACOs that help lead what we understand as generational change. Thank you.
Thank you. And I like the multiple storms going together very well. Would anyone else like to make a brief comment? And I apologise for my pronunciation of the My Watch name too. Me Watch, My Watch, yeah.
Thank you very much, Chair. My name is Emily Osborne and I'm the NDIS Operations Manager at Me Watch Health Aboriginal Corporation.
Good.
I've been working at Me Watch since 2016 and I also come today as a person of lived experience. I am a carer for my sister who has a significant disability. I've lived and worked in the East Arnhem region for approximately 30 years. I'd like to acknowledge the traditional owners of the land I'm dialing in from, Garramilla or Darwin in the Northern Territory, the Larrakia people. I pay my respects to the elders past, present and emerging. I'd also extend that acknowledgement to the region I'm representing today, which is the Yolngu people of East Arnhem Land and any First Nations people here today. As I mentioned, I'm representing Me Watch Health Aboriginal Corporation, and we are an art show who has been providing comprehensive primary and population health services in North East Arnhem Land since 1992. The East Arnhem population is approximately 15,000 people, and Me Watch maintain 8 clinics across those 7 locations. Art shows are key to implementing new and confusing government concepts like Thriving Kids. And for decades, we've adapted these complex systems to our ways of working, which are accessible and digestible for Yolngu. Art shows support the lifespan of community, and we've built innate trust within our respective regions. With our endorsement, much like Catherine, who spoke before me, initiatives like Thriving Kids can work when they have appropriate block funding to support the safe and sustainable rollout of these programs. We can make meaningful change to some of the most vulnerable Australians. At Me Watch, we're a remote community connector partner. We're funded by the NDIA to provide cultural brokerage between NDIS participants, the NDIA and their vital supports. We also provide support coordination for people from East Arnhem and have successfully been providing these services since 2017. We also have a small allied health service, which is currently providing dietetic intervention across the region. A key message from our remote community connectors is that the NDIS is difficult to explain and interpret in a way that our mob can understand. They've described their role within the NDIS landscape as Marnya Ma Thirin Miri, which translates to taking the weight off participants, but also going home and feeling fulfilled and like they've had an impact to their community. Participants can share their worries with our remote community connectors and offload their social, health and disability needs to our team, who then carry that weight. And whilst it's taxing, it gives meaning and fulfilment. As part of our remote community connector role, we support with NDIS access as well. And that team is led by an Aboriginal health practitioner and a nurse who submitted 15, just in the last quarter, 15 successful NDIS access requests for children aged 0 to 9, and she has an ongoing 100% success rate in this space. There are numerous children sitting on wait lists waiting for diagnosis or assessment to support with NDIS access, and we're really hoping that Thriving Kids is a way that we can mitigate those wait lists and fast track those NDIS access or other access pathways.
Good. We might open it up to questions if we can. Alice, do you have any questions?
Yeah, thank you, Chair, and thank you so much for appearing before the committee today. It's great to have you here. My name's Alice. I'm the member for Gorton, so I represent a community in Melbourne's western suburbs. I just have a question around the culturally safe screening tools that you mentioned in the MeWatch submission. Could you tell us a little bit about the sort of gap that we're currently seeing there and how it could potentially be addressed through the Thriving Kids initiative?
Sure. At the moment, there are a few, very few culturally safe screening tools that we use across Australia. And really it comes down to the team that are there supporting the screening tool themselves. So in our model, we use obviously Aboriginal health practitioners and community workers, or in our case, remote community connectors to support with those screening pathways. And I think that from our perspective, and I'm not a clinician, so I can't speak to sort of the effectiveness of those tools themselves, but it's without having the Archo model and having that wraparound team that is supporting that process that make it work. And I think there are so many different screening tools around, and there's so many different screening tools that need to be used with respective disabilities or age demographics that it is really challenging to make them all accessible and adaptable within language contexts around Australia. So I think the key here is that Archo model and having a team to support the implementation of that screening tool, rather than potentially adapting that to all of our very complex regions.
Thank you, that's great. I've just got one more question if we've got time, Chair. It's just around, there's a number of examples of some really wonderful Koori Kids support playgroups that I'm aware of, and I'm sure the community is as well. I was wondering if you could talk to, you know, how those programs could, you know, we could use those sort of, you know, models that we're seeing that are working really well at the moment, and sort of roll them out sort of more further abroad through an initiative like Thriving Kids.
Would you like me to lean on that one?
Yeah, thank you, Ms. Lewis.
Awesome, no worries. Okay, so I've touched on it very briefly.
Sorry, Catherine, it's Rachel here. Sorry to interrupt you, but we just wanted Helen and I wanted to give our statement.
Oh, sorry, I didn't realise.
Yeah, sorry.
It's okay.
Sorry, Catherine.
It's all good, Rach.
Yeah.
Might let you give your statement then first. Sorry, didn't see your hand up.
Yeah, no worries. So I'm Rachel Fisher, I'm a Yuin woman and the CEO of Gay and Dewey, and I'll let Helen introduce herself.
Hello everyone, I'm Helen Murray, Professor of Child and Adolescent Psychiatry in Perth in Boorloo, and the chairperson of Gay and Dewey, but I'll let Rachel speak because she's on video.
Thanks, Helen. So I'd just like to acknowledge the lands that we're on today. I'm on the lands of the Ngunnawal and Ngambri people, and pay respects to elders past, present and emerging. So Gay Do is the national peak leadership body for Aboriginal and Torres Strait Islander social emotional wellbeing, mental health and suicide prevention. We operate primarily in the policy space. We recently developed the National Aboriginal and Torres Strait Islander Suicide Prevention Strategy, and we're the lead peak and co-chair for the Social Emotional Wellbeing Policy Partnership. Thriving Kids represents a period of significant structural reform to early childhood developmental and disability support. This is amplified by the shifting of the disability and NDIS early intervention to health and ageing portfolio, and the Productivities Commission's inquiry report into the National Mental Health and Suicide Prevention Agreement, with the proposed Mental Health Declaration and Social Emotional Wellbeing Schedule proposed to be governed by the SUPOS partnership. Together, these reforms create a rare opportunity to build a culturally safe, integrated national system that supports Aboriginal and Torres Strait Islander children across developmental, psychosocial, health and social emotional wellbeing pathways. These reforms cannot be developed in silos, as they must be culturally grounded and grounded in Aboriginal and Torres Strait Islander concepts of healing and social emotional wellbeing. Thriving Kids and any other initiative put forward by the Commonwealth must be anchored in the Gaydewey Proud Spirit Declaration, support cultural safety, governance, workforce capability and system-wide alignment. Gaydewey is committed to partnering with government to design a strong culturally grounded systems that ensure every Aboriginal and Torres Strait Islander child can thrive. I might hand over to Helen to say a few words.
Thank you, Rachel. Look, one of the issues that we have in regard to social emotional wellbeing and mental health in early childhood is that there's not a lot of expertise and understanding in the system about emotional development. While we talk about psychosocial disability, I think it's sort of the poor cousin to the rest of the sort of developmental disability spectrum. And we focus on sort of physical and other kind of developmental disabilities and fail to sort of really take on the full understanding of poor emotional and relationship development in early childhood. Yet we know that if you look at the data on mental health and the origins of the mental health problems that we see later in life, it all stems back to early childhood, and yet that's where we put the least effort or the least resources. We also know that, and in fact, just this goes to the first question that was asked also of the panel, if we look at screening tools and culturally valid screening tools, there's very few, especially in the early childhood developmental area and particularly in regard to any sort of mental health issues. So while there's been a lot of work trying to develop culturally grounded tools, most of our screening tools are actually adapted, which doesn't necessarily mean they're the best possible tools that we could have. And certainly the Australian Institute of Health and Welfare have been doing a lot of work on this. But we still need to look at whether these tools are actually going to give us the best result in terms of what we're looking for. I also think that for young children, we consider that psychosocial disability sometimes just looks at the behavioural aspects of children and fails to understand the actual emotional and psychiatric issues that underlie some of the problems that children have in the early years. So I might just leave it there because I know that we're short for time and I know that we've been running over, but thank you for allowing us to present today.
That's my fault, I apologise. So we'll give you as much time as you need, so don't worry.
Thank you.
Thank you.
Back to you, Rachel, about the system.
Yeah.
What was that?
Sorry. I'm just going to continue on. So Thriving Kids cannot sit as a standalone program. It needs to be embedded within broader national reform architecture so Aboriginal and Torres Strait Islander children are not pushed between disconnected systems. The initiative must be formally integrated in the new National Mental Health and Suicide Prevention Agreement. This would provide clear funding responsibility, shared accountability, ensure that early childhood developmental and psychosocial pathways are recognised as part of the National Mental Health System for children. The Productivity Commission's inquiry report highlights gaps in psychosocial supports outside the NDIS, fragmentation across portfolios, and the need for stronger child and youth mental health architecture. Thriving Kids directly speaks to these gaps. However, it also needs to sit within the implementation of foundational supports. Thriving Kids is effectively the children's foundational support pathway, and embedding it here ensures continuity as children move from early childhood into youth and adult psychosocial support systems. Thriving Kids should also be anchored within closer gap priority reforms, particularly shared decision-making, strengthening community-controlled sector, transforming mainstream systems, and the child developmental and suicide prevention targets. Embedding Thriving Kids across these reforms creates a single connected pathway as it ensures consistency in cultural safety, workforce assessment, navigation, and service design. It avoids the fragmentation that has failed our children for far too long. This is how Thriving Kids is able to become a durable system-wide reform rather than another short-term program. It's an opportunity to embed cultural safety and Aboriginal and Torres Strait Islander governance to incorporate the principles of social emotional wellbeing to flow into implementation, not sit on the margins as an add-on. So we have some asks, I guess, that we'd like the committee to consider. So the Gaydewey Proud Spirit Declaration already exists and its implementation plan is committed to by governments. It's time to deliver on implementation of a nationally endorsed 10-year roadmap for cultural safety, system design, governance, workforce and social emotional wellbeing aligned service models. And we're asking the committee to make the declaration explicit design requirement of Thriving Kids. Also ensure that Thriving Kids is culturally safe, strength-based and inclusive for Aboriginal and Torres Strait Islander children. More broadly, we're calling for governments to embed nationally consistent cultural safety standards across the mental health system, and that would include this, ensuring they are reflected in policy, practice, funding, accountability and leadership. Ensure that the assessment and developmental screening tools used within Thriving Kids are culturally validated, strengths-based and safe for Aboriginal and Torres Strait Islander children. As we know, current Western assessment tools marginalise our children and lead to misidentification, underidentification and pathologising cultural differences. Cultural validation must be a design requirement. Ensuring Thriving Kids embeds genuine Aboriginal and Torres Strait Islander co-design, shared power and relational approaches. Ensuring that Thriving Kids is designed and delivered in ways that support the social and emotional well-being of Aboriginal and Torres Strait Islander children and tailored to local needs. Ensure that the workforce delivering Thriving Kids has access to adequate funding to build capability to meet the needs of Aboriginal and Torres Strait Islander children who access it. This includes sustained and long-term investment in Aboriginal and Torres Strait Islander workforce, particularly allied health and social and emotional well-being workforce pathways and the roles that walk alongside families every day. And ensuring Thriving Kids is built on supports for families and kin, not just the child. So Thriving Kids must have supports that strengthen the capacity of well-being of parents, carers and kin, and to include coaching, navigation support, respite, peer supports and social emotional well-being supports. Thank you.
Can I ask you, just so it's top of our inbox, you could send your list of asks to the committee, just so we have that front of mind.
Thank you, Chair. Could I ask Ms Liddell to respond to my question just around the models of career kids supported playgroups? Thank you.
Look, the playgroups is a fantastic example, and really it brings together a lot of the cyclones and storms that Rachel was speaking to. And I should really say it because I noticed it was asked for. I am neurodiverse. I do have ADHD, and I also have an autistic child and a granddaughter with ADHD. Clearly runs in the family, and it is our superpower, and it is what makes us able to come into rooms like this one. My early childhood, I was completely nonverbal until I was nearly 4. And it just happened that my mum had a best friend who was a speech pathologist that was able to work with me directly, and that was just luck, absolutely luck. So playgroups, wouldn't it be different? I wonder what I would have done if I'd been picked up that early. Playgroups currently, like all of our early learning services and those that are shaped by Aboriginal Torres Strait Islander people, put children first. And again, it's why I don't identify those other things that are very special about me when I come into a room, because we see our children as our children. We don't make those differentiations. Those services are built around what their communities need for their communities, and they respond to their communities, and they create a really safe place that is networked into where there might be a health service available, where there might be a mental health service available, where there might be a food bank available, those sorts of things, because they're often in low socioeconomic areas where a bit of extra help is required. So under the current reforms, and we heard Rachel talk to the policy partnership. The policy partnership that I co-chair is the Early Childhood Care and Development Policy Partnership. That currently has under consideration the ACCO funding model. The ACCO funding model is how those playgroups would be able to hook into Thriving Kids, because it basically says we need block funding, but that block funding needs to be relational, and that means you adapt it as you go based on what children might be in the service at any point in time and what you might need. But it also says, how do we outlay this support so that the supports follow you from playgroup into an early childhood setting, into a preschool setting, into an early school, primary school setting. So a couple of the things that it might be able to hook into would be something like Connected Beginnings, which is already on the ground in more than 50 sites. Connected Beginnings is a very cheap model, but it effectively provides the backbone that says, okay, we've picked up that there is a child that needs a little bit of extra support. Now, again, this isn't a massive NDIS plan. This is something different. This is the one that says mum and dad might need a bit of help to give you a couple of tools when baby's laying on the ground in a supermarket. How do you talk your child through that sort of moment in time? How do you help your babies go to sleep, when their brains are so active, so that they're so tired they can't come to school and engage the next morning. So I think, again, when I talk about where those circling cyclones are, they are sitting in the reform space, and there is a need to get all of the information from these different reforms, put it in a space that is able to move. And again, when we talk about the national agreement, we think that is the architecture that pulls it all together, because effectively it brings states and territories together alongside Commonwealth departments and their representatives, as well as the specialists in each of those areas that then work with their communities on the ground to inform what it could look like. And if we got really, really clever and we started looking at how we make that architecture move at speed, you'd then bring together the ministers that were relevant for the intersecting portfolios, so that as you made recommendations for implementation, you were following that train of thought all the way down to genuine practice that which shared back up again through shared decision making. That was a long way of saying playgroups are awesome and an awesome starting point. The opportunity to make them hook in is right now. Thank you.
Thanks, Ms. Liddell.
If I could just add a comment to the playgroup discussion, I think as well. So I'm Helen Milroy. I'm a child psychiatrist. I've worked for many, many decades in the early childhood area in terms of psychiatry. And also I work in the trauma space. And as you may know from my profile, I was also on the Royal Commission for Institutional Responses to Child Sexual Abuse for 5 years as a commissioner. In regard to the playgroup, it's a very, very good model of how you build in psychosocial and emotional supports for children and also for families by encouraging early creative play and imagination, which helps to build the social and emotional wellbeing of children in the early years. But the issue is we leave the mental health expertise until too late. And what we need to be able to do is bring mental health expertise into the forefront of helping to design and understand what's required from that emotional perspective and that mental health perspective in terms of development. So I think we spend a lot of time talking about early education and sort of development of disability in terms of speech and language and physical abilities and all of those sorts of things. But we must bring in the mental health expertise early. We shouldn't be leaving it until children become much more unwell, or it's later on down the track, or they're suicidal at 8, and then you bring in mental health expertise. It's got to be upfront. I notice on the advisory group for Thriving Kids, there is no mental health expertise. So we need to start building this in now. Otherwise, we're still going to be ending up using mental health service to be the ambulance at the bottom of the cliff, so to speak. So this really has to be paid attention to now. So we can build that in. I've done a lot of work with KindyLinks and other sorts of early childhood organisations where if you just give some of the workers that expertise into understanding when they need to take the child further, what are the signs that they need to look for those early indicators of child mental health problems going wrong. What we don't understand, I think, very well in children is children can look okay, but they're not okay. And how do we then gain that expertise into looking at a child's internal world and their mental health side of it when we don't have that expertise available to us. So I think that's something we really do need to build into the workforce. It's the thing that we get requested the most from schools, from early educators, from KindyLinks, from the early daycare centres, is, we don't have the mental health expertise. We don't know what we're looking for.
It's Mike Freeland here, the chair of the committee. Just for your interest, Frank Oberclade, who is co-chairing the committee that's going to be overlooking all this, has mentioned bringing mental health support in early in the Thriving Kids initiative as well. And he's done a fair bit.
Yeah, I've worked with Frank Oberclade for quite a long time. We've been on committees together. I think we did this the national policy in the child mental health space together as well. And look, it's absolutely essential. We've just got to bring it in early. Otherwise, we're not getting that sort of side of it.
Yeah. No,
and let's face it, if we think about Aboriginal kids in particular, the ones that end up in juvenile justice, the ones that we're all complaining about now, we see in the media in terms of crime, if we got them at 5 or 6 or 4 or 3, they wouldn't be there now in that other end of the spectrum.
Well, many of them wouldn't be. You're quite right. And we don't need any more studies to tell us that, unfortunately, they are high risk. But it's a matter of getting those supports early. We agree.
If I could add a little bit to that, the pieces that Auntie Helen was speaking to, it is absolutely true, and it is one of the reasons that the architecture of the National Agreement is so sophisticated, because it says you can't move one without the other. You have to have all the relevant expertise in the room, because then you get the 360. But it twigged in my brain some of the other incredible pieces that are happening at this moment in time that could be complementary and built in or built on, and those things like the FAC reform that bring in the supports for families so that they might be able to access mental health services a bit earlier and bring those supports in earlier, and the Aboriginal Child and Family Investment Strategy that's sitting there waiting for the dollars that will inform it, which could hook into both Thriving Kids and also the FAC activity reform. So there is like a cyclone of reforms available now, just saying bring us all together and let's create this generational change.
Good. Any other questions?
No further questions. Thank you for your contributions.
Ali, do you have any questions? Okay. Do we have anyone else online? I don't think so.
We have Ms. Stanley.
Anne Stanley, do you have any questions? Not yet. I've got a few more. Workforce is a huge issue, and I think, you know, across the health but also child development spectrum as well. And it is very difficult to get health workforce into some communities. Should we be training more Aboriginal health workers in the child development area? Should we be looking to that as expanding access?
It's broader than that. So, and if I could give a Northern Territory example, easier for me to speak to the Northern Territory because that's where I'm from. So in the Northern Territory, we often have children who are removed from their families before the age of 6 because we can't get the support workers into those areas in order to be able to support the child and their families. So in they go to child protection, never to be reunited again, when in actual fact, they were the workers. So it's broader. It is saying, yes, let's map the workforce needs for the sectors. There are, again, incredible reforms coming through in the economic development space under the policy partnerships of the National Agreement, as well as the Vet and Skills Policy Partnership that is looking at tracking and mapping what there should be, as well as the Data Policy Partnership that will enable those services and each of the sectors to start really getting an understanding of what workers are required, what resources we need to ensure that the workers are actually getting the supports that they need to be successful, that we're simultaneously using those incredible priority reforms to ensure that Aboriginal and Torres Strait Islander people are able to design the training in a way that is fit and relevant for their environments, as well as picking up their incredible expertise in understanding how to raise children, because a lot of what you see in the early education care settings for our services is based on that 60 years of observation and care, and that is one of the hardest things to get recognised, and yet it is, again, obvious in the AECD data where there is an early years service that is operated by Aboriginal people. We get different results. Similarly, the Connected Beginnings, we get different results. So there's this incredible expertise that needs to be built on, and then we need to then map the corresponding jobs. So short answer is yes. Long answer is yes, but a lot more work that recognises the different sectors that are available and the different expertise and this moment in time that we can build on to create the right jobs, the new jobs as designed by their families and their communities, because they're the ones that are fit for purpose. What an incredible change moment that could be. Yeah. There are jobs out there waiting to be designed.
Yeah. Now, the Health Minister has spoken.
If I could just add to the workforce
sure.
Piece as well, and Catherine has already given a very good overview, but one of the things that I still struggle with enormously, particularly with our remote communities, and I know that we're never ever going to get the level of expertise that we want in some of those remote communities, but we often have something like over 100 visiting services, and the visiting services do not link up. And they do not then provide the coverage that could actually cover off on an enormous number of different tasks in a community if they actually just coordinated their approach, and so that they join forces and actually work together. And this is what we want to see. I mean, essentially some of our remote communities, I mean, they're collectivist societies. So if our services that are visiting have that sort of collectivist mentality, then maybe we would have a much better workforce design, but we don't. Well, and I think a lot of communities end up spending a lot of time trying to meet the needs of visiting services instead of understanding if the visiting services had a collectivist approach, they could actually meet the needs of the community.
I completely agree. I mean, one of the reasons the art shows have been so successful is because they do tend to bring people together. And
they do. But the trouble with the art shows is that they represent a lot of communities, but they don't cover all of our communities. Yeah. And even with the art show, you still then have, an extra 100 visiting services alongside them, and it becomes too confusing for communities. I also think that if we aim for the base level support jobs for some of our community members who don't want to go on and have sort of higher level, university training, they've got to be supported by a tiered approach so that we have expertise going back out, so that the work at the front line can gain expertise and support by people who have a lot of expertise at the back end, but it's there and it's available and it's brought up sort of more front and centre rather than waiting for this tiered approach for people to move up the line before they actually get some, capacity to change what they're doing.
Sure. Now, I've got a question for all of you, and please feel free to answer. The Health Minister has spoken about a child development check at 3 or 4 that will be available to check on kids' development across the country, modelled a little bit on the Aboriginal Children's Health Check. I think it's item number 512. Can I ask how successful that's been? And should we be looking to replicate that model?
That sits on the Medicare number.
Medicare.
Look, if you could attach a Medicare number to a child, and I know it's not Medicare, but yes, if we could hook some of these things into Medicare or a Medicare type system, it absolutely changes the way we can attach funding to a child so that it follows a child through its journey. Has it been successful? It does pick things up. It's like any developmental tool. There is no such thing as uniform because all of our communities are, when we talk about the Aboriginal perspective, all of our communities are unique and all of them are saying that they need to be culturally responsive, culturally designed and culturally adaptive. So it's like when we say universal doesn't mean uniform. It's building those sorts of things into the architecture as well, but also recognising that it's broader than just health. I think we've heard that a few times. For thriving kids to work, it's the ability to coordinate all of the architecture that sits around our children, because it's not like one arm sits over there and one leg sits over there. We need to find a way that brings all of the relevant ministers and portfolios together. This is the moment to hook them in. How do we make it? How do we give it longevity? Hooking it into something like that changes longevity and certainly ensures that what we're doing, what we need to do, and that is supporting children in their natural environments. We don't want to over-medicalise this because this isn't a medical response. So yes, if there's the architecture there that could be replicated or nuanced, but we don't want to medicalise children on this. This is about giving families the support they need in an environment that is natural, that enables them to be the owners of their journey, wherever that journey might be and wherever they might be situated.
Good, thanks.
If I could also answer that question.
Sure.
I think at 3 or 4, it's a little bit late, to be honest. If you look at emotional development, then we want to make sure that the first year we have very good attachment with the parents or the caregivers who are looking after that child. We want to make sure that the child is making all the appropriate noises and is developing socially and emotionally in the right way. Then if we look at 2, you've got different aspects. You've got, greater emphasis on language. But provided you've got all of these other developmental checkpoints along the way, a 3 or 4-year-old check works well. But if you don't have all of those other developmental checkpoints along the way, that's too late. And that's too late for everybody, not just Aboriginal kids.
Yeah, no, I'm a strong believer in the first 1,000 days, so...
Yeah, absolutely. You've got to be looking at development as a fluid state, and you've got to make sure that you see it all come into life I mean, you can intervene at 3. That's great, but you're already becoming too late for some of the issues that may have already become complicated by that point in time.
Yep, great.
If I could please add, Chair, at MeWatch we support the implementation of the MESH program, the Maternal Early Childhood Sustained Home Visiting Program in the Northern Territory, and we've adapted that program to be called Yothul Mulka in our region, and that has been a huge improvement in the numbers of those assessments being completed within our community. So it's taking the service to the people rather than expecting them to come into the clinics, as sometimes that is unattainable for a lot of our young people and young mums. So that's been a way that we've been able to address some of those barriers for engagement within those assessments.
Do you have any details of that you could send through to us?
Absolutely.
That would be good.
And look, just in regard to that, if you look at the home visiting services for the maternal and child health for the Aboriginal ones that have been developed, if you have an Aboriginal service that supports the perinatal, health and mental health, then we've seen a halving of preterm births. We've seen improvement in, attachment and all of those other things. Yeah, birth weight. We've seen a lessening of child protection referral. So, I think that those, Aboriginal designed and owned and clinically and culturally driven services make a massive difference, but they're still piecemeal. They're not all over the country. I think we could get a basic model that looks at what's required in those first, in that perinatal period, and that would make a massive difference, because if we get good births and good birth weights, then we're already halfway there.
Yeah, and maybe add breastfeeding.
Yeah. Well, Aboriginal women tend to breastfeed anyway, so it's not so much of an issue. But we can certainly make sure that it's done, well and effectively, and continue perhaps longer than what currently women are doing.
Great. Good. I think Sam Birrell's on the line. Do you have any questions, Sam?
No, thank you, Chair.
Any other questions?
I think another comment to the workforce question from MeWatch Health here. So we've got a model that is working really well around training of our community workers in our communities, where the funding is pooled to the service area. So, for example, public health, allied health. The community workers are trained on sort of all of those funding streams that that support that team. And then that way, some of those challenges around workforce attendance and skills development is reduced in those communities, because, it doesn't matter who comes to work that day, they are skilled to be able to deliver on the particular service that they're providing. So I think the core key message for me is that that funding model for art shows, where we're able to pool sort of various different funding streams and be able to offer the one-stop shop for participants, really eases that burden from our community. They need to be able to come in, disclose what their issue or their support need is, and that they're able to get that service, and it doesn't matter which funding stream is rolling over or what's happening. They're able to get that service regardless.
Fantastic. Thank
If I could also just make an overall comment as well. We've been doing a lot of research in cultural safety, and the issue that comes up all the time is trust.
Yep.
And if there isn't the trust in the cultural safety of the services, you're not going to get young parents coming to the services because of fear of child removal. And it's an ongoing fear, and it's a very real fear. And given the data that we have, we know that, there's still far too many removals of Aboriginal children. Now, trust has to be part of, it has to be looked at differently, because I think we assume that there's trust, but there really isn't. And what we failed to do in cultural safety is we failed to actually incorporate cultural governance in systems. So while we might have some Aboriginal workers, we might have some Aboriginal models, we don't have the Aboriginal governance or the cultural governance in the actual systems. So we might have cultural governance in the ATROs, but in the non-Aboriginal organisations, we do not have the cultural governance present, and we certainly don't have it in the mainstream clinical services.
No, you're absolutely right. We have the same problem in South West Sydney, and you can understand why people are scared of engagement with health services. Yeah.
Particularly if there's a mental health side to it as well, because of the additional stigma and other sorts of issues related to the sensitivity of some of the topics. But the parents aren't going to come for their own trauma and helping them deal with their children if they then have to disclose things that they think are going to put them at risk of child removal.
Yep.
So I do think the cultural governance piece is the one piece that we've completely missed in terms of cultural safety.
Yeah. Very good point.
Would you mind if I added to that just very quickly?
Sure.
I promise. So you often hear the COVID example, right? What the Aboriginal Community Controlled Services did to keep our children and families and communities safe during COVID. And often it gets explained as a health response, but in actual fact, to get a tipping point, it was a whole response. Every single sector fired simultaneously for the first time, able to operate in the way that was responsive for their families. So that is when you get a tipping point. This is a tipping point. This is the one that brings everybody together, that identifies where those places of natural settings are for our children and families. Obviously, I'm always going to talk very strongly for the early education and care sector and the child and family sector, because that is my sector, but my sector does not operate alone and is often found in health services. It's often found in legal services. It can be found in multiple services across the country that all enable themselves to come together. So if we're looking for something like that to land a Medicare moment, then it is something that enables everyone to start working simultaneously together. It is about working out where the accountability mechanisms are. We know, and I'll lean for Aboriginal people, the priority reforms in the National Agreement, what an extraordinary piece of architecture, backed in by the Productivity Commission's findings, not once but twice, to say, lean in, get it right, because in it there are accountability mechanisms that sit at Joint Council, which means National Cabinet has to respond. It brings their corresponding ministers together and puts in policy partnerships that report directly to those ministers. It brings together all of those people that are responsible for designing policies and programs and says, get on the ground, work with your communities and design in relationship with those communities. So I think when we talk about this incredible perfect storm, we are sitting in it. There are strategies everywhere. It'd be awesome to bring them all together and bring this one home for generational change, and for once talk about our children being disproportionately standing to gain from an initiative.
Well, in my electorate, which was out of southwestern Sydney, during COVID, our Aboriginal community did so much to keep our old people, our elders safe, that we had a much lower mortality and much lower hospitalisation rate by just
believe that.
The whole community coming
I think
together.
that was true. I think that was true with a lot of the ACHOs actually.
Yes.
They had that same data.
It was. So, yeah, it can be done.
It can.
Yeah. Good. I see Monique's just appeared. Monique, do you have any questions?
Sorry, Chair. No, I've just come back. I'm sorry I was late. I don't at this point. Thank you.
Well, you'll be pleased to know we're still running late, so we haven't had a lunch break yet. So, sorry. Anyway, to all our witnesses, thank you so much for your attendance here today. It's been very interesting and very useful. If you've been asked to provide any additional information, could you please forward it to the Secretariat by the 24th of November 2025, and I think you have. You'll be sent a copy of the transcript of your evidence and will have an opportunity to request corrections to any transcription errors. And once again, thanks very much. It's been very, very valuable to us. We will now suspend for 5 minutes or 10 minutes.
Thank you very much for the opportunity to speak.
Thank you. 10 minutes. We'll suspend for 10 minutes.
Thank you.
Convene this hearing of the House Standing Committee on Health, Aged Care and Disability of the Thriving Kids Initiative. And I'd like to call representatives of Plumtree, First Steps Count Incorporated, Good Start Early Education and Gowrie, Victoria, to give evidence today. Thank you very much for appearing. This hearing will be broadcast on the Parliament's website. Before giving evidence, could you please state your name and the capacity in which you appear? And before answering any questions, could you please state your name so that we know that for the Hansard record. Would anyone like to make an opening statement?
Yes,
so we have Miss... so I can't quite read it.
I'm Silvana from Plumtree Children's Services, Silvana Mamik. I'd like to make an opening statement.
Silvana Mamik. Thank you very much, Ms Mamik.
I will only take 2 minutes for my opening statement. Thank you for the opportunity to speak. I'm Silvana Mamik, the parent of a 35-year-old man with a disability, and I have been the CEO of Plumtree Children's Services, which is a non-for-profit child and family organisation based in Marrickville in Sydney's inner west, Marrickville also known as Midgeberry, acknowledging the traditional owners of the land and elders past and present. I've been the CEO there since my son was a very little boy. With that long view, I have seen many reforms, but one pattern is clear. The system relies almost entirely on professionals. Professionals are as one wing of a bird. A system cannot get off the ground without the second wing, trained and supported parent peer workers working alongside professionals in true partnership. Parent peer workers fill the gap families experience while waiting and finding their way through complex systems. They build parents' skills, confidence, strengthen connection and belonging, and help families recognise and build on their own and their child's strengths. This support exists already within some parent-led organisations. But Thriving Kids is the opportunity for the parent peer workforce to be woven into early childhood, family and broader support systems. That is why Plumtree developed the Now and Next program, a co-designed, peer-led foundational support program with a decade of evaluation. It shows that trained and supported parent peer workers help families set and achieve goals and work confidently with professionals. We have trained 63 peer facilitators of that program and 135 family leaders. Parent peer workers are an untapped workforce that can be incorporated into early childhood and community organisations, just as peer work has been incorporated into the mental health sector. Children are a part of families, and families need support to learn how to best support their child and to build a good life, both for the child and for the family. Families need 3 laneways for healthy development: a peer laneway for connection, guidance and confidence, a community laneway for everyday inclusion, and a specialist laneway for specialist supports, including therapy, if and when needed. At the moment, only the specialist laneway is fully built. That is why we see therapy becoming the first and sometimes only response. When all 3 laneways will be in place, families should feel supported earlier, stay connected in mainstream settings, and use specialist services more appropriately. Thriving Kids is the opportunity to complete and develop the peer and community laneways so that families feel confident, connected and supported right from the start. We have the evidence, the workforce and the model. What we now need under Thriving Kids is system integration of parent peer workers. Thank you.
Thank you. Anyone else like to make an opening statement? Yeah.
Karen Weston, CEO of Gowrie, Victoria.
So it's named after Lady Gowrie, isn't it?
Yes, that's correct. Named after Lady Gowrie, yes.
Yeah, wife of the
the
Governor
Gowries were
General.
established about 85 years ago.
In Erskineville.
Yes, there's New South Wales, South Australia, WA and Queensland.
Go ahead.
Thank you. Thank you. I wanted to make an opening statement because of the history of the Gowries in Australia and the work that we do around quality early childhood learning. Here in Victoria, we operate 6 services with about 1,000 children attending each week, and I wanted particularly to draw on some work that we do in a disadvantaged community at Broadmeadows Valley, where we have a 194-place early childhood service, which has, for the 3rd time, just received an excellent rating. It's a service that supports families with very complex needs, from developmental delay, experiencing family violence, needing lots of family support, children known to child protection, and just poverty, really. Parents without employment or, qualifications. And so the service is renowned for the way in which it works with a whole lot of partner organisations. McKillop Family Services, the local MCH service comes in, and how the staff wrap around families. So for families, it's almost seamless in terms of the types of supports we try to provide. But I wanted to present the other side of this. We make it seamless for families, but so, for example, in the period from June to August this year, 417 professionals from sort of speech, OT, psych visited that service. It takes a lot to coordinate that many visitors, but each of them come and have different directions for the staff about what to do. So we might have 10 versions of what's the best speech therapy to do for one-on-one with a child. And we have to push back a little bit and say that's pretty unreasonable on our educators, who are trained more as people who work around early learning and child development and care than that idea of one-on-one practice. They work with groups and they do small group work. They have lots of expertise in learning and development, but they don't have health expertise, and there's a bit of a clash because some of our health clinicians want to work one-on-one with children, and we're a service that operates and works with children in groups. I welcome the Thriving Kids initiative. I think it's amazing that some thought is going into how to put more health services in and around children in the places where they are, because as you know, there are lots of children in early childhood education and care, lots of children in schools. And then finally, I'd like to refer the committee to a piece of work that I've been involved in for a very long time called the Early Language Victoria study, because I heard you talking before about screening, and that's a longitudinal study where we've discovered that screening it's not easy to do screening around speech and language. Children's development is not linear. At one point in time, their language might be okay, development might be okay, and at the next it flops the other way. And the research is more recently thinking about the whole child in the family, and the mother's, I suppose, qualifications, experience, education as some of the risk factors. And when you talk about complexity, I don't think it's helpful to only screen the child. I think it's very important to understand the context they're in terms of the early childhood service we might provide them, where the family are up to, what's going on for them. Are there, for example, around speech and language, we all know how important reading is to children and whether there are even books in the home. So I'm happy to provide the links to that work led by Professor Sheena Riley and colleague Trish Eadie at Melbourne University. It's a longitudinal study, ARC funded. Whilst it is focused on speech and language, I do think it's probably something that's quite relevant for all of children's development. Happy as well to offer, if committee members would like to visit the service at Broadmeadows Valley and see the amazing work they do. But it's reliant on a really strong leader, and it's cross-subsidised by our other services to be able to provide the supports to that community. Thank you for the opportunity to make a statement.
Thank you. Anyone else? No?
Chair, I think there's somebody trying to talk, but the sound's not coming through. I can see her on the screen.
Oh, sorry. That is, I can't even read the name. Is that Miss Brennan, is it?
I'm Claire Brennan.
Oh, we can just hear you. Were you trying to talk or?
No, I just mentioned that I can see somebody trying to talk, but they're not talking.
Oh, okay.
Hello. Can you hear me?
Yes.
Hello?
Yeah, that's Miss Baxter, is it? No?
It's Kelly Jeb from Good Start. Can you hear me now?
Yes. We can. Thank you.
Thank you. Sorry, I've just tried my headphones and that seems to be working better.
Could you state your name and the capacity in which you appear? Sorry, we didn't hear that before.
Yes, thank you, Professor. It's Kelly Jebb. I'm the Head of Social Policy at Good Start Early Learning. I'm joining you from the lands of the Yagara and Turrbal people today. Good Start is Australia's largest not-for-profit social enterprise and the largest early childhood education and care provider. We have over 660 centres. We operate in every state and territory, and we support more than 61,000 children from 51,000 families. Our mission, our purpose is to ensure all Australia's children have the learning, development and wellbeing outcomes they need for school and life. At Good Start, we've made deliberate investments to ensure we can support all children, including those with a disability, developmental delay, diagnosed conditions, trauma-related behaviours, to access early learning. As a result of these investments, we have a significant population of children and families with additional needs or disability who will all be impacted by the Thriving Kids initiative. This year, just over 4,500 or 7.5% of children in Good Start centres had an additional need or disability, and every single one of our centres supports at least one child with a diagnosed disability or additional support need. We know the main 4 additional needs consistent across our centres are speech and language delay, developmental delay, which account for about 50% of our children, and then autism spectrum disorder and requiring other behavioural support. 43% of the children with additional needs or disabilities in our centres have at least one other risk factor. Most commonly, they are from low-income families, or they are also children deemed to be at risk of abuse or neglect. We're able to achieve these levels of inclusion and accessibility because of the additional funding that investments that we make that go well beyond government funding. For example, in 2024, Good Start spent $24.3 million on additional above-ratio educators to ensure children are supported to fully participate in early learning, of which the government contributed $13.2 million through the Inclusion Support Program. That means we are funding about 46% of those inclusion costs. And that's just additional educators. We make other inclusion investments in professional development, developing and implementing programs to support enrolment, access and participation, and specific investments in supporting reconciliation and cultural safety and responsiveness. The NDIS review recognised the need for improved inclusion and accessibility in mainstream services and the value that early learning services play in early identification and referral as a universal service setting. But it's really important to acknowledge that not all children are universally included because the current inadequate inclusion funding means it's cost prohibitive for some providers to include them or to meet all their needs or match those hours of enrolment with their parents' work or study. And to address those concerns, the PC inquiry made recommendations about what inclusion investment should look like, including urgently increasing the inclusion support program subsidies this year in 2025 and establishing an ECEC inclusion fund from 2026 to be fully operational by 2028. If we could ask for 3 things from this inquiry, it's that the Thriving Kids initiative complements, strengthens or increases existing funding streams that support a child's inclusion in early learning settings, not replace them. That it's co-designed and co-delivered with the early learning sector to embed supports in natural settings where children play and learn, and to apply a local needs lens, acknowledging the strengths and gaps in local service systems that prevent equitable access to supports across the country. Thank you.
Thank you. Now we'll open it up to questions. So Anne Stanley, do you have any questions? Maybe not.
Chair, it's Claire Brennan here. I don't know if I've missed the boat to introduce who I am and share a few words.
Yes, sorry. Absolutely.
That's all right.
Go ahead.
Thank you. I won't take up too much time. My name's Claire Brennan. I'm the Director of First Steps Count Child and Community Centre on the beautiful mid-coast of Taree in New South Wales. We're not a childcare centre or an early child and education centre, but instead we are a collaborative, place-based child and family hub for families with children aged between 0 and 12, providing a safe and welcoming place for families to access supports and services in Taree and the surrounding areas. We've only been operational for 2.5 years, but our branding has been around the town for 15 years or more, having been thoughtfully and intentionally designed in partnership with the community, using biophilic design principles, creating a beautiful space, promoting health, well-being and healing. Our ultimate aim is for all children to thrive, have the best start to life and to reach their full potential. It was developed in response to an analysis of the AEDC data, which hasn't shifted over the last 2 decades. In fact, the most recent data illustrated that it has increased, and well over a quarter of our children start school with 2 or more developmental vulnerabilities. Our objective is to engage early with families, providing knowledge and skills to parents through their journey of raising children, empowering them to raise healthy, thriving children in safe environments. Our hub model is based on working relationships with local service providers who deliver their funded supports and services at First Steps Count. The First Steps Count Navigator, a critical component of a hub model, works alongside families, connecting them with the right supports at the right time. I believe that hubs like First Steps Count provide an excellent, accessible place for something like Thriving Kids. Child and family hubs offer a vital foundation for building long-term trusting relationships with families. These relationships create safe, welcoming environments where parents feel comfortable discussing their child's development and broader family needs. This trust enables warm referrals to targeted supports, ensuring families are connected to the right supports at the right time. Hubs provide inclusive, non-stigmatising settings for programs such as supported playgroups, which are instrumental in helping parents identify developmental needs in their children. Conversely, with trained staff participating in these programs, playgroups also provide a safe space to educate families on typical early childhood development. Playgroups also foster peer connection and offer holistic support to families, including access to early childhood specialists, opportunities to embed allied health professionals, and trauma-informed relational practice. At First Steps Count, we have piloted student speech pathology placements in a playgroup setting, providing natural contexts for speech and language screening, combined with opportunities for parent education and/or appropriate referrals. Through wraparound supports and accessible information about child development, hubs empower families and strengthen community wellbeing. With sustained GLUE funding to coordinate the services that are delivering supports and services and additional investment, hubs have the potential to expand their reach and impact, delivering integrated place-based services that respond to the complex needs of children and families. Thank you.
Thank you. Monique, any questions?
Oh, thanks very much, Chair. Yes, I do. Thank you. I might start with Ms. Mamek, if that's okay. I'm really interested in this concept of the value of the parent peer workers. I guess I'm kind of interested in how you identify which parents are sort of suitable for this role and how you support them in taking on that position.
Thank you. That's a great question. We entered into this in 2015, 10 years ago. We didn't know where we're headed. We built it through co-design. The way we recruited our peer facilitators and family leaders was with a process called reverse recruitment. Families do the Now and Next program, and peer facilitators of that program recognise family leaders who are participating within the group. They tap them on the shoulder. We invite families to family leadership training, and we recognise families with leadership skills that are really understanding both their own experience of raising their child with a delay or disability, but who have the capacity to tell their story, connect with other parents in a hopeful and empowering way, way and really support families by connecting to them as a parent. So the process is of reverse recruitment. We support and supervise our parent peer facilitators. We employ them, we pay them, and we support them as trained members of our staff. They are a part of our team. We obviously don't employ 63 of them now. We don't have funding right now, but over time what we've shown is this is a proof of concept. It's not just an idea. This is an Australian initiative, and having trained 63 facilitators and over 130 family leaders, I think shows that this can be done.
Love it. And so how do you train them? And when you pay them, what do you pay them as? Like in what capacity? Using what sort of pay scale and things like that?
Yes, we pay our facilitators as contractors, so we contract them because of the uneven amount of different funding that we've been able to secure through the 10 years of this research. So we pay them as contractors. They get just over $2,000 to facilitate an 8-week program for 2 hours each session. So we think that's a good and honest rate of pay to honour the expertise that families have. In terms of, that was one question, pay. I'm sorry, what was the other question?
Well, exactly how do you train them? Is it sort of hands-on or...
Yes. So
what does that process involve?
Yes. So once we've recruited the families, they do what we call the family leadership training. That's 3 sessions. And then when they're going to, if they express an interest and we see they've got the skills to become a facilitator of the program, and I note that this isn't about delivering information to families. The focus of the program is about getting families to support one another, engage with one another, and help one another, giving and receiving support. So that's a quite unique skill set. So they then receive facilitator training, and they also are buddied in the first time that they run the program by a more experienced parent facilitator. Altogether, what they're doing is they're learning how to facilitate, how to share their story in empowering ways. They learn about the program content, which is based on positive psychology and strengths-based approaches, how to work with professionals in empowering ways, and it's really bringing their lived experience along with that training to support families who are in similar circumstances to them.
Okay, thank you. One more question, if I may. Ms Weston, you mentioned we've heard this a few times, the challenges of having lots of different therapists and things come into sorts of centres like the ones that you've run. We've heard that from a number of different providers around the challenges there. So what would your suggestion be? If you could run how yours had free rein over how your centres run and how it all goes, what would you do? Would you say, look, we'll provide the services and we'll provide someone who can give group services to people, or what would your suggestion be about how to do things a bit better in a way that's a bit more streamlined and perhaps maybe a little bit less disruptive to the routines of your centres?
Thank you. It's a good question and one we grapple with, but I can probably share at that site we have a partnership with McKillop around some of the family support services. They're on site. We've built a relationship with them over a long period of time. They understand the way the service works. Parents can get referred to McKillop, and it's an example, without even, they want to be referred because it's all on site and there's consistency. So I think the challenge is actually to move from a health model of one-on-one service delivery to a model where you have consistency of, say, the speech therapists and OTs. Now, it could be that we employ them. It could be that they are in a partner organisation that is on site. But I think that would allow you to build capacity in both our educators to understand more of the way the health professionals work, but would also allow the health professionals to work on getting those consistent messages and what might be the most effective strategies around their particular discipline in a group setting for children. So I think there are many options about how to do it, but I think consistency is really critical.
Consistency and co-location?
Yeah.
Okay, yeah, agreed. Thank you. I've got lots of more questions, Chair, but I'll let some of the others have a go first.
Alice.
Thank you, Chair. Thank you all for appearing here today. I'm the member for Gorton, so represent a community in Melbourne's western suburbs. I've just got a question around transition, and I wanted to seek your view on how we better support coordination for children in that critical transition period from, early learning and education sort of spaces to school.
This is Silvana Marmik from Plumtree Children's Services. So we do run an early childhood intervention service and a mainstream preschool as well, as it being a broader child and family organisation. My answer's focusing today a little bit on parent peer work because we think that's a niche and something that the Thriving Kids initiative could incorporate. We find that connecting parents with other parents very early on helps them to understand how to navigate complex systems themselves. If we're relying completely on professionals to do this transition work, and there are many transitions that very young children go through in those very early first 1,000 days, but then up until school, you could be on a waiting list for a very long time. So parent peer work, parent-led organisations, parent workers embedded in community organisations are a way to get effectively quicker information to families to help them to understand what other parents have experienced in terms of successful transition. The work that we're doing is really about enhancing parent participation and agency. We're looking at increasing hope, statistically significant increases in hope, empowerment, well-being and progress towards their goals. We're trying to show families that they can lean into this relationship. They are the parents of their child. They'll be here for long after the professionals have come and gone. We've met many, many professionals through Karim's 35 years of his life, and we, the family, are the constant. Building the capability, the connection, the knowledge and the skills of families is where I think the real essence is in this new Thriving Kids system, the potential.
Thank you, Ms Marmik. No further questions, Chair.
Would you like any other response?
Yes.
Yes.
Yeah, please.
Transition?
Please.
I'm happy to speak, and there's a lot of work happens around transition, but 3 of our sites are currently co-located on schools. The Broadmeadows Valley site and our Carlton Learning Precinct site, both disadvantaged, multilingual, diverse communities. There's just a constant relationship with the school. And the one insight I'd like to share from Broadmeadows Valley is where at the beginning of the school term, our staff have actually got over to the service to help settle the children, explain some of the strategies that we've used to be able to help children feel okay. I mean, it's a big change environment for some children. And so our staff making themselves available in that first few weeks of school and sharing those strategies. I have to say transition is not a point in time piece. It is actually something that should happen over the full year, and I'm sure you'll hear that from other people. Just wanted to add that value if I could. Thank you.
Thank you, Ms Weston.
And Claire Brennan here from First Steps Count. Just to reiterate the fact that we need to be able to empower parents to be in control of how they work with schools. In Taree here on the mid-coast, this is an area that's characterised by significant disadvantage and adversity, with high populations of First Nations families. Many of those parents have had very negative experiences with attending the education system themselves, and so don't necessarily feel comfortable going into the school gates and having a conversation with their teacher, nor do they feel welcome actually going into the schools. And sometimes we find schools have very big security fences out the front and intercoms where they need to be able to sign in and out. And in a context of high levels of complexity and other things going on, it doesn't seem to be necessarily a very positive interaction with schools if parents have some concerns about their child's development. Anyway, that's thank you.
Thanks, Ms Brennan. Thanks, everyone.
Thanks. I've just got a couple of questions that I can start with you, Ms Brennan. Do families come to you with concerns about their kids?
Sometimes. So we provide a no wrong door approach. So we welcome families. The only eligibility criteria to come in the door is that you have children under the age of 12. Mm-hmm. So some of our families come into the centre for a play. It's a very beautiful nature-based play area, so it's quite unique in Taree. There aren't many playgrounds outside that offer a safe and shady place to play.
Sure.
And what the most beautiful part about this place is that we let families in. We over time build trusting relationships with our parents, And then it's through that trust building that families start to open up and tell us their story so that we can understand how best to support their children.
And if your worker thinks the child has a developmental problem, speech and language or behavioural, what's the next step there? How do they get support?
So our process would be that we would introduce them to our First Steps Count navigator. Her role is currently it's funded by Communities for Children funding and employed by Karitani, which is a metropolitan-based service that provides that service here. Yep. It's a very innovative and slightly experimental role, I would say. But the navigator's role is to come alongside the family. We embed the family partnership model to learn about where the parent is at that particular point in time. And then the navigator's role is to identify some key goals and some areas in which the parent can take control of how they might approach a service or a support. Otherwise, the navigator is available to help them to navigate what is a very complex and fragmented and often very siloed system, whether that's connecting with health or whether it's going through education. A lot of our children are on suspension at school or on lower attendance. They don't have to go to school every day. And that's typically because there's been a behaviour that has been recognised by a teacher, and the solution that some of our schools have is to only put them on partial attendance, which puts a significant amount of onus on a parent who might be working. Even if they're not working, they don't get that opportunity to do all the things that need to be done while child's at school. Right. So I know of children who have been sent home on partial attendance. They attend 2 hours in the morning because they have some behaviours that are not able to be managed by the education staff at the school. Right. And so when I think about allied health provision in school context, how might we be able to do this in a way where allied health can work in partnership with teachers rather than come in, do some work with the child and then give a program to a teacher who's expected to have to implement that in the context of a curriculum that they have to teach.
And how do you get allied health? Do people pay for it or...?
Yes, so the large majority of the allied health providers who come through First Steps Count are funded by the NDIS and they're private practitioners. We generate some revenue through room rental, so they come in and they use our space. One of the really interesting things that we've recognised is that when we have worked in partnership with, say, community health or the public sector, there are some very rigid system policies and procedures that don't allow them to necessarily work in a way that we would consider strengths-based, trauma-informed or the hub way. Whereas sometimes what we've observed is that private practitioners do have a bit of flexibility and agility built in. It brings me such joy to see private physios, OTs, psychologists, speech pathologists out in the floor in our family room, engaging with families who are not necessarily on their books, but just while they're waiting, having a conversation, it really starts to break down some of that stigma that might be associated with reaching out to a therapy service for support.
Right. And what about access to paediatricians? Is that a difficulty?
It's a bit difficult in that, I heard you mention earlier, Chair, some workforce shortages. The paediatricians have an extensive waiting list here at Manning Base Hospital in the public sector. There is huge demand. That just this year, one of our the senior paediatricians from the hospital has started running a clinic here at First Steps Count and has really enjoyed the opportunity to do it in a different space. One of the beautiful things about this hub model is that a doctor or a specialist can see a child and a family, and then once that consult is over, because that consult could be quite challenging, the family is welcome to have a play and sort of decompress after that appointment rather than just get straight in the car and drive home. Yeah. So, yes, we have had paediatrician services this year, but it's just their list has moved from the hospital to here. Okay. So rather than prioritising.
And is that a free service or a bulk billed service, or is it?
It's bulk billed through the hospital, yes. So they manage all of that in the hub context.
Great. Thank you. I'm conscious of the time. I just have one question to you, Ms. Mamik. What helped you the most when your child was a preschool age, when concerns were raised about his development?
We had some great therapists, but as I said, they come and go. The most important thing that I found when he was young, but also throughout his school years and adult life, is connecting with other parents who understand what I'm going through. Parents offer the kind of support, skills, knowledge and connection with a credibility that professionals just cannot, but it's complementary. It's not either or. We just finished providing 1,008 families who did not have NDIS funding with the Now and Next program, and what we found was that these families who do not have funding are just waiting in the system, confused, connecting with another parent peer worker on the telephone and then engaging with other parents throughout the 8 weeks. Their hope, empowerment and well-being was well below our benchmark of NDIS families. But what was interesting is that those that finished the program after 8 weeks, they made greater gains than their families with NDIS families, even though they were slightly under the benchmark of the NDIS families. That tells us that families who are not engaged, who are still searching, who are still looking, they can get really valid support that is having statistically significant differences on their hope, empowerment and well-being just by engaging with other parents in a structured program. Thank you.
Thank you. Well, there's lots more I'd like to ask, but I'm conscious of the time. So thank you all very much for coming today. If you've been asked to provide any extra information, could you forward it to the committee by the 24th of November 2025. You will be sent a copy of the transcript of your evidence. We'll have an opportunity to request corrections to any transcription errors. And once again, thanks very much for coming, and we hope with your help we can design a better system. So thank you.
Thank you.
Thank you for inviting us.
Thanks for the opportunity.
Good. And without further ado, I now call representatives from Early Childhood Intervention Australia and Bathurst Early Childhood Intervention Service to give evidence today. Oh, good too. Yeah. The last thought were good. Yeah. Is Alice coming back? Okay. All right. So, thank you for coming along today. Before giving evidence, can I ask you to introduce yourselves and the capacities in which you appear before we proceed to discussion? So we might start straight away, if we can.
Good afternoon. My name is Sally Moore. I'm the CEO of Early Childhood Intervention Australia, Victoria, Tasmania. Would you like me to make an opening statement now, or we'll do the intro first?
Good afternoon. My name is Jo Johnson. I am an early childhood specialist teacher at Bathurst Early Childhood Intervention Service.
Good afternoon, I'm Meredith Cox. I'm an early interventionist specialist teacher, and I'm also here as a mother of a neurodiverse child who is now 8 and has thrived on early intervention under the key worker model.
And I'm Lucinda Jones, also representing Bathurst Early Childhood Intervention Service, which we may refer to as BECCS as we talk. I'm also an early intervention specialist teacher, and I also have the role of Sector Capacity Building Officer.
Great. Well, thank you for coming today. Now, Ms Moore, would you like to make a short opening statement?
Thank you, Chair. ECIA VicTAS is perhaps the easy name, or just ECIA that I'll use today, is a membership peak body. We represent providers delivering quality services to children with developmental delays and disabilities. We started with members just within Victoria and Tasmania, but we now have a membership that is national, and we have members from all states and territories across Australia. At present, we have over 450 memberships, and those members are supporting thousands of children across Australia. It's a very diverse membership. Within that, it's comprised of allied health practitioners, speech pathologists, OTs, physios, psychologists, music, art, play therapists, social workers. We also have specialist teachers and then teachers and educators within the early childhood education and care sector. We have preschool field officers who are members from within Victoria, and we have students and a handful of parents as well. Our members provide services to children with all disabilities, no matter the diagnosis, and they often work with the most complex of children, whether they be health or complex medical disabilities or neurological disabilities. The majority of our members are drawn from not-for-profit organisations. We are aligned very closely with the National Best Practice Framework in Early Childhood Intervention, recently refreshed, which is very exciting. And prior to that, we aligned with the National Guidelines for Best Practice in Early Childhood Intervention. ECIA VicTas, our work focuses on member support, advocacy, the provision of professional development, and particularly building the understanding of what best practice is across all sectors working with children and families. In my role as CEO, I am also a member of the Australian Child and Family Supports Alliance, and I chair the Victorian Child and Family Supports Alliance, two collectives that were formed following the introduction of, or the announcement of, foundational supports. And over the past year and a half, those two groups have been working closely together, looking at what possibilities could be under Thriving Kids. In preparing our submission, we consulted widely with our members to respond to the terms of reference. And what we highlighted in there and what members highlighted for us was a really firm need for clear pathways for families to navigate. We talk about a no wrong door approach, but often it's hard to find where the front door is. So how do we make that easy for families to navigate? We focused on collaboration with everyone who is working with the child and family, which includes early childhood education and care, community services, child protection, any other services that are working with the child and family. We also spoke to tiered services, so opportunities for when families need more, they can access more, and when they're travelling well, then they can step away from services, but then also have the opportunity to link back in when they need to. And we spoke particularly about integrated services where information is shared and families only need to share their story once or twice and they don't need to keep sharing a story. In Victoria, if you have a child that is identified as having some developmental differences, you can tell your story 5 times between birth and school in order to access services.
Sometimes more.
Yeah. We talked a lot about local approaches. We've talked about the essential input from quality professionals working with a team. And we've talked about a move away from dollars and hours to focus more on goals and outcomes. Equally, we've talked about a move away from the wait and see or wait and fail approach that we currently have and being able to step in quickly and support children and families immediately. Yes. We're very interested in co-design in order to stand Thriving Kids up. And representing to providers, we feel that a really clear workforce plan is going to be essential. And we'd be very pleased to participate in that.
Good.
Thank you.
Thank you. Anyone from Bathurst want to make an opening statement?
Oh, yes. We're going to share it.
We're sharing.
Yeah.
You get all of us today.
Yeah.
We just have to make a brief...
Yeah. We will, yes.
Yep. I am Jo Johnson from Beckus. Established in 1981, Bathurst Early Childhood Intervention Service, or Beckus, is a non-for-profit incorporated body and charitable organisation in Bathurst, New South Wales, run by volunteers and a community board. We are an exceptional team of early intervention experts who include early childhood teachers, specialist teachers, speech pathologists, allied health assistants and early childhood educators. The service has an abundance of knowledge and early childhood experience and lots of personality. It is important here to add that our administration and management staff are also a critical component to our team. The team's strength in early childhood and early childhood intervention knowledge is a skill that is exceptional. In total, we have 267 years of experience combined. There are 12 early intervention practitioners in total, with 3 speech pathologists, 7 early childhood specialist teachers who specialise in early intervention and child development, and 2 early childhood educators who are also allied health assistants. We have 3 staff with over 30 years of experience, the most being 35 years and the lowest amount being 12 years. Children's age range is from approximately birth to 8 years. Their diversity in background and strength and identity is vast. Each child's family is a partner in early intervention with Beckus, with families' diversities and goals shaping their journey with us. Early intervention is shaped through evidence and research-based approaches, but most importantly, modelled on human rights and a strength-based approach. A human rights approach recognises that disability is a natural aspect of human diversity and humanity, and it further exemplifies that a strength-based approach for a child with a disability is seen as a child with diversity, not as a defect. For a child with developmental concerns or a disabled child or a neurodivergent child and their family and community, early intervention that is modelled on human rights and strengthens a disability-affirming and neuro-affirming child, and Beckus prides itself in practising these approaches with heart, pride and joyful play.
So, Meredith Cox. So one of the things we are concerned about is one size doesn't fit all. In regional areas like Bathurst, we've struggled with getting supports through the current model. We would not be the only one in these areas that it has occurred. Although it's difficult, our model at Bathurst Early Intervention Services has proven that it truly succeeds because we work with services that are already there and provide support. That will mean that it is a smoother transition, as mentioned before, to other big pictures like school and into workforce. What works for the city doesn't necessarily work for families in regional and remote areas. For example, the recent changes in travel charges, so that within the NDIS, so some families are travelling further to services and some providers are now swallowing up those costs to service needs in rural and remote areas. Families need support when they first reach out. We are often the first port of call for families in our regional areas. These families are serviced by what we call Start Strong, and we currently are creating a playgroup to try and capture families when they first reach out for us. We're being supported by another like-minded organisation to fund these programs. Once the playgroup starts early next year, we will be inviting families to come and meet some of our team. We will work with the families to complete ages and stages, identifying areas of concern, and if Thriving Kids would be in place, we'd happily be a pilot program for this.
I'll quickly finish it off. We are celebrating Thriving Kids as well. With our history of over 40 years, we feel we're ready to be. We are sustainable. We've proven that we've been there for a very long time, and that's what's needed for Thriving Kids. We need something that's equitable with a wraparound, proactive and reactive approach, which is what Beckus has set up already. The moment a family contacts us, we are proactive in supporting them and their journey for that child. And we feel that Thriving Kids must be inclusive, and we have that set up in our organisation with at least one referral each day where families recognise when they walk in they feel welcomed, they feel like they can be unhinged, they can be whatever they are as they come in, and they're not questioned, and that's what Thriving Kids needs to be. Thank you.
Thank you. Good. We'll open it up for questions. Ms Stanley, have you any questions?
recommendations for ultimately our report. Do you have any recommendations that you could share with us? Like, we've heard that every child needs to be able to have a voice and be looked at separately, but do you have any overall recommendations?
Can I suggest that I know there's been quite a bit of talk about allied health, but within our organisation, and I believe ECA would support this, ECIA, and Plumtree, who spoke previously, early childhood specialist teachers are really a go-to. We have over 250 years' experience within our roof of these people with a really deep understanding of child development holistically. When we're looking at an occupational therapist or a speech pathologist, they have very specialised skills. We're looking at language, we're looking at speech. When you have an early childhood specialist teacher, we see the family, we see the child, we see this whole unit the moment they enter. And we are able to deliver services from the moment that we open a conversation with those families. And I feel that really needs to be a major point in the rolling out of Thriving Kids, and that I know we're talking to a lot of early childhood services, but they are bombarded already with what's going on in their service, and having these early childhood services that are already sustainable and set up, and having that wraparound approach with these early intervention teacher specialists, I feel is a really important point to note there.
How many specialists, early childhood teachers, do you think, or do you know where we could go to get that data? And is it just on the job, understanding long-term, doing so well at your craft, or is there actually upskilling that could happen?
If I could respond to that one, Sally Moore. I could probably, with some notice, pull some of that those numbers together for you from within our membership base in terms of the number of specialist teachers. I would agree, specialist teachers are an amazing resource. That's my background, personally. I started in mainstream education and then 20 years ago moved into early childhood intervention. I think what I would add, though, to what's been said in terms of a recommendation, that point of transitions and the use of a key worker model, that person can be the conduit between home, wherever the education setting is. If I think of it in the context of school transition, if you've got a key worker who has been already working with the child and family, they then are going to help them navigate the process around transition into school, help with things like choosing an appropriate school setting, suggesting possibilities, and being that person who can then transfer skills and strategies that have already worked well to go across into that school setting. So I would definitely look at that, the key worker, as a resource. They are also great at generalising skills from the education setting back into the home setting, and looking at how you can build therapeutic skills and strategies into daily routine, so it doesn't just become an add-on that I go to once a week. I'm going to be helping the family embed within the daily routine so that practice happens little and often to get the best outcomes.
No further questions, but thank you all very much for coming today. It's really interesting.
Monique.
Maybe just add one little point around, just on the workforce piece too. I would recommend looking at the composition of current service providers. There are many service providers out there currently operating in the NDIS space who will have available workforce, and so planning early in order to see how Thriving Kids could be prepared and commissioned. There is a ready workforce there. If the NDIS's focus is going to centre more on, for example, speech and OT, those other disciplines that are sitting within those teams could provide a ready workforce in order to support the standing up of Thriving Kids. They're already working with children and families, and I think, Ms Stanley, part of your question was around training as well. I would suggest that a teacher who's straight out of tertiary education probably will need a considerable amount of training in order to go and work under a Thriving Kids model. My recommendation would be that they have some time learning their craft first before then moving across, which is what many teachers have done, starting in mainstream, as I did, after 12 years, and then moving across into the disability space.
We would agree with that, very much so.
Monique, do you have any questions?
Thank you. I'm interested in a few things, but I might start by just, in terms of that workforce era question, we've heard a lot about the need to avoid siloing of workforces. Is it your feeling across the board that the workforce that's currently engaged with NDIS would have capacity and interest in engaging with thriving kids?
Perhaps if I could respond first. Sally Moore. Yes, within our membership base, I am regularly asked what's happening with thriving kids, can we participate? I feel that you have organisations, both certainly within our membership, that are both metro and rural, that are ready and willing. If the referral stream under NDIS is going to be changing, they are already staffed with teams at the moment. There is a certain amount of uncertainty, and so moving quickly around a workforce plan and letting the sector know what that is would be very helpful in order for us to, within our sector, to retain the expertise and the skills that we currently have. And then you can avoid starting from scratch within Thriving Kids. But certainly our members are regularly asking me how could they be participating in Thriving Kids. They are well set up to do that, and I believe they have all the skills and experience necessary.
Yeah, we have similar models. Yeah, in the Central West, and because we've been in our business for 40 years, we've diversified from NDIS, so that's the model at the moment. So we are adaptable again to those changes around Thriving Kids.
Mm-hmm.
Yeah.
This question might not be fair, but do you think people would be, might be a strange question, but do you think people would expect to be paid differently for support providing services through Thriving Kids, potentially to more than one child at a time, as opposed to a one-on-one through NDIS?
We can speak that we already practice in our group settings, that we're not expecting different payment during a group, that it is still the same payment, and the funding we've just received to be proactive in this model that we hope would be something that Thriving Kids would look like, that we're being sponsored to deliver, is under that same payment model.
Yeah.
Right.
Perhaps if I could also add to that, Sally, within our membership base, providers are often managing different multiple funding streams already. They're often delivering NDIS. In Victoria, they deliver under the Department of Education block funding. They're also delivering under private health and Medicare as well. So they're well versed in having systems and processes in place in order to be able to navigate those different funding streams. I perhaps would just make a comment around a risk in this space that if we want to retain a workforce, we want to build a workforce for Thriving Kids, if that's not seen as a desirable place to work in terms of remuneration, then how are we going to do that? Will we end up with challenges around recruitment? And as we all know, we do already have challenges. We don't want to exacerbate that any further.
Further to that, Jo Johnson, at Beckus we also work under a number of funding streams. NDIS is our main source of funding, but we also receive money from the state government and from the Department of Education to run programs. And so we are able to provide services in many different ways, and the way that we are very excited about Thriving Kids coming into play is that we can start to capture some of those families and children that aren't getting any services at the moment. We have
57 currently not receiving any services, waiting for NDIS, some waiting over 18 months. So not receiving.
So just say that number again.
57, yeah.
So there'll be 57. So the new program that we are starting up, that we are we've received a donation for, will capture 57 children who aren't receiving any supports at this stage, and we will be looking at providing them with early intervention, so addressing the family's concerns, building family capacity, working within childcare centres or natural settings where the children are, and starting to address those issues before they are even able to access NDIS.
Good.
Okay, thank you. I might ask one more question if I may, just again to all of you. Any thoughts, input you'd like to give us regarding provision of thriving kids type services via telehealth? Any concerns about that? Any barriers to doing that?
Sally Moore. I think it is a model that we're going to need to embrace. We speak of it as telepractice, as being a very dynamic way of working. COVID, if nothing else, taught us how to actually make the best use of those kind of virtual skills, and certainly our sector has developed an incredible amount of skills in that space. I think some of the key things will be thinking about how are you going to develop the relationships if you've got, for example, a team on the ground and others who are coming into that as a virtual team. Dr. Tim Moore often talks about the concept of virtual hubs, and I think that is one that definitely could be explored and could work really well. So it'll be about how frequently are they able to meet together. You'd need to be thinking about glue funding in terms of developing those teams and relationships to make that work. Within our membership base, they have made use of allied health assistants also, where you've got a professional who's not on the ground in the space who is working very closely with allied health assistants and supervising and providing mentoring and the construction of the program for then an allied health assistant on the ground to actually go out and deliver in the home. I know we have had members who have then had the allied health professional dial in, or the early childhood intervention practitioner dial in. So there are ways of working around that and making use of virtual services in order to support that. But maybe I'll let my regional colleagues.
We'll add to that, because we also services areas where internet is very poor. Capacity of families can impact that. Often we have the families come into our service for our telehealth appointments just to help them in that, connecting to that space, having accessible internet and being able to navigate that system, because it can be quite difficult, particularly when you're a family with lots of things already going on, and then we're adding to that someone that is virtual. So I don't know if you want to speak further to that.
As a mother, it needs to be a cohesive approach too. So you're having your early interventionists there for their telehealth, and you're building capacity, as Sally said, going into services with them. So, yeah.
Good. Thank you. Ellie.
Thanks, Chair.
Ellie France. You're still muted, Ellie.
Apologies. No, I don't have any questions, Chair, but thank you all for giving evidence today. Really appreciate it.
Great. Sophie Scoms.
Hello all, sorry. Thank you very much for your presentation today. I've just stepped back in, so I won't be asking you a question just at the moment.
Thanks. Alice.
Thank you, Chair. I just have one question. Thank you all for appearing today. It's great to have you here. It's just around the role of parents play in this process and how we can better empower parents and, better educate our parents in navigating this process. Do you have any recommendations for the committee specifically around the parent cohort?
Would you like to start? Jo Johnson. We use the key worker model approach, and that approach is very much so working with the child, but also capacity building the families. We are at the very beginning of their journey. We will not be there long term. So our role is to support families, identify what their strengths are, identify what their goals are, and start to help them to work towards those. They are the expert on their child, not me or any of us. And so our job is really two parts: to work with that child directly and to build capacity with families. We have to recognise where families are at, and we have to work within their means. But ultimately, if we're doing our job well, families will leave and have the skills and knowledge to be able to advocate and support their child moving forward.
So would your recommendation to the committee be something like rolling the key worker model out across the Thriving Kids program?
Correct. The key worker model would be of most benefit to families and children.
From the moment they walk in the door, because there isn't a family that walks in that doesn't need support. They're not coming in there because their child is developing typically and they just heard about this organisation. They can't come in because there is something that isn't quite feeling good, and we need to be responsive from that moment they have been brave enough to call or enter that space.
Exactly right. Thank you for your contribution today. No further questions, Chair.
Perhaps could I add to that just a little bit? Sorry. Sally Moore. I would agree with my colleagues at the table. I think the other key part to a key worker model, or the advantage, is that they are going to see families in their homes, which obviously won't work for every single person, but for most it will. So in order to then understand a family and the needs that they have and the capacity and the opportunities there, it is really important to go and see them in their space, to be able to see the environment, to be able to then think about what strategies you're going to suggest that would be appropriate. There's no point suggesting a whole swathe of strategies if they're not going to be able to be implemented within that particular environment or situation. And so being able to be in a family home gives you the opportunity to look around and see, okay, this is the family setup, this will work, that won't work. I think that's really important. And then I think coming back to that key worker model being that link for families also into all the other services that they might be involved in. So if a family is not feeling comfortable to go and see the paediatrician or go and start the school enrolment process, a key worker can be that helpful person in order to guide and empower the parent in order to be able to go and actually do that work. They're sometimes the one who will explain the process and say this is what to expect, which can certainly allay a lot of anxiety and fear and hopefully give the parent the confidence. So it's a great model to be able to, as they said, build capacity and then step away and come in when they need more and not be there when they're travelling really well. So fade in and fade out.
I think it's really important to recognise that this isn't a new model. This is something that we've been practising for a long time, and we don't need to reinvent the wheel. We just need to apply it in a different way.
Sure.
That's true. It is a model that is used across Australia too. This is not something new. Eki Victaz have been promoting this model for 40 years. So it's not new. It's just that perhaps the population who are delivering under this model has changed with the introduction of the NDIS. Certainly in Victoria, that was the model. The key worker model was largely used across the state prior to the NDIS. The marketised approach of the NDIS has altered that. So there are still very committed providers and practitioners who are delivering under that model. I think maybe if I could make one point too around addressing thin markets and the use of the key worker model. So within one of the really strong principles under the key worker model is the concept of team. So whilst I'm the person who is delivering the bulk of the service, I'm backed by a team, as these lovely colleagues have demonstrated today. And within rural and remote areas, obviously we don't have a nice big fat team in order to provide those services. So perhaps coming back to Ms Ryan's question around rural and remote and telepractice, there is an opportunity there in order to be creating teams that would have agreements around how they're going to work. They will have relationships so that then we are still operating as a team. Your team might not always be on the ground with you, but you can still have that team operating in the background, coming in and out as needed when you need particular skill sets. I guess the best example I can think about is my background is in teaching. I'm not a speechy. When I've worked with children in the past who have had particular feeding issues or articulation issues or those kind of things, then I sub out and I bring in that speechy who's from my team. It's a warm relationship. I'm not saying go and find a speechy to address that.
But you're acting as a navigator.
I am acting, exactly. So I'm acting as that person, that navigator, if you will, to say, well, I have these lovely colleagues that I work with who have those skills and disciplines. In the early childhood intervention world, it can be very collaborative. So if I don't have that skill set in my team, I can bring it in from another team if I've got a good partnership or a collaborative relationship.
I just want to ask a couple of questions around that, because one thing we've heard fairly consistently, there are lots of barriers, and one of them in rural and regional areas is cost. Can you just talk to the cost? You might be a navigator, but you've still got to get through that barrier. Is that a problem?
I think if you utilise the key worker model, then you're probably going to get the best bang for your buck around cost, because not only are you going to get that navigational function that you're seeking, because anyone with all of those allied health or specialist teacher qualifications can work under that model. They're going to bring whatever is their therapeutic or specialist teaching discipline. So you will get the navigation, plus you will get the play-based therapy input as well.
So we build trusting relationships with those families that they feel very safe and secure in the early intervention space. So then we're able to direct them to other services, but they're not shopping around as such. So the cost is less because they've got that key worker to then navigate those other therapists that fit that family.
But how much of a barrier is cost as well?
Do you want to speak to that? We travel to what we would class as remote areas because they are not serviced, and we typically find that there's a group of children that need servicing there. So we have speech pathologists travel approximately 100 kilometres, but there's more than one client in that space, so that makes it more viable for our organisation. The changes in the NDIS travel have impacted that significantly for us. So we are still in the process of navigating that in regards to the NDIS changes with travel. But we are not seeing it as a barrier because under the sector capacity building program, I travel to those regional areas and we're able to identify that there's groups of children there that need key worker supports, NDIS, and then we're able to deliver that to those organisations.
Yeah.
It's just continuing having financial support to continue that. And to build that as well. And I'll speak further to that model. Our speech pathologists, as well as us to them, will say we can't work without each other. We cannot do it as a silo, as a speech pathologist, as an early childhood specialist teacher. We come together. We have the knowledge of child development of play. They have the knowledge of speech and communication. Together it thrives. It really brings out the best, and it makes it more viable to travel to regional remote areas as well, because there's more than just that one providing that. But there will be, I'm not going to deny, there wouldn't be dilemmas in travel in regards to regional areas.
Good.
I think, can I maybe just add to that? I think travel is going to be a really important consideration. From our membership base, I do hear regularly about the challenges of financial sustainability with the changes to the NDIS travel pricing. And that has changed the nature of the way providers are needing to deliver service. So, for example, those who have families in their services now have needed to scale back the amount of time they go to a family and swap that to, a family coming in. But they're often saying with new families coming in, it'll just be a centre-based approach. So it is going to be a real consideration in terms of how we are able to, under Thriving Kids, how we're able to have people out seeing families in the community.
Good. Thank you. All right, any further questions? Yep. Thank you very much for coming today. If you've been asked to provide any additional information, could you please forward it to the Secretariat by the 24th of November 2025. You'll be sent a copy of the transcript of your evidence, and we'll have an opportunity to request corrections of any transcription errors. And once again, it's been really helpful, really interesting to hear from you, and thank you for the service that you provide.
Thank you very much. Thank you for your time.
Thank you. I now call witnesses from Australian Medical Association, Dr. Danielle McMullen, the President, National President, and for the Australian Paediatric Society, Professor David McDonald, both appearing online. So Thank you both for appearing.
We've got a couple of others. And Peter Goss
from
the Paediatric Society.
And we also have 2 other members from the Paediatric Society, Garth Hargraves and Peter Goss. So thank you all for attending. Could you please state your names and the capacity in which you appear for the Hansard record? Starting with you, David. I think you're muted.
Thank you, saying come back to me.
That's better. Sorry, I thought it was me. I'm David McDowell's my name. I'm a regional paediatrician in Port Macquarie in New South Wales and representing the Australian Paediatric Society.
Peter Goss.
Yeah, my name's Peter Goss. I'm a general paediatrician. I was in East Gippsland for 27 years in Victoria. Now I'm in Geelong, just managing type 1 diabetes and allergy. And I'm the treasurer of the Australian Paediatric Society.
Dr. Hargraves.
My name's Garth Hargraves. I'm a general paediatrician. I predominantly worked in the last few years at the Northern Paediatric Unit, which manages kids in the top half of South Australia. I also work at the Women's and Children's Hospital, which is the main tertiary site in South Australia. And currently I'm the head of unit at Mount Barker, which is South Australia's newest paediatric unit, setting it up in sort of regional and remote areas.
And Danielle McMullen.
Dr. Danielle McMullen, I'm the President of the Australian Medical Association and a GP currently practicing in the Ipswich region of Queensland.
Great. Would anyone like to make an opening statement?
I'd be happy to do that, Michael.
Okay, David.
First of all, the Australian Paediatric Society represents predominantly regional paediatricians, and our brief to the committee, the key messages. The first is that regional paediatricians are embedded in partnership with their general practice colleagues in their communities and consequently are well placed to coordinate local services across health, education and social care, but most importantly, tailoring those solutions to local resources. We consider able to streamline and ensuring children are referred with our local understanding to the right services early. I do think we have a unique position because we do cross the medical and the social to some degree. So the child we've seen who's had a difficult birth, for example, might be the person we're seeing for developmental assessment in a couple of years. So we have that particular unique perspective. We have major access difficulties, however. I have 250 children on my waiting list. I have a 20-month wait to see me, and that's just for an initial assessment to come and talk to me. And it's a daily basis that I'm seeing referrals from my GP colleagues with concerns about developmental delay or autistic spectrum disorders. And we have undoubtedly witnessed an increase in prevalence of those neurodevelopmental diagnoses that we would all on agreement say is not just a perception or a classification. Having been in practice since 1988, I think that there is a definite increase in prevalence in these disorders. A model that has worked very well for 2 other increased prevalence disorders, which was type 1 diabetes and allergy, has been to have a regional focus to their practice, and the national allergy approach has crystallised very well that regional services are well placed to provide a high quality of service to their community. Telehealth has a place but should not replace face-to-face assessment. It has very significant limitations in terms of the clinician to client interaction. And we feel that although there are long documented inequities in healthcare, the regional paediatricians have a role in planning equitable access to kids, and we also consider that we're able, using regional medical schools, using allergy, using diabetes example, to provide a high quality of care to those populations. I think the hub and spoke model, where the MM3 services, particularly along the east coast of New South Wales, are able to provide support to the 4, 5, 6 levels to some degree. Geography can be a problem. Does mean that we can provide a well-coordinated service. That would be my introduction. And in terms of the recommendations, the main recommendation would be to involve regional paediatricians directly in policy design in planning. We think we have a role to bridge the gap between knowing as much as we can about the child, both medically and biopsychosocially, that we may have seen them at birth. We're in a position to undertake those first-line investigations that act with clarity to provide a kind of biopsychosocial model. We are very familiar dealing with a range of allied health professionals, so rather than being craft group specific, we understand to some degree what speech therapists, occupational therapists, psychology, behavioural support therapists can do. We would strongly advocate for our interaction with schools on a regular basis, and so most of us in regional centres have regular meetings with schools and school counsellors. We are of the view that as children evolve every year, that a comprehensive annual paediatric review for the children identified as having delays is very important. And that would be a similar model to the geriatrician annual review using those specific item numbers.
Thank you. Danielle, do you want to make an opening statement?
Thanks very much. Thank you for having us here as the AMA to present to you today, or to provide evidence today. The AMA, of course, represents all doctors of all specialties and stages of career across the country. And so in addition to supporting what my paediatric colleagues have just said, I'll provide that perspective as a GP. As a GP, I work with families every day, including this morning, who notice developmental, behavioural or emotional concerns in their children. And navigating the variations of normal development, identifying delays, determining how urgent or worrying those are, and navigating the necessary supports is a really difficult task, and one that's built on that trusted relationship that I've forged and that my GP colleagues have forged with families, often since before the birth of their children. Providing that care has gotten harder even over the decade that I've been in practice. You'll all be familiar with the Healthy Kids Check that Minister Butler fought so hard for, but was then removed from the MBS in 2015. And I have seen a shift. We have seen a shift in sort of the focus on childhood development and the ability for general practice to provide that care since the removal of that item. Longer consultations, those few extra minutes to discuss development are not well supported by an MBS that was built 40 years ago. And while the NDIS has been brilliant in supporting our community members with severe and complex disability, it has created a vacuum of services and supports for those kids who need rapid access to what's often short or medium term early intervention to help identify concerns and give them the supports that they need to thrive in mainstream environments. So for thriving kids to succeed, the AMA thinks that we need to support, uplift and invest in existing systems, that we don't need shiny new things, but we need funding. We need to recognise the pivotal role that general practice plays in early intervention and ongoing care for children. GPs are often the first point of call for families. We're trusted, accessible and uniquely placed to diagnose and support early developmental concerns. And then, of course, we need supports for those children and their families to access the care that's identified that they need. We need expanded allied health supports in a coordinated fashion, easy access to paediatrics for that diagnostic clarity and specialist management recommendations. Allergy is a great example of where teamwork between the usual GP, sometimes a GP with special interest, and paediatrics have worked really effectively together. And then, of course, there are some children who will still need the NDIS, and that's important that we're clear in that intent. Digital health certainly has a role in better connecting teams in a way that we haven't been able to before. And I would reiterate that we've already got the foundations here and it's time to build a system that works for every child, and I'm looking forward to your questions. Thank you.
Thanks, Danielle. Either Dr Goss or Dr Hargraves want to add anything to...
No, I think as somebody who works in city, regional, rural and very remote areas, I think there's a very stark difference in services in each of those places, and I think it's clear, and I'm sure you've heard a lot, primarily issue would see is there's no access to therapeutic services. That's the biggest issue we see. The existing funding models are not sufficient to maintain face-to-face services. I think beyond that, we might get into a little bit more detail. There's certainly room to move around, perhaps using what is a limited resource more effectively. And we're uniquely positioned, I suppose, to have a view on that, which I think Thriving Kids will hopefully be able to achieve.
Good.
Can I just add to that, that I think this whole process has come about because of the finances have got away from the government, and I think this was entirely predictable, really. We're referring back to a model that has worked. We know this model works of the regional paediatrician engaging with the local resources, with the schools, with the GPs, and working together. And each region in Australia is different, within a region there might be different teams to set up, and working with our tertiary colleagues. We're going back to I imagine for these particular kids, we're going back to a system where you've got the person that is, if you like, coordinating all of this is the general paediatrician, because that's what used to happen and that's what used to work. And then we can select whether the child does in fact need occupational therapy or psychology or speech therapy, etc., on the needs and strengths or the requirements for assessment of that individual. And I think that's where we're very well placed. I'm saying, and I think my colleagues are saying, this is not a new model. This is a model that's worked. It's far more efficient than anything that's currently on the table, and as things have actually got away. That's probably my statement.
Good, thanks. We might open it up for questions. Sophie, would you like to open up?
Hello, thank you everyone for your evidence today. Great to have you along. I had a couple of questions, and it's around Professor McDonald. And we hear this so often, the 20-month delay, that really long delay is what's a huge barrier to the kids getting the help that they need. And I understand that having a general paediatrician model, really works when people can have that access. But how will we provide support to children at an earlier age when they need it, so that they're not getting that delay in accessing support?
First of all, I'd like to thank Danielle for such a very clear role of the very important relationship we have with our general practice colleagues and how well it works. The main problem is the MBS system has meant that in regional centres, private practice has disappeared entirely. And I think that the state-funded public model is just never going to be designed to have the adaptability and scope that private practice will provide. Michael, of course, was a very dedicated, very successful private practitioner for a very long time in southwestern Sydney, and saw a very large number of patients in a way that it's just not possible for the public system to have done it. I was personally in private practice for 25 years. I'm now employed in the hospital system. I'm just not getting through the numbers. But the reason private practice has disappeared in regional centres has been that the Medicare benefit schedule is asking people to see complex neurodevelopmental conditions in the way the FRACP, the College of Physicians, would like, but it's just not supported financially, and so consequently it's all public clinics. And I think there's only two models. There's public clinics that offer a good service, you can get into them, but have delayed access, or private services that are more adaptable, more flexible, but disappearing because of the financial situation.
He wears a stethoscope very well. He should go into politics, don't you think?
Yes. So I'm city-based, have a child on the spectrum, but there's also very limited private access. And I was a GP trying to refer people into private services. So there is a real barrier there to people accessing specialists to get that diagnosis and that support. So what is the solution around that?
Look, I think it does lie with the Medicare benefit schedule, which is slightly outside today's discussion. I'm aware of that. But basically, if private practice were more financially viable, because it's not even viable at the moment, the recently appointed paediatrician Paul Macquarie is charging $200 gaps to make it viable. And that's a lot of money for all families in 2025. I just think that Medicare, the College of Physicians are currently working on this. Sophie, I'm part of the Paediatric Policy and Advocacy Committee, and we're looking specifically at Medicare benefit schedule reform. I think that's part of it. But I think that the increased prevalence and the complexity is a real phenomenon as to why access has become difficult. For us to really do the right thing for these vulnerable kids, they really do need a comprehensive assessment. Danielle's point about the role of general practice is really crucial. I would support 120% of all of the content of what Danielle said. It reminded me a little as to how grateful we are for our general practice colleagues, but there's a sort of time complexity that means that both people working together provides the best outcome.
David,
Danielle, would you like to comment?
Sorry, before Danielle comments, Sophie. David, what increase in the Medicare rebate will we be talking about for that geriatrician type item number?
The geriatrician item number is 141, which I vaguely recall, not using it often, has a rebate of about $450, which is getting towards the economically viable cost. The costs have increased enormously, Mike, since your own time in private practice, but it's about $500 for an hour compared to about $300 if people are using the 132. I suppose the important thing is we're not talking about increasing doctors' incomes, because I would have to say paediatricians tend not to be very financially driven in what they do. If the rebate were increased and access meant that families could afford that access more reliably, it would allow a busy private practitioner to bulk bill people in need. I think that's something that's disappeared entirely from private practice, Mike. I used to bulk bill lots of patients if you thought it was reasonable, as I did. That's disappeared entirely because that's no longer possible. And the 116 item number, which has a rebate of around $70, you just can't make any living at all if you're using that as a bulk bill. And so and as you know, the child with neurodevelopmental concerns, financial impoverishment for the family is often a consequence of the additional time required. It's all falling on public clinics, and they just don't have the capacity. And it's not the core focus of state-based health services when you're competing with emergency departments, all of the other complexities they're asked to control.
Good. Sorry, Sophie.
Daniel, maybe I'll add in just one other level of questioning, and anyone can hop in as well, is that, I think that sounds like a good idea to have a comprehensive annual review, but if we're not getting, how would we do that? Like, how would we get there? So we're a long way from that. People can't get their children in to see a paediatrician, public or private, and there are big cost barriers as well for the private. But I know there's very, very long wait lists in Sydney here, and I have my own experience of that. How do we get there?
I think the ADHD. I think the ADHD co-prescription proposal is one that will get there. I think that that's not completely the core business of Thriving Kids, but that does mean that they'll free up capacity if GPs are co-prescribing. I think if there's better access to private services, they act as a blow-off valve for demand on the public services. And I think that there doesn't seem to be, as somebody who trains paediatricians, a shortage of people coming through the system. I think there's a limitation in terms of career options between private and public. So many young paediatricians would only consider work in the publicly funded service because the private services just are not attractive in terms of viability for them. Even though I think the private services offer a fantastic service because you have to be responsive to that person in front of you.
I would encourage all of you to be thinking in terms of short, medium and long-term levers. So you're right, Sophie, that some of these will be long-term gains, that cultural pressure in medicine to be further subspecialising. We're seeing we do need more general paediatricians and those willing to work in areas of need, including rural and remote Australia. That's got a long lead time on it. And so we're not going to fix that overnight, but we should be trying to shift our profession in that direction. I would agree with the colleagues that financial pressures for patients we could change fairly quickly. Even if we can't address the wait list, the financial pressure could be eased if there were reasonable NPS items for both general practice and for paediatrics. I think there's clear recognition that undertaking a developmental assessment in a paediatric office is longer than the current rebates allow, and there's precedence not just in geriatrics but in psychiatry, obviously, for the item 291, where there's development of a shared care plan with the intent that that then is defined and shared with the usual treating GP, and that we're operating in more of a collaborative model, and that's where our discussions around digital supports come in. We're not that far away from having the ability to have a shared chronic care summary, and the work of the Australian Digital Health Agency and this government in kind of progressing some of the digital internet, connected care agenda may help some of this in just streamlining the administrative burden. And so it's this multi-layer approach, and then obviously in general practice, GPs can take on more of the load for children, for example, with a single domain deficit, for example, an isolated speech delay. They shouldn't need to see a paediatrician. That's within the scope of general practice, as you know, but the time and financial pressures on general practice in some cases are probably making putting pressure on for referral, whereas if we could manage more of that in the community in general practice-led teams, then we free up paediatric input for those more complex cases, either with multi-domain deficits, global developmental delay, or kids with really tricky psychosocial needs, where we do need that specialist input as well. So strengthen general practice with better funding for longer consultations and the teams in our practices, making sure we've got public supports where they're needed for families that can't afford an out-of-pocket cost. We have seen in some jurisdictions a real falling away of any public outpatients, including paediatrics and allied health, and I think that's having a significant impact. And then, of course, supporting our paediatricians with item numbers and the tools to be able to collaborate with GPs. Another example is the case conferencing items. You need at least 3 people, which is really hard to coordinate, whereas it's unfunded time for the specialist paediatrician to talk to the specialist GP, and while that's really valuable, it is done in our lunch breaks and after hours.
Thanks.
If I could just add to that, I think one of the difficulties we've seen with the NDIS model is that when you've got 90% of the kids on NDIS for either intellectual disability or autism, that really funnels what patients are seeking in trying to get into paediatricians. And that is one of the things that has led to a big wait list, and the inability for GPs and paediatricians to refer kids for something other than that, other than those 2 conditions. It has been something that's really significantly, I think, affected the capacity for us to get care for kids. So ADHD, for instance, is the most common mental health illness in children, and children on NDIS for ADHD are only represented 0.03% of cases, yet it's the most common condition. So that's just one example of many. Any paediatric clinic is not represented by 90% of problems are autism and intellectual disability. And I think the role of the paediatrician to see kids and say, this is the right direction for this child, has been impacted by NDS having this system where you really are predominantly allowing only those two conditions to be funded. And funding has become a binary thing where you're either on NDIS or you've got very limited access to any care. And hopefully Thriving Kids will address that in providing some more nuanced layers.
That's a very good point.
So some of this policy change may in fact ease wait lists because there has been significant market consumer pressure for specialist review to be in or out of an NDIS scheme. And as all of you who are care providers on this panel know, there's rarely an in or out. And particularly when we're talking early diagnosis and supports for kids, we really need a graded layers of supports to rather than a binary lifelong scheme.
Good.
I think the model for us from the regions is very much a kind of local solution and local input. So, for example, fly-in, fly-out models, even though there are some advocates for that, we don't consider that they're responsive to the individual needs of the community. And we would say very much a kind of regional paediatricians are at the heart of being able to work out how to scale up, how to scale down, who should go where, who are the most local resources. We typically have good contacts with our general practice colleagues. It's been a very rich experience for me as being a regional paediatrician since 1988 to be able to work so collaboratively with just an outstanding bunch of clinicians. I think that an urban-centric solution through Thriving Kids is not the solution. It really does need to empower the local communities to be able to do that.
Sure. But David,
I'll just add to that, David, to the comment that you said before about private practice diminishing or dying in regional areas. I think that the regional Australia needs both systems, and one is far more attractive than the other, as in the young person coming out and being comfortable being salaried in the hospital. And with all due respects, I think the work output and the efficiency in a private system is actually far more than a public system, and I think that's where part of the problem is. But that's not to say that they're not doing any work, because there's teaching and there's quality assurance and there's a whole lot of things that will bide their time, but they're not getting the patients seen, and so the waiting list is getting further. And I'm putting that out there that somehow in this whole solution there does need to be a consideration of how do we, if you like, save, or how do we make private practice or private paediatric practice in regional areas attractive again. I'm not sure the answer. I know you talk money is one thing, but maybe there's a few other things as well.
I'll let somebody else have a go, Mike.
Good.
Thank you, everyone.
Monique, would you like to ask some questions?
Oh, thank you. Thank you all for your time this afternoon. I think we've heard from lots. While I have a vested interest in, the involvement of paediatricians in our healthcare system, and I do feel that we play an important role. Let me acknowledge that first off. Yeah, a number of the people who've talked to us around Thriving Kids have basically said that paediatricians shouldn't necessarily be a part of it, both because of the delays that you've just touched on yourself in terms of accessing paediatric assessments and reviews, but also because they don't want us to medicalise the system unnecessarily. Given the issues with the paediatric workforce and the GP workforce as well, obviously, albeit to a lesser extent, do you see any other way of identifying children with emerging developmental issues and funneling them into early intervention services that doesn't involve paediatricians or GPs, or are you the wrong people to ask that question to?
I'm happy to kick off initially. I don't think it's a silly question. There are some workforce constraints. Our submission does outline we'd be open to early childhood centres in particular being a point of identification. It's really about meeting children and families where they're at, and they spend most of their time at home in early childhood, and they're often seeing the GP. So depending on which data source you look at least 80%, but probably more closer to 90% of kids see their GP at least once a year. And we know, of course, that they're seeing us more often in that first year of life for immunisations, and often in those preschool years for a variety of illnesses. So while there are workforce constraints on general practice, particularly for paediatrics, we remain really accessible. And so I think for a variety of reasons, we need GPs and paediatricians in the loop. GPs and paediatricians are expert in identification, diagnosis, assessment of what level of intervention is needed. And we have seen in the current binary system that we have, where you're in or out, there is a race sometimes to get a certain diagnosis to be able to allow supports. And that's not helpful for children or families who then, even if they get on the NDIS, so to speak, I've had families who then find it really overwhelming to navigate that process, get the supports, know whether they're making progress, as compared to prior to the NDIS, where we could quite clearly build a management plan, have identified goals as to where we were trying to reach, and again, for sort of single domain deficits, identify if we were catching up, reaching goals, and then able to wind back supports and allow kids to thrive in their natural environment. These, I think, where we should be, where supports could be provided is flexible. So we've talked about, in GP teams, but it would also be reasonable for there to be community-based supports delivered through early childhood. If kids are already spending time there, why not have some of their allied health professionals in a coordinated fashion seeing them in their school-based, early childhood centres, but of course being coordinated back to their care team. We've also demonstrated that GPs and paediatricians, medical professionals, have been good at cost containment for government, and that is a layer that's important in this. Part of this discussion is that NDIS has struggled with some of the boundaries of what care is required and how do we make sure it's a sustainable program for all the Australians who need to access it. And I think the medical profession has a strong track record of delivering sustainable outcomes as well as really high quality health outcomes for our population.
Agreed. David, I'm interested in what you said about it. Would it be fair to say that you were suggesting that it's easier to get through the workload and see kids more quickly and effectively in a private setting than in a hospital setting?
I think so, Monique. The hybrid model is what I would support. So that in our regional centre we have some hospital-based doctors and some private doctors, and working collaboratively means that, for example, tomorrow's Caesar for some 34-week twins, the hospital-based doctors will do type of thing. But I think the hybrid model is the way that's going to. It allows the private people to get through large numbers of patients, and Michael probably held the record for the number of patients seen for many years in that.
Don't say that.
Well, it was astonishing the quality, but we use the term Freelander busy. That's how busy it was. But I think that I don't think that paediatrician involvement necessarily medicalises people, as some perception would say. I think we provide diagnostic clarity. I think we're an uninvolved third party in terms of service provision. We don't have a narrow therapy-based intervention as being the key. We're able to look broadly. But I also think that to obtain maximum benefit, there is a need for some diagnostic clarity to know exactly why we're doing what we're doing, and somebody to have some coordination on referral from our GP colleagues. I think that's the important thing, is that we don't see patients without that referral. And there's a very detailed triage system. So I think for paediatricians to be able to see patients doesn't involve medicalisation, but a hybrid model offers the maximum benefit in terms of flexible accessibility for patients, and the increased Medicare rebates would mean that's more accessible for more families.
Okay. Thank you. Peter, you talked about a system where we go back to the general paediatrician coordinating care for children. Do you think that's still a practical reality given the workforce constraints that we're all talking about?
I can understand your question, and I've been out of general paediatrics now for 10 years, but what I'm saying, it's a model that worked. And when you've got a model that did work, I think that we should go back and look at that model, which is the stuff that we've been talking about here with acknowledging that there might be a speech issue or a combined issue or whatever, and direct them into the right space. So is it realistic because it takes so long? Well, maybe it's not, but does that mean we dismiss that? No, I think we have to work towards saying we're recognising there's a problem with sustainability. If we start a method of rectifying that, maybe we will get more people that are open up to provide that sort of model. It's hard to go past a model that's worked, and I worked in SAIL for some years, employing an occupational therapist, a psychologist, a diabetes educator, and a speech therapist in a multidisciplinary model that we basically made up in a regional area. It was fantastic. It was not necessarily cost effective, but it was. We had schools, we had teachers come in. It was a very well coordinated multidisciplinary clinic, which worked. In fact, there was awards and things like that. We had other specialist clinics come down as well. So that's probably where my passion is, from looking back and saying there is something there. When NDIS was coming in, I was very concerned about what was going to go on, and I think it lived out all the bad things that actually happened to some really good things. Don't get me wrong, because that area is totally underfunded. But I would support a model that works, and I would look at ways that we can potentially facilitate that model again as part of this whole deal.
I think if I could just add, I think the future will probably be perhaps a more tiered approach where we're particularly involving GPs in the process. I'm involved with looking at this long wait list around autism assessment through the Minister of Autism here in South Australia, and separate to that, the reform group that's looking at changing ADHD care in South Australia, and essentially both are still, I think, requiring a core role for paediatricians to look at the child overall and to help direct care. But certainly I think having people working at the top of their sphere of practice, and that will probably moving forward, be including GPs a lot more. And I think some of these changes to Medicare item numbers, case conference numbers and so forth will be important as part of that. But I think that will be the ongoing model. And I do think, I don't know many of my rural paediatric colleagues who want to be the guardians of access to services, particularly in where they accept there's long wait lists. But to the idea that you might exclude paediatricians from the process, I think is hard to justify. Is that being of benefit to the patients?
I think I'd just like to also echo that stepped care approach here. I know sometimes a packaged up thing called Thriving Kids that you could well define sounds attractive but is hard to deliver in real life. Yep. All children should have regular developmental screening, and that should occur both probably through their early childhood centre and their GP. So that we identify issues. Some of those kids will have relatively simple concerns and need short-term intervention. Some of them will be a bit more complex or harder to figure out, and that's where we need paediatricians and allied health and a team for that diagnostic clarity. And I see those two groups as being where you could label something Thriving Kids and create sort of a suite of services. And then we've got to remember there's always going to be those complex kids who really need specialist intervention and a whole team and the NDIS right from the beginning. And so I think trying to step through those and make sure that we're not leaving people out of them and who is around through all of that, no matter how well or sick you are, is your medical team, and we can help find the right level of supports. And then geographically, I guess to that question of the general, the local paediatrician, allowing that flexibility for the workforce that you've got, especially regionally, where you might have a really well-equipped paediatrician who runs the show. In other places, you'll have a GP or a rural generalist or others who are a bit more of the coordinator.
Good. Alice.
Great.
Alice.
Thanks, Chair.
Sophie's got a hand. Do you want me to?
Yeah.
Thank you, Chair. Thank you all for appearing today. I've just got two questions sort of picking up some of the commentary from Dr. Ryan and Dr. McMillan as well. My first question is around admin burden. There's no doubt you're all at capacity and you've got long, wait times for assessments and that kind of thing. How do you think we streamline this support to improve, earlier referrals? There's a cost aspect, obviously, in that, we can look at minimising gap payments for specialists, that kind of thing. But in terms of your time, is there a way we can take some of this admin burden off of you, both paediatricians and GPs, looking at the allied health pool, potentially taking histories, that sort of initial assessment? Would you have a view on that?
I guess from the GP perspective, it's what we do all the time for everyone. So there are various tools that assist. We already have often practice nurses in our general practices who may have an interest in child and family health and often do a fair bit of the initial history taking. We have things called health assessment items, and those are already within the MBS, and they're pretty well equipped to allow that team-based care in general practice. So we would be supportive of expanded use of the health assessment items in the paediatric target populations. It's again, the digital health tools. There is work being done to try and streamline how we could have a shared chronic condition summary. It's not for use yet, but just to give you an idea of where the connected care agenda is going, is so that I could input some information, the paediatrician could, the allied health could, and the patient could see it. And I think that will be helpful. AI is helping a bit in our clinical note-taking already, but it really is a bit of that time. And then e-health referrals. So here in Queensland, we do have online referrals into our public hospital sector, which has been helpful compared to other jurisdictions where I've worked. It does make it quicker and easier to be able to track whether a referral has been received. Honestly, though, most of it is the time it takes to really do the thinking and the clear assessment and building that rapport with families and providing that therapeutic intervention that requires those few extra minutes in each consultation that we need to better support. The paediatricians may have a different view.
Thank you. Would anyone else care to comment?
There's some information that comes. I think the traditional model still works well. Hearing that person's unique story and getting it directly from the patient's perspective is still very valuable. The background information is very important, and the electronic referral system often has some guidance about what we'd like to know in advance. But having said that, I think the old-fashioned FRACP long case model is still a good way to initiate a fresh assessment on the patients that we're seeing. The detailed GP referrals help enormously, and that's usually at an extremely high standard.
Thank you. I've just got a second question as well. We've heard from a number of people appearing before our committee about the importance of the first 1,000 days, and I know our chair is a strong believer, as is a number of us on this committee as well, and those early checks and screenings during the very early years of childhood. Is it your view that these checks should be commenced even earlier than they already are, in that should we look at an 18-month sort of early check? We've heard that from a number of sort of our maternal health and child health nurse associations as well. Is it your view that we should be doing this check even earlier? And yeah, any commentary on that?
Certainly from a GP perspective, our training is that every interaction with a child is an opportunity for a developmental screen, and particularly each of those immunisation visits provides an opportunity. When we're thinking about social and emotional development and autism in particular, that can be hard to identify in that first year of life, and then we do have a bit of a gap in our routine assessments between 18 months and 4 years. We would be supportive of targeted intervention. So we lament the loss of the 4-year-old health check for that reason. It was a strong reminder to provide a detailed assessment. And while, yes, so our clinical training is that we should do it at every immunisation visit and every visit, certainly the AMA would be supportive of more targeted supports, those health assessments at least the 4 years, ideally 18 months or other time interventions, to really highlight the importance of being able to take that detailed history, and a health assessment item would be appropriate.
Yeah, I think as paediatricians we'd agree. In New South Wales Health, we talk about the first...
Oh, you've gone back on mute.
Sorry, we talk about the first 2,000 days, the pregnancy in the first 5 years. And I suppose, as Danielle has said, the sort of most useful interventions are 18 months for the more severe developmental delays and 3 years for the you should be talking in 2-word sentences by now, and 4 years is a fraction later, I think. 3 years is a good time, 18 months. But I think Danielle's point that close contact with your GP really helps, but unfortunately it only helps those people that have that contact, and we don't always have the same continuity of care. But we would think 18 months and 3 years are the two interventions. Monique Ryan, as a paediatric neurologist, perhaps would have her own point of view about that. But the 2 points that we would say offer the best early recognition.
Thank you. Thanks, Chair.
Ellie France, do you have any...
Do you have a point of view, Monique, about the 18 months, 3 years?
That's I think I'm with there, David. I think that's, you're going to pick people up there, and we've heard repeatedly about kids showing up to school, with significant unpicked up delay. I think if we aimed for 3, we'd be picking everyone up before they get to school, at the worst case scenario. So, I think that's about right.
Ali France, any questions?
No questions from me, Chair, but thank you all for giving your evidence. It's been great. Thank you.
Yeah, thanks. I've just got a couple of questions. And Danielle, it's around the role of the GP, and we have spoken about trying to pick kids up early and get them into early intervention ASAP, and there will be some soft referrals, but at the moment it must be very frustrating for GPs to see a child with a developmental problem, not being able to get them into services. Is there a role for an expanded child and family nurse program, or at the moment it seems to have sort of withered on the vine. We used to have the 4-year health checks where people would take their child to a child and family nurse, and they get hearing tests, they get vision tests. They'd have perhaps a child health doctor, not necessarily a paediatrician, but within the baby health clinic itself. We seem to have lost all that. And I think it puts a lot of kids at risk. How do the GPs feel about that?
In terms of the public sector and those child and family health clinics, the provision is really variable around the country. We see a different scenario in different jurisdictions and also within different jurisdictions. Certainly in private practice, it is deeply frustrating. It's awful seeing kids where particularly if their speech and language is behind, or they've got behavioural, emotional regulation concerns, and I know that they need either a speech therapist or an OT and or a paediatrician, and parents, if they can't afford it, that's a real barrier. But even when they can, the wait lists in my area for speech therapy are often much longer than 6 months, sometimes a year. And that's a year that a kid can't communicate effectively, and we compound their problems. It is heartbreaking and frustrating to be in that scenario and trying to support families through that. And that's why we think that the early identification is the health assessments. Then could we have better awareness of things like chronic care plans, even force isolated deficits, and in that short-term intervention and supporting that team-based care with some more allied health visits and an expanded set in the private sector to make sure that kids could access some more care. And with that recognition, as I said, what are the clinical outcomes we're trying to achieve so that they're not sucked into a lifelong system where they can't exit care either. I liken it a little bit to the better access schemes we saw with mental health, and when during COVID we expanded the number of sessions of psychology, but more patients didn't get in, the same set of patients got more services. And I wonder if that's part of what we're seeing with NDIS, is that it's really hard for new entrants to access service because we've got a pool of people getting maybe more care than our system can afford to give at the moment. And so that's where I see hopefully this sort of streamlining of getting the right care to the right patient at the right time is sometimes this shorter term but quicker access intervention. It'll take a bit of private services through Medicare referrals, a strengthening of the jurisdictional hubs for people who can't afford to pay or for other reasons where we've got, a state or federally, but a hub of allied health and paediatric services for the really low or no cost intervention, and then obviously really specialised clinics for the complex kids.
Good, thanks. I just actually noticed, Sophie Scomps, you've got your hand up. Do you have another question?
I did, but you haven't. My question was around, I think it was Professor McDonald mentioned that there was really good models with the type 1 diabetes and allergy clinics in regions. Just wondered how you sort of envisaged that happening for these kids and thriving kids.
I think the emphasis of that was having a regional-based approach. Part of it has been the Australian Paediatric Society's actively promoted local care for both those conditions. Type 1 diabetes has increased enormously in prevalence, so our clinic has 80 kids with type 1 diabetes in it, as opposed to 20 about 10 or 15 years ago. I think it's about empowering the local paediatric population, but starting with a local response, encouraging local resources, but it does benefit from a kind of collaborative approach with central services to provide some ongoing sources of education. Both allergy and diabetes have their own regional paediatric conferences held annually where doctors are upskilled. So it's a combination of upskilling but also having a regional focus.
Thank you.
Good.
Can I add there that the National Allergy Council has involved the Australian Paediatric Society, and that's been absolutely wonderful. And in working with a broad group of GPs and allied health people to create models that are sustainable in regional areas, and I think that's where David was coming from with that. We're open for collaboration. It's worked in the past. Let's have a look at that again.
Good. Well, any other questions? No other questions? Well, thank you all for attending here today. If you've been asked to provide any additional information, would you please forward it to the Secretariat by the 24th of November 2025. You'll be sent a copy of the transcript of your evidence and will have an opportunity to request corrections to any transcription errors. And once again, thank you all for coming.
I wonder if I might just add one further point just quickly.
Sure.
I just suppose that one of the areas we often see in paediatrics where we could improve the efficacy of therapy and services to rural areas is around the capacity for therapy to occur in the home setting or in clinical settings as opposed to in school settings. And I think over time, we're seeing a lot of kids getting therapeutic services ongoing in school settings, which excludes the parents. And I think you get a lot more bang for your buck if therapeutic services are including parents, particularly for the conditions that therapists are often working with and the sort of symptoms and problems that they're seeing. So I think any reform should be very mindful that I think the system has slipped into this model, particularly because we fly in, fly out services. It's a lot easier and convenient to do therapy in school settings, but I don't think it's the most efficacious. So I think moving forward, funding models that might allow for clinical spaces outside of schools or in the home really should be part of it.
Yeah, we've actually heard from a number of the schools about how disruptive it is to have to provide space and take kids out of class for therapy, etc. So I think you're probably very right there that we need to look at other ways of doing it. Good.
Thank you.
You'll be sent a transcript of your evidence. We'll have an opportunity to request any corrections to any transcription errors. If there are any questions you think we haven't asked that we should have, please let us know. And it's been a very, very useful session. So thank you all for attending today and giving us your very valuable time. Good to see you again, David, and keep up the good work. All of you.
Thank you very much for having us.
Thank you.
Bye.
Thank you.
Keep it up. It's really amazing.
Thanks. I now declare this public hearing closed, and thank you for all my colleagues for attending, and thank you to the Secretariat for organising it so well and keeping me out of trouble. and thank you to broadcasting and to everyone else involved.
Thank you, everyone.
Thanks, Chair. Thank